Well, good morning, everybody, and welcome to the first hearing of the Committee's inquiry into fertility support and assisted reproductive treatment. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today, and I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name is Sarah Mitchell and I'm the chair of the committee. I ask everybody in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants, and I encourage committee members and witnesses to be mindful of these procedures. So we're going to start, obviously, with our first witness, Mrs. Bruce from New South Wales Health. Thank you for being here today. Would you mind starting with stating your name, your position title, and swearing either the oath or the affirmation, please?
Thank you. My name is Tish Bruce. I'm the Executive Director of Social Policy and Health Equity at the New South Wales Ministry of Health, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Would you like to make a short opening statement?
No, thank you. Happy to go to questions.
Okay, great. So just for your information, the committee has resolved to equally split the time available for questions. So we're going to start actually with questions from the opposition, which would be myself or Ms Carter. I don't know if Ms Carter wants to kick off.
I'm happy if you do.
Okay, great. Well, thank you. Thank you. I feel like I'm doing all the talking, but anyway. Thank you for being here this morning. I just wanted to start with the Affordable IVF Initiative, which is obviously spoken about in New South Wales Health submission. Do you have any data on how many families have accessed that since it came to fruition?
Yes, thank you. So we have data on the number of women who have accessed the the publicly supported lower cost IVF services, and that's just around 8,000 women since it commenced in 2020. We also have information on the number of women who have accessed the IVF rebate, the pre-fertility rebate, and so since commencement that's just over 11,000, I think 11,800 women have accessed that. The fertility rebate one, which is the $2,000 rebate for women who have accessed a private provider, there was 17,600, I think, applicants for that. And since the implementation of the fertility rebate 2, which introduces the income threshold to target it towards lower and middle income families, there have been 605 up till about the end of April.
Okay. Do you have, and I'm happy for you to take it on notice, but just a breakdown of those numbers per sort of calendar year or however Health has that data? I'm just interested to see the trends, I guess, in terms of access and applications. So
very happy to take that on notice.
Yeah, that would be great. Thank you. And then just picking up, since the introduction of the means testing, I think you said 605. Over what time period is that?
From recollections, that's March 2025 to April 2026.
Okay. So would it be fair to say, and obviously I appreciate you have to, be led by the government of the day, but has there been, obviously putting in that means testing has made it a little more challenging or less people eligible to apply. So have you seen the numbers then go down once the means testing was brought in?
Yeah, the numbers have gone down.
Okay, thank you. And then I wanted to ask about, I guess, more sort of public provision, particularly in relation to IVF services. And I note in the submission you talk about, I think there's 3 hospitals or 3 health districts that offer some form of IVF support effectively. Could you just talk through a little bit, if you're across, and as much as you can, I guess the history of those 3 particular services and also why there isn't anything more broadly for regional communities as well in terms of those offerings?
Yep. So the 3 services that we have, the lower cost publicly affordable, publicly supported IVF services, is the service at Royal Hospital for Women, the one at Sydney Hospital, RPA, and the one at Westmead Hospital. Those three had established partnerships with private providers in each of those areas and were already ART registered providers, which meant that when we were looking to establish that program, we were able to act quite quickly. They're complex and costly services to stand up, so we were able to initiate that program much more quickly with going where we had those partnerships in place already. We were aware that the issues around regional and remote access. I think a couple of things in there. One is the programs are accessible for anybody wherever they live within New South Wales. The providers have worked to look at how they can extend the reach and availability of those services across New South Wales. So each of them have different ways of implementing that. Some run some regional clinics or look at areas where they could enable testing or other activities to occur more locally to where the person is, and then come to Sydney for the surgical treatments. We also have the IPTAS program in place, which is the Isolated Patients Travel and Accommodation Assistance Scheme, so where we can support the travel costs for people who do need to come to Sydney for those types of services. And I think we're continuing to look at how we can extend that reach for regional and rural areas. So it's a live question for us about how we can continue to improve that.
And do you collect any data, obviously being conscious of people's privacy, but how many individuals or families are accessing those services who come from rural and regional communities? Is there a way to sort of understand the demand outside of the metropolitan areas?
We do have, I understand we've got available data, and we could
if you could provide that on
notice.
Yeah, and obviously in a de-identified way. I'm happy for that. But just interested to understand sort of where, how many people are coming, and again what some of the barriers to that access might be. Susan, do you? I might just pass over to your colleague now. Yeah, thank you.
Thank you for being here. Some questions about the IVF rebates and financial assistance that's offered. So what's in the IVF basket? I guess I'm thinking specifically about some of the submissions we've received about NAPRO technology and whether there's financial assistance that would support women looking to conceive through NAPRO technology. And
I have to admit, you've got me on, I don't actually understand what NAPRO technology is.
Right.
So could you explain that?
As I understand it, and I'm not an expert in this field, it's basically a number of women are choosing to access it because it relies on more natural processes rather than hormones, and women are achieving great success through that process. And so I'm wondering whether that's also included in the support that is available to assist women to conceive.
So I think the main focus for the publicly supported lower cost services is around IVF and frozen embryo transfers. They're the main two areas that we're involved in. I think we are again looking at what's the breadth and range of services, because the space has evolved considerably over time. Clearly that hasn't come up as a discussion point that I'm aware of, but that doesn't mean that as we look at the types of the work that we can support, I think what we are very focused on is actually supporting the clinicians and the clinical teams to understand the needs and interests of the women and the families that are coming in, their medical history, their health, and how they want to approach their fertility journey. And that then becomes a discussion between the fertility provider and the woman themselves. But there are currently in scope and out of scope procedures. Yep.
So what work then is being done to educate fertility providers or to look at what is in scope in terms of providing the best range of services for women, especially looking at their whole health in terms of interventions and hormones and things over the life of the woman?
So I think it starts, the journey starts often with general practitioners and primary care providers. And they're incredibly well placed to look at the whole of the woman, their broader health needs. to be able to look at things.
But if I can stop you there, with respect, if one path can be funded and another path requires self-funding, doesn't that make a lot of fertility choices for women right there with the way health is structuring what fertility paths are supported and what fertility paths are not supported?
I think I'm just trying to think how best to answer your question. Certainly, we have determined criteria for the services that are supported, and that was, I think, in light of both what was understood in the place at the space at the time, but also the partners that we were working with and the delivery that they were doing, but also considering where some of the greatest costs and where we have the evidence around the interventional services that are there. We're guided by a lot of the materials from ANSCOG and other sorts of places that inform the types of provision of fertility services, and it's not unusual that some types of services are supported and others aren't, because
and how often is that reviewed, which services are supported and which are not?
So we haven't reviewed that since the commencement of the program, but it is something that we are looking at now, and we'll probably look at somewhere in the next 1 to 2 years as we look at the extension of the current agreements that we have.
And is that an internal process, or is that a process where other people can make submissions?
At this point in time, I don't have the information about how we would go about that. So, yeah.
And just one last question from me. In terms of assisted reproductive technology, there is significant evidence that there can be psychological impacts on children, and they emerge particularly late adolescence, early adulthood. Which part of New South Wales Health manages supports for ART and donor-conceived children and their psychological health?
I would think that actually comes across a range. I don't think we have a specific service that is targeted to doing that. However, we have a whole range of services around adolescent and young people's mental health services. We have social work services across our community. We also have our community health centres, etc. So all of them engage with young people, and there's also a broad range of not-for-profits and other publicly supported things like Headspace and other types of programs that would variously support young people and young adults as they progress through these sorts of things. We have the donor register with New South Wales Health now, and we're aware that within the next 2 years, the first people registered in that, because that commenced in 2010, will be reaching the age that they may seek access about their donor providers, and we're actively thinking about what needs to be in place as that ticks over to those people being able to access it.
And you're confident that there will be sufficient psychological supports and that these services will be well enough educated and resourced to be able to provide appropriate support for these young people?
So today I can say I'm confident that we're absolutely aware that that's coming up and that we're looking into how we are best placed to be ready to meet the needs of those people accessing the services.
On notice, could you provide the committee with details of what preparations are being made to psychologically support donor conceived as they seek to access that information?
Happy to.
That'd be great. Thank you.
I'll just have a minute left. Just in relation to surrogacy and families particularly going through altruistic surrogacy, is there sort of set New South Wales health policies with each hospital with how families are supported through that process, or is it LHD specific?
Through the process of surrogacy itself, or with the maternity processes?
With the maternity provisions and processes was what I'm...
Sorry, thank you, just clarifying.
No,
I think our broad maternity policies would be enacted in place, like how we support people, the surrogate themselves through their antenatal and maternity care, also how they go through birthing experience. At a local level at the moment, we're looking at how we support, or a number of districts are looking at through the birth experience, where the biological parents' involvement as well as the surrogates' involvement. Oh, obviously the surrogate's very involved. And how that works. I think we are interested in thinking and we'll take information out of some of these sorts of things about inquiries about where we may need to go in the future to support both the surrogate and the birthing parents, the biological parents.
Thank you. I'll hand over to Dr. Con.
Thank you. Good morning.
Good morning.
I had a couple of questions to start off with about the Affordable IVF initiative. Yep. So it's my understanding that was originally funded from 22-23 through to 25-26.
Yes.
What's going to happen to those services after the 30th of June this year?
So they have been extended. The funding's been extended through, I think, all of them till 29-30. There may be one element that's before that, and I'll get that corrected if they're not all extended till 29-30. Yeah.
Thank you. The Affordable IVF initiative, so my understanding is there's the 3 publicly supported clinics, and there's also a rebate that people can access through Service New South Wales. Yeah. That strikes me as a very unusual funding model for health services. Mm-hmm. Are there any other examples across New South Wales Health where people's access to affordable healthcare is through a rebate at Service New South Wales?
Not that I'm aware of. I think this was put in place because the majority of care was actually provided within the private system and would continue to be provided into the private system. So it was a mechanism to support families who are using the major stream of care.
Look, we've received a number of submissions recommending expansion of the public services because, as you've said, the majority of services are in the private sector. I'm interested in understanding potential practical or logistical barriers that might need to be overcome if there were a view to expand public provision. So, for example, in terms of the capability of the workforce or those sorts of considerations, what advice would you have?
I think there are quite a lot of considerations to the expansion of the program, but I think we'd be open to those considerations. There is, as we said, it's a very technical, high-cost industry to be in. Needs a lot of specialist equipment and specialist clinicians. I can't speak on what is the availability of that clinical workforce, but knowing that we would need to have that in place. I think where we have now, we've partnered with other providers who already had established fertility services, so we haven't independently looked to set up a public program in ourselves. I think that creates a more feasible pathway, but again, without exploration, that's an opinion rather than a position around that. I think, and that particularly comes into if we're looking into regional and rural areas around what is the facilities and availability of those supports. But it is something that could be explored about could we partner with other people and look at other ways, because it doesn't have to be partnership.
I'm also interested in understanding the opportunities for rural and regional areas. I understand that the existing 3 services, which are all in Sydney, do allow some parts of treatment to take place in the place where someone lives, and certain aspects require travel. It's sort of shocking to me that even a hospital the size of John Hunter Hospital or Wollongong Hospital wouldn't have the technical expertise that's needed. Could you talk us through, I suppose, what is actually needed at those 3 services that's not able to be provided at smaller hospitals?
I think it's a level of detail that I don't have. So again, either I can take it on notice or see if there's something else that can be provided for you.
You'd be very welcome to take it on notice.
Thank you.
Thank you. I also wanted to ask about some of the issues that have taken place in the private sector. There have been a number of high-profile cases of problems that have occurred with private providers. I understand there was a ministers' meeting in September last year that recommended state and territory regulation in terms of protecting consumers and ensuring ethical and transparent delivery of assisted reproductive technologies. What involvement has New South Wales Health had in researching or drafting or supporting a higher level of regulation?
Again, I'm not across the specifics of our involvement, but I know as part of the work with the Health Ministers' meetings and the review that was done by Victoria that informed that rapid review that was done into the accreditation and regulation of ART and IVF. So we, along with all the states and territories, support the work that was the commissioning of that review. And aware that the health ministers, as you say, have supported a range of activities out of that. One of them is to actually refer the accreditation and regulation to the Australian Law Reform Commission to commence work in that space. And as New South Wales, we are looking at opportunities to support the timeliness of the uptake of that and the speed of the response from that. I think I might have missed part of the beginning of your question. Was there something else
okay.
I needed to cover?
You've mostly
Sorry.
answered it, so I'm interested in that work that's happened, that's already ongoing in terms of improved regulation, and you've mentioned the Australian Law Review Commission process, which of course the committee is very interested in. I suppose my follow-up question is, do you have a sense of the timeline of that work that's already underway?
So I'm not aware of the timeline of the Commonwealth work, but we certainly as New South Wales are seeking to look at how we can support that to happen in a timely way. I think some of the other things that have came out of that was the recommendation that the Australian Quality Commission,
Commission on Safety and Quality.
Thank you, thank you. You can get
It's a
my words
mouthful
for
of an
me.
acronym, that one.
That the accreditation is actually is moved into their space as opposed to a voluntary. Not the accreditation, but the compliance work actually happens through them. And so that work is also underway. And again, I'll correct myself if I'm wrong, but I think that's happening within the next year. But again, the team can correct me if I'm wrong in the timing of that.
Okay, thank you. Last question from me, and then I'm happy to hand back to the chair. For those three public services, what guidelines or policies are in place to ensure cultural safety for LGBTQIA+ people?
So we don't have specific ones around the provision of IVF. I think the whole of the broader policies that we have in place. So we have the LGBTIQ+ strategy that informs our directions. We have all of our normal ministry and public health policies around fair and equitable delivery of services. We've got the Gender Equity Action Plan that drives that we actually provide care equitably, and that's rolling out now, so looking at how we can actually strengthen and ensure that occurs. So I think it's the broad base of our policy place that then is then delivered through IVF as opposed to being specific to IVF.
Thank you.
Thanks. I'll just ask a couple and then we'll hand over to the opposition. The government, sorry. Just going back to my questions before, just around the processes for families who are using surrogacy, and I guess I am particularly interested in, the maternity services, so just for clarity, there's not a specific sort of statewide policy around, that birthing process, who's at the hospital, where, if the all parents want to stay there, like, is there a framework that operates off, or is it basically up to each hospital to work with the families involved to find a way to manage that appropriately?
So we've actually got quite a breadth. Again, not specific to surrogacy.
Okay.
So we've got a breadth of policies and guidelines and strategies in place around maternity services. We have the Connecting, Listening and Responding, an action plan for maternity, blueprint for action for maternity services that got published last year. And then we've got a large suite of policies and guidelines that sit behind that in terms of the delivery of quality and standards of maternity care, the timing of types of maternity care. It does include things around involvement and support for family participation in both the antenatal period and the birthing episode, and beyond that into the postnatal period. So we could provide you with a list of the breadth of documentation
that would be
supports
good.
that.
Yeah. Because I guess, as I said, I'm just sort of trying to understand. I mean, obviously, I know it's not a particularly sort of common occurrence, and in different hospitals it probably happens more than in others. But I'm just keen to sort of understand, are staff supported to really appreciate, the experience of families when they are going through a surrogacy arrangement and what that looks like, and if there is some sort of broader guideline. But if you can provide what you've got, that would be great. And then I just want to ask one quick one, and then we'll hand back over to the government. The submission talks about, in relation to pregnancy loss specifically, that there is going to be, the ministry is finalising the pregnancy and perinatal loss guideline, which again is for clinicians and staff. Can you just speak to that a little bit more, and when you think that will be made available?
So pleasingly, that was delivered last year, October 25.
Okay. Even better. There you go.
Yes. And I think, there was broad consultation around the development of that, as well as taking into account the things we heard through the birth trauma inquiry and through the blueprint development. We've now working with our local health districts about the implementation of that guideline. We've developed some education materials and resources that the districts can use locally to assist in the understanding of that guideline, the communication across both maternity settings, but also settings like emergency departments and other places people may present who are experiencing loss. And it includes things around bereavement supports. It includes reference to our tiered perinatal network, so that where a person, the care requires specialist or additional services that are not available locally, that can get escalated through our tiered networks across the state, looking at ensuring people get the right services as close to home as possible, but where we can't deliver that close to home, it's actually making sure they get to the right services.
Okay, thank you. Hand over to government members now.
Thanks, Chair. Thank you for appearing today and for your submission. I just wanted to seek an update from you, given that it's been some time, obviously, since the submission was made. In part 1.3 of the submission, it talks about the expanded definition of infertility and New South Wales Health supporting the extended definition. Is there an update on how it can be implemented in the Affordable IVF Initiative that you can provide?
Thank you for that. So what we've done is updated our guidance material and the information available to people as they look through there, and also to our providers, to recognise that expanded definition.
So it is being...
Yes.
Great.
Yep.
That's good. Very reassuring to hear.
Yep.
Excellent. It's a very simple answer to my first question. In terms of the services as well, there was the pre-IVF fertility testing rebate. So the submission talks about analysis of the out-of-pocket testing costs and the rebate being revised.
Yeah.
Has there been any work done to look at that again, just in terms of whether it's keeping up with out-of-pocket testing costs?
No, we haven't looked at that again since that original review of that adjustment to the rebate.
Is that something that's being planned, or?
At this stage, it hasn't been planned. I think because what we did was use the money that was available by adjusting that rebate to put into other elements of the Affordable IVF Initiative.
Sure.
So we've embedded into other areas of care. So that specifically hasn't come up.
Sure, thank you. The fertility treatment rebate,
Yep.
the $2,000 rebate to help reduce out-of-pocket costs associated with ART in private clinics. Has Health got any data around what the gap still is? Because I think it's fair to say broadly that the $2,000 will not cover the expenses incurred in total. I'm interested in how much of a gap there still is, but also whether Health have got any data to suggest that, as is sort of stated in other submissions, that rebate has just been absorbed into the costs and the pricing model of private clinics?
Yeah. We don't hold information about the out-of-pocket costs to consumers across New South Wales. So I don't have information on that, sorry.
So really there's probably no way of knowing or at least measuring how effective that rebate has been?
No, we know the uptake of it, so we know,
Okay.
as we said before, the numbers of women and families who took up that rebate, but the impact on their fertility choices and the overall out-of-pocket costs, that's not information that we hold or are able to hold.
Okay. That's interesting. And of course, clinics don't necessarily or don't in most circumstances publish the costs involved with treatments.
No, that's a decision for the providers themselves and between them and the consumer. So it's not publicly available and not held by New South Wales Health.
Yeah, okay, thank you. The RANZCOG submission that we received for the inquiry talks about, and obviously they are appearing later today, talks about their preference for, or at least acknowledgement that rebates alone is unlikely to address the underlying equity issues in ART access, and instead, along with, I think, just to acknowledge the comments of the Deputy Chair, that the emphasis should be put, or at least the funding should be directed towards expanding the existing low-cost services that the New South Wales Government does fund. Has there been any work done to look at reviewing how that could take place?
I think we've done preliminary thinking, but nothing that's yet particularly evolved in that space. I think more in the space of what would be some of the things that we would need to consider, what would be some of the challenges and issues to do that if a budget was available to do it. But we haven't actually gone through the specifics at this.
Is there any data that Health have on the, I suppose, waiting time to access or like how full these lower cost IVF clinics are? What I'm trying to get at is there a need? Is there a clinical need for them to be expanded?
So we fund 1,400 what's called unique women because the number of cycles could be different from that. I think there have been times where there is the clinics have had to manage the demand for those services because it is a capped funding pool that we're providing to them. The clinics, I don't hold that, and I can ask whether we hold any information from the clinics about wait lists. But I am aware that what they do is they work with the consumers that are coming to them about the best type of service, the best way to go through. And I think recognising that a lot of women actually want choice in their provider as well. And so, we're very proud of the three services, but there's a lot of other providers that women and families will choose for different sorts of reasons. And so, so we are one of the providers.
Yeah, and noting obviously Westmead Fertility Centre are appearing next, so this may be a better question for them, but does Health keep any or look at any sort of data on patient feedback, the patient feedback surveys that we do through the health system, just in terms of the quality of the service or the experience that people have with the service?
I have to say I don't hold the detail of whether we're collecting that information at the moment. It may be collected within the ministry, but I'm not particularly familiar with that.
Okay, thank you. Just change gears somewhat to the fertility preservation services that New South Wales Health provides, which is obviously also done through these wonderful clinics. I was interested in understanding more about why the funding provided covers storage for up to 5 years only, just in sort of recognition that there may be instances, albeit outliers or unique, whereby patients are faced with, some of these serious life-threatening medical conditions that may be quite younger, and 5 years may not be a long enough period of time.
It's a good question. I think there's a couple of things in there. One is around that it is focused around urgent and life-threatening, women who are experiencing urgent and life-threatening, or women and men, life-threatening conditions that may affect their fertility.
Yep.
And so potentially the time frame of the outcome of that can occur within the 5 years.
Yep.
I think we worked with the providers about what was feasible and manageable for them to deliver. And I also know that I'm not quite sure the integration between this and the Commonwealth, but the Commonwealth also has a program that extends support to 10 years for some, freezing of material. So I'm not sure whether we can transfer between those, but there is an extended option that's also publicly available for particular types of
That's good
support.
to know. Yep. Thank you. I might just pass to my colleague now
Thank you.
for a question.
Thanks very much for coming along today.
Pleasure.
I've just got a document to share. I've already foreshadowed it to the chair and the committee. It's the Health Commissioners, or rather the Health Ministers meeting communique from September last year, which has been referred to already in one of the lines of questioning. So that's the communique document. But specifically, just want to draw your attention to the heading on the second page, which relates to the earlier line of questioning. That first sentence, which is not highlighted, Health Ministers agreed to that all Australians should have confidence in the ART services they access. Health Ministers commissioned a rapid review of ART in June. So this is June last year. Obviously New South Wales Health would have a copy of that.
Yes.
So on notice, could you provide to the committee a copy of that?
I can take on notice the request. I'm not clear on the privilege or the position, so I can take on notice the request and we'll reply as best we can.
Pleased to that. Thank you for that. We go to the next paragraph, which is a reasonably long one. Can I just specifically draw your attention towards the bottom of that, where it says work will commence immediately and the new accreditation requirement will be in place by January 2027. And that relates to what's above, where it says Ministers agreed that the Australian Commission on Safety and Quality in Healthcare should provide independent accreditation for ART services against updated national standards. So that's the timetable that's being worked towards?
My understanding is that, yes.
Yeah, well, that's what the communique says.
Yes.
But I'm saying from a New South Wales Health point of view, they're committed to working to this timetable.
That is my understanding, yes.
That's fine. No, thank you for that. On the matter of data collection, and thank you in your submission, you deal with it helpfully. And I'm looking now in your submission, and I'm talking about basically page, it's page 15, 16 and 17. Can you explain that with respect to the data collection that New South Wales Health collects, specifically page 17, I guess, is the
I haven't got page numbers. Could you give me a dot point?
You've got page 17. It's bottom right-hand corner is the enumeration, pagination.
No, interestingly, mine are unpaged, but I've got item numbers like 2.3, 2.4.
3.2. It's above 3.2.
Thank you.
Yep. And apologies, I haven't had a chance to go to the website that's referred to and interrogate the website in terms of information that's available. But with respect to information in terms of numbers going through IVF with New South Wales Health and related matter, is that all published in the public domain? I'm not talking about, obviously, specific examples and names and what have you, but the aggregate information that's being collected, is that actually basically managed and publicly available?
I'm just trying. So in the broad IVF ART space, my understanding.
Talking about New South Wales Health.
Our data are ones that are going through the publicly supported
Correct,
lower
yeah.
cost ones. Yes, we certainly hold the data on that, and I'm just trying to think whether we have published that.
We can take that on notice.
Yes.
That's okay.
Yeah.
But with respect to ART, and specifically IVF, it is the case that if you look at the aggregate numbers in New South Wales of women passing through the IVF experience and journey, the New South Wales Health numbers are much smaller than the for-profit businesses.
Yes.
That's correct. Do you have roughly a percentage that you understand is the ratio between the for-profits and that's what's effectively public provided?
So we don't gather or hold the information about the total volume of IVF and ART. I think there's a group called I think it's the RANSTAR, the Australian and New Zealand data collection that do. Again, my understanding is the most recently available data was from 2023,
Right.
of which there was collectively about 103,000 episodes there.
Yes.
We have information at a large breakdown of just over, I think 29% were in New South Wales of that, so 30-odd thousand were that, and then we support 1,400 women, which is, but again, there are more cycles than women.
I think that's probably my time.
Okay, that's it. Yep, thank you. Thanks. Well, thank you, Ms Bruce, for giving evidence today. You have taken a number of questions on notice, so the Secretariat will be in touch with you just to arrange the returning of those answers. But thank you for appearing today.
Thank you so much. Hope it goes well.
Next witnesses appearing from the Westmead Fertility Centre. Thank you to both of you for making time to give evidence today. Could I just ask, starting with you, Dr Gillen, just to for each of you to state your name, your position title, and swear either an oath or an affirmation, please.
Thank you. Dr Lindsay Gillen, Westmead Fertility Centre, where I am CEO, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Dr Kylie de Boer, the Chair of Westmead Fertility Centre's Board of Directors. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to begin by making a short opening statement?
We would like to take that, please.
Please.
Thank you. So, Chair and members of the committee, thank you for the opportunity to appear today. As mentioned, I'm Dr Lindsay Gillen, Chief Executive Officer of Westmead Fertility Centre, and I'm joined today by Dr Kylie de Boer, Chair of Westmead Fertility Centre's Board of Directors. Westmead Fertility Centre is a private fertility service that has been wholly owned by the University of Sydney since 2014. The University of Sydney was founded in 1850 on the land of the Gadigal people, with the founding vision of creating a university based on merit and equity, not privilege, for the benefit of all. That commitment to equity continues today and directly informs our ethos as a fertility clinic, particularly our focus on equitable access to care. Westmead Fertility Centre is embedded within the Westmead Hospital Precinct, a key tertiary health campus within the Western Sydney Local Health District. This setting provides a strong research, public health and tertiary care environment in which we operate, serving one of Australia's most culturally diverse and socio-economically varied communities. I provide this background as context only. Today, Dr. DeBoer and I appear solely in our capacities as Chair and CEO of Westmead Fertility Centre, representing our organisation, our patients and our experience delivering high-quality, equitable fertility care. Within this framework, Westmead Fertility Centre operates as a profit-for-purpose organisation, meaning any operating surplus is reinvested into patient care, laboratory excellence, workforce capability and for fertility research, rather than distributed externally. For more than 40 years on Durack land, our purpose has been to deliver high-quality, research-led fertility care that is affordable, accessible and grounded in compassion and equity. Our submission is anchored in one central principle. Access to fertility care should be based on clinical need, not postcode, not income, not relationship status, and not on a person's capacity to absorb financial risk. Through our working relationship with Western Sydney Local Health District, Westmead Fertility Centre delivers the New South Wales Affordable IVF Initiative. While we strongly support existing government initiatives, we have outlined several forward-looking recommendations in our written submission. These have also been shared with our Western Sydney Local Health District colleagues and formally escalated to the Affordable IVF Initiative team for consideration as part of the future program. We would welcome the opportunity to expand on these matters in response to questions today. In closing, our message is simple. The New South Wales Government's Affordable IVF Initiative works, particularly when delivered through a model like ours at Westmead Fertility Centre, with our ownership structure and collaborative approach. The initiative improves access, reduces inequality and delivers meaningful outcomes for people who would otherwise be left behind. With thoughtful expansion and sustained funding, New South Wales has an opportunity to remain a national leader in equitable fertility care. Thank you for your attention and we welcome your questions.
Thank you for that. So you might have heard before, but the committee's resolved to equally split the time between opposition, crossbench and government members. So I will start for the opposition. Thank you for the work that you do. And I'm interested to know, it's probably more of a general question, but I guess over time, and I think you said, Dr. Gillen, that the clinic's been operating for about 40 years, general trends, demand for services, I guess technology advancements with the work that you do, would you say that more and more individuals and families are coming to you for support, and do you have the resources to be able to keep up with the demand?
Yeah, so to your first point, definitely demand continues to grow. Look, there's many socio-economic reasons why the demand for ART is continuing to grow, but financial reasons is definitely one of those, and so we're privileged to play a part in the delivery of the service.
And then moving to some of the specifics in your submission, I'm interested in, you speak about, obviously we've asked questions and I think there's agreement about the Affordable IVF Initiative and that making it more accessible for people, but you talk about embedding the funding to remove the cyclical nature of application and improve the reach of the funding itself. Could you just elaborate a little bit more on that for the committee, please?
Sure, thank you. So the path for a patients embarking on fertility treatment can be often quite prolonged and it's cyclical in nature in and of itself. So a patient may come and commence treatment, they may go through a series of investigations that they are helped with the pre-IVF rebate as well. Then they access IVF treatment, the investigations take some time and are explored with their doctor, and then the clinical path is then delivered through treatment. Patients may be unsuccessful on the first and come back for future cycles. Treatment cycles. So in and of itself, there's a cyclical nature of that, and that may overlay with a different grant funding cycle. So when we're talking to patients about if they have frozen embryos with us, so supernumerary to their first cycle of IVF and they're stored in our facility, we want to be able to provide them certainty that if they come back for a frozen embryo transfer cycle down the track, that pricing will be of a nature of that affordable nature. And that's, in our setting, that's enabled through the grant funding that we receive. So if we had certainty over grant funding, that's what we were referring to. It would just take away any uncertainty of a blocked funding period.
Because now when you don't have that certainty of funding, in that case, and using the example that you did with frozen embryos, so is there potential sort of increasing cost to families? Is that what is the impact of that in practice? Yeah.
That would be the reality.
Okay.
Look, taking a step back, we are very much focused and our values are very much embedded in affordable delivery of care.
Yes.
But it's very much underpinned by the grant funding right now.
Yeah.
So if the grant funding were not to be renewed for whatever reason, we would have to look at, and we have scenario planning always going underway, how would we continue to keep that out of pocket as low as we can. And you would probably be familiar, so for an IVF cycle in our setting with the New South Wales government supports $1,000 out of pocket. So that's quite remarkable, and I'm sure if you had a look across, as you've had a look across the various private groups,
Yes.
even those that are claiming to be lower cost, it is difficult to reach such a low level. So we're very proud to be able to deliver it for $1,000 out of pocket.
Yeah, and so I guess in terms of potential recommendations from this committee, trying to just have that funding continuity would be something that you would be advocating for.
Certainly.
Yeah, okay, great. And then I also wanted to ask, not surprisingly, I'm the Nationals and regional person, the regional and rural component, I suppose. And I know that you've talked about the remote cycle program and how that supports individuals and families from regional areas. Can you speak to that a little bit more as well,
Sure.
please? And happy for either or. Sorry,
Yes.
I should have tried to. Yeah.
I'll jump in. So that again is something we're very passionate about delivering. How it works in our setting is that we use our location in Westmead Hospital as the central hub, for want of a better term. And we do work with a number of external service providers, so that's pathology centres and ultrasound providers that are in the regional, spread regionally and across New South Wales. So patients will commence their journey with telehealth conference with their doctor and then is supported through care by our nursing team through a similar model. And then in their local town, the patients will be accessing doing the cycle monitoring, so the first part of the cycle in their local town as close to home as they can, and then only travelling to us for the egg collection and the embryo transfer procedure.
Okay, and then how does it work? So, okay, I live in Gunnedah. Say if I wanted to come and access your service, how do people know that you're available? As you say, obviously low cost. Is there criteria, or what's the process for people to access your services based out of Westmead?
Clinical need is the real way, yeah. And so raising awareness is something that's really important, especially for our remote support program. So just making groups aware. And so we do actively reach out to healthcare providers to make them aware of the service and how we can work with them.
So, and when you say clinical need, my colleague is a doctor, I'm not.
Yep.
What sort of the thresholds or benchmarks that you look at in terms
And look,
of
I would just mention, Dr. DeBoer and myself, we're both PhDs. We're not doctors.
No, that's okay. That's all right.
But you're happy to talk about that as well.
Yeah.
So the clinical need would be as recommended by their doctor. So there are many paths why a patient might end up with seeking fertility care.
Okay.
Generally, they've been trying to conceive for a period of time, generally a year in our younger patients, and that just haven't been able to achieve a pregnancy, and so they've gone to their GP or their specialist, but they've ended up it being identified through a series of investigations, the IVF or some other type of ART would help them on their journey.
Okay. And I would imagine, obviously being lower cost than some of the private providers, and this would go back to my original question in terms of demand, I'm assuming there is more demand for your services than the ability that you have to support individuals and families?
No, actually, we have capacity. So, through careful management, we are able to meet demand. So right now, to take a step back to be completely transparent, so some patients may have a bit of a wait to access to see a specialist. But once there's a recognised need for IVF or any type of ART, we don't have a wait list to get started.
Okay.
We are ready to receive patients.
Okay. I'll just have one more and then I'll hand over to my colleague. And if you need to take this on notice, that's fine. But I was interested in your submission where you talk about expanding the application of funding to all types of ART cycles, including the less invasive treatments.
Yeah.
Is there more detail on that you could talk to?
Yeah. So we want to have an environment where patients who are very price sensitive are not jumping straight to IVF because that's the easiest path financially. We want to make sure that doctors are able to provide any option to patients along that ART journey. So that might be less invasive procedures such as ovulation induction, ovulation tracking, IUI, intrauterine insemination. So there are some more less invasive options that could be, if it was broadened, that the doctor would be able to step through.
Okay, and the reason, I guess, in your experience, that those initial steps maybe aren't the first, it's a financial barrier. Is that what you find?
It can be from time to time, not always, but we just think if the complete set of potential ART treatments were included, it would just take that out of the equation. It would make sure that the appropriate path could always be followed with ease.
Yeah, that's
Makes it-
interesting. Yeah, thank you. Did you?
Yeah, I was actually going to ask about that as well.
Oh, sorry.
No. It follows straight on. In terms of, I guess, understanding about the suite of ART that's available, do you have any concerns that perhaps not all clinicians are well informed about what is available for women?
No.
So we've received, for example, a lot of submissions about NAPRO. You'd think that everybody would be familiar with that and able to recommend that to their patients as well?
I probably won't comment on that specifically. I don't know if Dr. De Boer wants to. I won't comment on that one specifically, not being clinical myself, but I think all of our doctors are.
Oh, sorry, I didn't mean your doctors. I meant the perhaps initially treating doctors who might then refer for your services.
So we are reliant on GPs or specialists recognising the need and then referring on to the specialists who work with Westmead Fertility Centre. But I think that path is well set out.
The other thing I noticed in your submission, you talked about enhanced mental health support. What exactly do you think needs to be improved?
I think it's just a continual focus on mental health support, recognising the toll that dealing with infertility has on patients, the impact that has on the broader community, and knowing that even if we do our absolute best and try and help patients on their journey, from time to time they step out and remain childless. That does have a large impact on individuals, and we know that has a lag period that can go on for many years. So just making sure that it's end to end and as much as possible, providing that support in the community.
And especially in regional areas.
Absolutely.
Where do women and men go to receive that support, and are the services available?
Look, I think it would be to just to call on what Ms. Bruce was mentioning before, making sure, and that's something so we have a counsellor embedded in our organisation, but once patient, and that's freely available to our patients. And I know earlier on you were mentioning about donor conceived offspring. They can come back to if they're birth parents, if they were created through ART, through our centre, then our counsellor is there to support and make sure that they can get directed, either provide the support internally or directed elsewhere.
And there's capacity in your service with the counsellor to do that?
There is, yeah.
Okay. And that continues for how long for the child who's been conceived?
Look, we try to make it as available for as long as we can, and it's just then our counsellor will work with the individual to work out what is right for them at this point. It might be handing on elsewhere.
Where else is available for that child or that young person to be handed on to?
Yeah, it just would be some of the resources that Miss Bruce was
mentioning. So there's no
before.
sort of specialist resources that can deal with these particular issues?
There are a number of specialists.
And what do they look like?
I could take that on notice and
that
come
would be
back
great.
with the list.
Thank you. No, that would. And my last question is, your submission also noted the need to encourage transparent reporting of success rates from ART clinics. What's the issue about current reporting processes?
I'll jump in. Look, I think something that was very important for us is to really be recognising the impact of socio-economic status and the impact that can have on success rates. for many reasons. When the individual, it's correlated with socioeconomic status, there may be factors that affect the health of the individual that also affect success rates. And so we just wanted to always make sure that there's a very wholesome presentation of results, of reports.
So what would if there was a reporting template, what would that, across all clinics, what would that look like?
Some measure of socioeconomic status in some way, of whatever was appropriate.
Mm-hmm. A uniform measure, you could develop that?
Or if there was something existing that New South Wales Health may already...
Is there something, if we were looking at a template or a recommendation?
There may be.
Can you take that on notice,
Sure.
perhaps? That'd be great. Thank
Yep.
you very much. Thank you.
Okay, thank you. We'll just move now to... There we go, perfect timing.
Yeah.
Thanks, Chair. Good morning. I just wanted to follow up on a couple of the answers you've already given. The Chair asked a question about managing demand, and in your answer you said there was a wait time for that initial specialist appointment, but then once that appointment had happened, IVF was quite readily available.
That's right.
What's the average wait time for that first specialist appointment?
Look, it can range dependent on the doctor, and so it is often a preference of, obviously, for who the patient may resonate with, who they want to see, whether they've got some reason that's informed their decision of which doctor they want to go to, and so that does sometimes mean that there is different wait periods for certain doctors over other doctors. But if patients come to us and say, can you help me find a doctor appointment quickly, we will work across the doctors who work with us and liaise with their rooms and try and find an appointment as quickly as possible.
Yeah. So for those patients, so for someone who's agnostic as to which practitioner they see, what's the average wait for those people?
Could be as quick as a couple of weeks, but realistically a couple of months.
Okay. And I also wanted to follow up the questioning around cost and your suggested expansion of the application of funding to all types of assisted reproductive technology, because I just wanted to clarify. So, a treatment like ovulation induction or intrauterine insemination, is that more expensive to provide than IVF, or is it that because the IVF is subsidised that becomes the cheaper option?
The latter.
In terms of the expansion of public services or publicly funded services to make them more available, obviously funding would be needed, but are there any other considerations in addition to funding? What would be required to meaningfully expand the service?
You mean if they, like a new, sorry, just to clarify, you mean another centre to be created?
Yeah, I mean, one of the things we've received a significant number of submissions about are the geography of the existing clinics. So, would funding be sufficient for another centre to start in another area?
That's right. Did you want to jump in on that one? That would be right. So there would be a number of structures we would have to put in place. So obviously we'd have to have the personnel, the doctors, facilities, but there could be a path, just as an example, but without any commitment, of course, but potentially if it was a broader commitment, looking at locations in other local health districts perhaps, or co-located with other health precincts, looking for a geographic location where there is demand. I suppose a factor that we always have to consider in running an ART laboratory is to keep compliance of the individuals and to keep all of our systems and processings. We do have to have a regular flow, or we would need to block it and be having it as a cyclic, so a drop in and drop out service.
Okay.
But that is a consideration in terms of quality management, to have reasonable numbers flowing through.
Thank you, and I appreciate this might have to be taken on notice,
Sure.
but do you have a sense of an approximate number of what would be the scale or the throughput required to meet that safety and accreditation?
We'll give that some thought and come back with a number and take that on notice,
Thank you.
please.
I also asked the same question to the previous witness from New South Wales Health. I'm interested in understanding for your remote cycle program, what specifically are the parts of care that can be safely provided remotely, and which are the parts of care that then people are having to travel for?
So our model at the moment is the cycle monitoring. So the patient is advised. So I'll take a step back. So if it's an IVF cycle and the doctor has said that the patient should be having an IVF cycle to assist them with their infertility. So it would be the cycle monitoring, which is the part of the cycle up front where the patient is under the care of the doctor and being advised on taking medication to stimulate their ovaries, to stimulate the follicles containing the eggs within their ovaries. So that can happen remotely, that can be remotely monitored through our service arrangements right now with external pathology labs. So they're the ones who are taking the blood samples, processing the hormonal results, and they're also performing the ultrasounds to monitor how the patient is responding to the medication. That can all happen remotely. And then the patient just travels to Westmead for the egg pickup, so the clinical procedure that happens within Westmead Hospital's theatre at this time, and then the embryo transfer procedure, which happens within our procedure room.
Okay. And in terms of the, I suppose, clinical either expertise or specialist equipment that's required for the procedures that are taking place at Westmead, would it be reasonable, for example, for that to take place in a regional-based hospital or a smaller hospital?
Absolutely. Yep. As long as, and it would have to have the appropriate regulation and certification, training of the individuals, and a period of time to get everyone trained up.
It is quite common around the world to do what they call satellite clinics, where the team comes in for a certain amount of time. It's usually about 2 weeks. The patients are treated in their own environment. Often there is an individual who is part of the local community that is in that community that supports them. It's often a nurse who is their main touch point, but the specialist team comes in and out. The main part of that is the laboratory that needs to be set up to deal with the gametes after the collection, and that's where it's very important that, and it involves a capital expenditure, that the equipment is designed for transportation and to meet the accreditation standards that are appropriate.
Thank you. You've segued into my next question nicely, which was you made a recommendation around strengthening the activities commenced by the Fertility Society of Australia and New Zealand to review the regulatory frameworks, and we had a few similar questions already to New South Wales Health. Could you expand on what you'd recommend in that space in terms of improving regulatory frameworks?
Just to say that we support it and welcome continued attention in that area.
As it stands now, what role is there from New South Wales Health in terms of oversighting the service that you're providing?
So we are registered with New South Wales Health it's as an ART clinic, and then we have different reporting through the Affordable IVF Initiative. So there's 2 separate streams. So just as an ART, not just, but as an ART clinic in and of itself, and then also through the administration of the Affordable IVF Initiative.
Okay. And is it possible to talk us through that process, particularly in terms of quality and safety mechanisms?
So as an ART clinic, we are registered through ARTAC. So we have a certifying body who is accredited by the Fertility Society of Australia and New Zealand. They do a very detailed certification process or auditing process. We just went through ours before Easter. Very pleased to say we had a complete, clean and clear audit. That happens annually. It's on a 3-year schedule though, the way that the accreditation process happens. What sort of items would you like to...
That's right. And I think you mentioned that as part of the partnership with New South Wales Health that you separately have to report back to them. So what are you providing in that instance?
Yes. So then working with our Western Sydney local health colleagues, so we have an agreed targets, a funding model, and where we have performance reports. We have meetings with our colleagues in the district as well as our colleagues at the ministry to check on progress, see how we're going, and look at the targets and how we're performing.
Okay. And are any of those targets in terms of performance, are there any relating to quality and safety?
We do share information around some aspects. We can share the template if that's appropriate.
Yes, thank you. I'd appreciate that.
Yeah. Look, I would say we have very strong a measure that we use. So we measure, sorry, to take a step back, we measure feedback along the cycle of the patients having treatment with us. One of the ways that we use is the Net Promoter Score. So we're very pleased that we always have a Net Promoter Score that comes above 70 or higher. on an ongoing basis. So patients are very pleased with the performance and the care that they get with us. We're also very open and transparent in the reporting of our results onto the Your IVF Success website as well.
Quality and safety is very much part of the depth of governance that comes with Westmead, and it is reported through to the University of Sydney through the board. The board has a clinical governance committee that has the appropriate members sitting on that, and we also have a risk and audit committee. And so all safety matters, all quality matters go through the appropriate committees there, through to the board, and ultimately through to the University of Sydney as well.
Okay, thank you. I wouldn't expect you to be able to rattle it off the top of your head, but there was already an offer of providing a template of performance indicators. Are you able to provide those matters that are reported to those committees, or what?
Very easily. It's a standing agenda item for us. So yes.
Thank you. Last question from me, and I'll hand back to the chair. Just same question I asked New South Wales Health. What measures do you put in place in your clinic for cultural safety for LGBTQIA+ people?
So one of our values is accessibility, and that means all walks of life. We are a very diverse clientele, and we welcome everyone.
I suppose, are there particular protocols or guidelines or training that underpins that to be implemented in practice?
It's very much embedded in all of our protocols and practices. I'd have to take on notice exactly. Maybe I'll pull out something particular for you. Yeah.
Thank you. Thanks.
Okay, thanks. I'll just ask a couple of quick ones before we go to the government members. Dr. De Boer, you mentioned just in some answers to Dr. Con, the satellite clinics, and you said in some, I think overseas or other jurisdictions that operate. So are there any examples of places where you know they do that well in terms of the satellite clinics that the committee could look to?
Look, yes, it is. It's even done within New South Wales at the moment by some of the private clinics. So there is a template for doing that. I actually presented at the European conference on regional clinics, and the very first regional clinics that were put in place. I presented there as an invited speaker, and we talked about the development of equipment that was particularly made for transportation to these clinics. It was equipment that could be used on smaller amounts of patients, and therefore it was able to be used, able to be transported quickly and set up quickly and taken down quickly. So there are a number of well-established models for setting up regional clinics. But we also can remember there's a spectrum on which you can deliver this to regional patients, because it's not regional patients. It is not just about the actual delivery of the service, as we talk about in our submission. It's very much IVF takes up quite a component of a patient or a family's life. And so it's about giving them the ability to have the resilience so that they don't have to travel so much, so that they've got people around them who can support them. That mental health support often comes from family, not just professionals. They have support. It costs them less to access treatment in their own community. By having nurses in place that are just focused and understand infertility is often incredibly helpful. So there's a spectrum on which you can provide services to regional patients that doesn't have to be everything that you would get at a city clinic, but helps them along the way.
Yeah. And then in terms of, I guess, the provision of that, if the government of the day said, we want to expand this and we want to do 3 more regional clinics, we're going to do Newcastle, Tamworth and the Shoalhaven. I'm just trying to move but wherever. So there's no impediment to, other than the money to set those sort of arrangements up. If government was to fund more provision of these public regional clinics, there is the capacity to be able to do that, in your opinion?
There is the capacity. The only impediment, obviously, is the capital cost and the willingness to ensure that this is done safely and with an understanding of regional need.
Okay.
In a sort of a not-for-profit way, I think is very important.
Yeah, thank you. I'll hand over to the government members.
Thank you,
Mr. Donnelly.
along. Can I just turn to the subject area of surrogacy and see how that fits in, to the extent it does, within the service offering that Westmead Fertility Centre provides. Is it the case that that is on your suite of services to facilitate surrogacy?
So at this time we don't offer surrogacy services at Westmead Fertility Centre.
So it's strictly a fertility centre. Sorry.
We don't offer surrogacy at this point in time.
So, I mean, just out of interest, do people contact the centre and say, listen, we are contemplating surrogacy? Do you offer it? And you obviously would say no to that. Where would you, if you do you direct them to another?
We do, that's right. And so a number of the doctors who work with us have a relationship with ourselves at Westmead Fertility Centre or with other IVF clinics, and so we make sure that there's a path there for patients to access care.
So that would sort of involve saying, well, listen, you may consider looking at this or that business. And
that's right.
Those, are they mainly, I'm trying to understand whether there is a pathway back to New South Wales Health, or whether the pathway would normally be to one of the for-profit enterprises that sort of offer surrogacy arrangements.
Look, my understanding at the moment is it would be back to one of the for-profit organisations.
Right, okay. On the question of your submission, and thank you for it, the second last dot point or dash point on the page 1 about the matter of the transparency.
Oh, yes.
Yeah, so thank you for that. You've referred to the matter of transparency, particularly with respect to the tracking of access and outcomes across socio-economic groups.
Yeah.
And I understand that. So, but in regards to other than matters of the socio-economic circumstances of individuals, which is tracked, are there other matters that Westmead Fertility Clinic track as well as part of their treatment of their patients or clients, whatever term you use?
Oh yeah, there's a whole range. Yes, a very broad suite of KPIs, so key performance indicators at a laboratory level, at a clinical level. We contribute to the ANZARD report, as Bruce mentioned earlier.
Yeah.
So and then that gets used by the NPSU team, and it uses to create the measures that are then on the Your IVF Success website.
So, in regards to the collection of data, you've described that it's extensive. So is it the case that there's data that goes off to New South Wales Health because you're registered with New South Wales Health? That's a pathway for data that flows. In other words, you've got obligations. That's right. To provide data to New South Wales Health?
Via the Western Sydney Local Health District, and then goes to our colleagues at New South Wales Health.
And do you know whether New South Wales Health publish any of that or make it public in any way, or that's essentially, I use the sort of term, in-house information which is reported for them to, I guess, look at and perhaps, if they've got any issues, come back to you? Is that what you understand?
It is certainly being used by the Affordable IVF team to assess the performance of Westmead Fertility Centre and the local health district in terms of meeting our obligations.
Yes.
I can't comment on then how publicly available that is.
And is it another pathway of reporting that's to a Commonwealth entity or Commonwealth agency? If you could sort of just help elucidate that. We're just trying to get a sense of what are the accountability that's going on in terms of where from.
Yes, so as an ART, an accredited ART clinic, we have reporting obligations, and so the key one that we have is to contribute to the ANZARD report. So we submit our data, and that gets critically reviewed under the ANZARD report, which at the moment is part of University of New South Wales, the NPESU.
Now, I noted in your opening statement you referred to the relationship with the University of Sydney, and you described the organisation as a private facility and a profit for purpose facility.
That's right.
Or profit, it's run along a profit for purpose model.
Yes.
What I'm interested to know is that it is the case as a general proposition that the fees charged and I use the fees across the different domains of fees that
Yes.
you charge for ART or specifically IVF, they are generally speaking lower than what for-profit companies would charge. Is that
Most
a
certainly.
fair general statement?
Sorry to cut you off there, but most certainly, yes.
No,
In
sorry.
my excitement, yes.
Yeah, no, sorry. Forgive me. I wasn't letting you on there. No, I thought that was the case, but I just want to confirm. So, with respect to then the setting of the fees that you do, I'm trying to just in my mind make a distinction that you set your fees in what way? You're not a not-for-profit, okay? So you are a profit for purpose. So are you essentially looking to ensure you can, on an ongoing basis, break even or a bit better, and surplus goes back, and you continue to offer your service? Is that how you generally sort of
Yes,
look at the
generally.
way in which the operation? Yeah. And in terms of the setting of the fees that you do have, I'm not asking you to obviously reveal anything that's commercial in confidence, but is that looked at by examining what the for-profits are charging, so you can see effectively what those fees are for the different services, and then as a organisation make a decision through your governance, body or subcommittees about what your fees will be charged? Is that how you?
I suppose just to jump in, we certainly have an eye on what the marketplace is offering, but we very much come around the other way of looking at our cost structure and what we can deliver it for. Look, we do, as you know, work with the Affordable IVF Initiative, which is requesting of us to offer it for an IVF cycle for $1,000. And so we're committed to that.
Final question. Would you be bold enough to accept this proposition that with respect to the for-profit companies, and I'm not asking you to, not nominating any particular company, but the for-profit part of the industry, that they are charging, given that if you look at your fee structure and their fee structure, but also appreciating the remit of your organisation compared to a for-profit business, are they doing pretty well with respect to their charging schedule and, dare I say, the profits they're capable of making?
I would say that they have different stakeholders than we do.
Like shareholders, perhaps?
Yeah. So their expectations are different. For us, our main, what we need to deliver on is accessibility. And so our main stakeholder is University of Sydney, so research plays a huge part in what we do. So we very much focus around those pillars. So our stakeholders put a very different emphasis on what success looks like than the private clinics.
Yeah. That's. Do you have anything to add to that? I mean, it's quite a.
I just
Yeah.
confirm,
Thank you. I wanted to go back, if I could, to the ART cycles request in your recommendation, so expanding the application of funding to all types of ART cycles. In terms of the other ART that is available, you mentioned a couple. You noted they're less invasive.
That's right.
Are they therefore cheaper?
That's right.
And is there any clinical benefit for exploring those options prior to going to an IVF?
In some particular clinical scenarios, there is, or there is a path where it can be explored. And that's what we leave in the very capable hands of our fertility specialists and their medical decision making. But yes, certainly there is a path for some individuals at some times to use those less invasive approaches.
So there could be a case for that being, an option to be considered that is then, but there it is not available because you're not funded specifically for that. Is that the case? That could occur, hypothetically speaking.
So it's certainly available to all of our patients. It's available in our setting.
Yep.
What we're requesting is to make it even more affordable
Okay.
So that it doesn't come down to a financial decision. If it is a clinical decision that may be recommended by the the couple's doctor, that there's no impediment from a financial perspective.
So you offer it, but it's not subsidised at the moment?
That's right.
So how much does it cost?
I can either take that on notice, or I could have a quick look through my files.
That's fine. Whatever you prefer.
Perhaps I'll take it on notice. I'll come back to you. Yeah.
Sure. Thank you. It's interesting for us to sort of have the full breadth of information. Is there a reason why, to your knowledge and best understanding, why that is not subsidised as part of it, in terms of whether it's clinical efficacy or I don't know, whether the research hasn't caught up yet? Is there any sort of reason for that? Do you know?
Why it's not included in the funding envelope?
Yep.
Look, I wouldn't want to talk on behalf of the Ministry of Health.
No.
I would only be taking stating a position which would be, I think we were starting somewhere. I think everyone was starting somewhere, and I think it was starting with the most prominent and usual course of treatment, which is IVF, and then the subsequent fertility, frozen embryo transfer cycles is the bulk of ART.
Sure.
And so I think that's where the benefit of the program was focused.
So it may be the case that this option is not necessarily the standard option, but would be good to have to be able to offer.
For some patients, stepping through those, it is a standard option that they would step through those lower interventions and then reach IVF.
I want to go back now, if I can, just to change gear to a question that I asked Health this morning about, the review of the quality of your program, patient feedback surveys, whether that is something that you can do, and if you could provide us with any information about that.
Yeah, so feedback from our patients is something that we're very focused on. So there's a number of touch points along the patient journey where we seek feedback. So just as some insight into some of those examples, when the patients come on site and they're using our services. So we have a simple process of the patient will swipe a card so that we know that they're on site. They have their care that is required for that day, and then they swipe out. They're presented at that point of care with the opportunity to provide some feedback, and if they'd like to talk to our Director of Nursing or one of the other teams, we monitor that feedback and respond to that. At the end of treatment, the patients are provided with a very detailed, full scope of the entire treatment journey, deep dive into their treatment, and we have those results, and we monitor those as a leadership team. We have a quality manager who is focused on reviewing and assessing. If required, we will follow up with patients and have more of a discussion with them and explore.
In terms of the question asked by one of my colleagues earlier in the day about having a sort of a satellite operation, if you like, a drop-in team. Have you done any work to understand what the associated cost with that would be? Obviously, there's a requirement to have a level of service on the ground, and I think you mentioned the sort of the transportation and having a lab. Have you done any work to sort of model what that looks like?
Yeah, historically we have. Yep.
Is that something you're able to provide the committee with on notice?
We could, yes.
Thank you.
I think one of the key things to remember is also it's not just the physical being there, it's being able to access a site that would be suitable to host that clinic.
Okay. That is my time, I think. But
yes, thank you. That's okay. Thank you both for being here. You did take a few questions on notice, so the Secretariat will be in touch just to organise receiving those questions. But thank you for your time and for appearing today.
Thanks for the
Thanks
opportunity.
so much.
So the committee will just take a short 15-minute break now for morning tea. We'll resume again at 11 a.m. Welcome back, everybody. I'd like to welcome our witnesses from the Catholic Women's League. I'm just wondering if I might start with you, Dr. Walsh, if each of you could state your name, position, title, and swear either an oath or an affirmation, please.
Name, position and title is Dr. Anna Walsh. I'm the State Bioethics Convener for the Catholic Women's League Australia, New South Wales Incorporated.
Mm-hmm. And an oath or an affirmation?
An oath.
Mm-hmm. Please.
Okay. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Snoop.
My name is Miss Elizabeth Mary Noons. I'm a member of the Catholic Women's League New South Wales, and I'll be swearing an oath today.
Mm-hmm.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. And would either of you like to make a short opening statement?
Yes, thank you, Chair. Just a short 2-minute
That's fine.
statement.
Yep, great.
The terms of reference for this inquiry are very broad, and our submissions dated the 30th of September 2025 focus on two main issues. Firstly, infertility investigations and treatment that are little known in the community, including the medical community, that don't involve IVF. IVF is morally controversial, and for some of us in the community, IVF is not a service we can access for infertility challenges. So it's important for the panel to know this from a diversity perspective. Other concerns about IVF are its low success rate and its high costs, and these are echoed in our submissions and in some of the non-faith-based stakeholder submissions, such as Submission 38 from the Feminist International Network of Resistance to Reproductive and Genetic Engineering Australia. Accordingly, opposition to IVF is not solely a religious issue. Our colleague and member, Dr. Deirdre Little, is a medical expert, and she has experience with other ways of managing medical infertility, and her thoughts are set out as Annexure A to our submissions. And Dr. Little, as we understand it, will be addressing those issues separately in her own session. The second issue we focus on in our submissions is surrogacy, and again, whilst we are a faith-based group, our position against surrogacy is shared by other stakeholders who do not identify with our faith. An example is Submission 18 from the United Nations Special Rapporteur on Violence Against Women and Girls, dated 26 August 2025, as well as Submission 22 from the New South Wales Women's Action Alliance, dated 27 August 2025. The point being that opposition to surrogacy is not constrained to people of faith-based on some sacred texts that only people who are members understand. Rather, it's a shared perspective about the human person based on common wisdom, which leads to certain conclusions about what is good for society. One of those conclusions is that there is no moral right to have a child, and the state should not grant a legal right to people to have a child via surrogacy legislation. Now, we obviously acknowledge that people, most people who wish to expand access to surrogacy do so with the good intention of wanting to be a parent to a child. However, we believe that surrogacy agreements should not be a legal contract for services rendered. We believe there's an unresolvable tension between the best interests of the child, which is the guiding principle of the Act, and the wants of the commissioning parents and surrogate mother. So for the record, we want the lawmaker to maintain the prohibition against commercial surrogacy and to rethink the wisdom of permitting altruistic surrogacy. Thank you.
Thank you. So the committee has resolved to equally divide the time for each set of witnesses between opposition, crossbench and government. We start with opposition questions, and I'm going to hand over to my colleague, Ms. Carver.
Thank you, and thank you both for being here today, and thank you for your submission. I'm interested in the comments you make in relation to parentage orders and birth certificates, and the suggestion that what we currently do in New South Wales is to obliterate the identity of the mother. I wonder if you have any comments about that, and also your comments in relation to the UN Convention on the Rights of the Child and the right of a child to know their identity, and what impact no information about the birth mother may have on the child going forward.
Sure, thank you for the question. It's quite interesting because I teach law at the University of Notre Dame, and my first year law students are actually doing an assignment on the Surrogacy Act and about parentage orders. That's what I said them. Yeah. So we've had some discussion about this obviously in class. So my understanding of the legislation is that the birth mother and her spouse are considered to be the parents of the child on the birth certificate, and that can be changed after there is a parentage order entered into by the court. And it obviously raised concerns about something that we say is very important to the dignity of a human person, which is their identity and their right to know their biological heritage. Articles 3, 7 and 8 of the Convention on the Rights of the Child, which is international law and soft law, contains some important things we can turn to for some wisdom. Article 3 talks about in all actions concerning children, whether undertaken by public or private social welfare institution, courts of law, administrative or legislative bodies, the best interests of the child shall be a primary consideration. That feeds into Article 7. The child shall be registered immediately after birth and shall have the right from birth to a name, the right to acquire nationality, and as far as possible, the right to know and be cared for by his or her parents.
Can I just stop you there?
Yes.
In what way would you say that the best interests of the child are not served by having the identity of the birth mother suppressed on official documentation?
Well, obviously there's an issue in relation to truth. The birth mother gave birth to that child, and there's a bond formed during pregnancy between the mother and child. I think we go into that a little bit in our submissions. It's common wisdom in relation to the fact that there's a physiological connection as well as other research that suggests other aspects of connection that's severed obviously by the relinquishing of the child to the commissioning parents, and that flows through to official documentation where ultimately it is changed and amended to reflect the fact that the commissioning parents are the parents, so the child may wish to know their genetic heritage if indeed the surrogate mother contributed it, perhaps an ova, or notwithstanding that, just the fact that there was a 9-month connection with that mother. And I think probably Dr. Little will go into a little bit more of the medical aspects.
With respect to that, you touch in your submission on evidence in relation to the psychological welfare of surrogate children, and there's well-established research about some of the psychological challenges for children conceived through ART. This is interesting. I hadn't seen this research about surrogate children born of surrogacy before. Are you suggesting that our practice with birth certificates, where we subject to a parentage order, issue a new birth certificate which removes references to birth mothers, that this somehow contributes to psychological challenges that children may face?
Certainly, I think there's a risk of that because we acknowledge that identity is very important where you came from. My understanding is that the child might be able to go back at the age of 18 to understand whether or not they were the product of a surrogacy arrangement. But I guess the commissioning parents may decide not to share that with the child, and the surrogate mother, there may be an arrangement that they have no contact with that child throughout their life. So definitely the Convention on the Rights of the Child makes it clear that the child has a right to its identity. And it raises an important point regarding the guiding principle of the current Act, that it is in the best interest of the child, because there are obviously presumptions when you interpret statute that Parliament doesn't intend to, it intends to legislate in conformity with international law, and it doesn't intend to abrogate people's fundamental rights. So it's an interesting challenge to say how the best interests of the child are served by this current situation where it appears, at least it's arguable, that the rights of the people who want the child, the commissioning parents and the surrogate mother herself, may be raised above that of the best interests of the child.
Is it just an identity question? Because I note you quote testimony given by a surrogate child, Olivia Morell, to the UN Convention on the Status of Women, where she talks about the idea of the fact that her knowledge that she was created, and I think she says the idea of being treated as an object slowly destroyed me. Is there something innate in the idea of the commodification of children that are born through surrogacy that has impacts on their psychological and mental health?
I think common wisdom would suggest yes, and it's important to hear from people who are the product of surrogacy agreements about how they feel in relation to that. It's obviously something that it goes against nature. Nature, however unjust you may think it is, doesn't allow older women to naturally give birth, to sterile couples to have children, etc. There are obviously issues to do with medical infertility, but that desire to have a child, which is very, very natural, we don't think should be satisfied through legislation that permits people to procreate in this way.
But the idea of identity that we've explored, the idea of being ordered as a commodity, are these not issues that could be addressed by appropriate psychological counselling, or will they stay with the child forever?
Well, if the damage is already done, it doesn't sound like it's in the best interest of the child to create them in circumstances where there's already this risk that didn't need to be there in relation to damage. I would call on more research to understand what has been done. If lawmakers decide to make this lawful, what evidence did they have that it actually wouldn't cause harm to a child, or it could be greatly reduced by some sort of intervention, and what's been done in relation to that?
Last question from me before I hand over to my colleague. In your submission, you quote somebody who refers to surrogacy as strip mining the wombs of the poor. Are you aware of any circumstances where commercial surrogacy takes place that do not involve coercive conditions on women?
Well, there may well be, but I think at the end of the day, if you start from the premise that the very nature of the act of surrogacy is undignified, and it commodifies women and instrumentalises them, regardless of their view about whether or not they've given consent to it, regulation won't change the nature of that act.
Okay, thank you.
No worries.
Thanks. Just a couple from me. Thank you for your submission and for appearing today. I just wanted to ask, in the executive summary, you say that your organisation upholds the views of the Catholic Church and say that you support advances in knowledge and technology that can correct defects within or with a person's fertility. Can you just elaborate a little bit more in terms of that? I know Dr. Little isn't here today, but the submission does go into a bit of detail about, I guess, people understanding their own fertility and that awareness. But, the views around, I guess, sort of where is the threshold for support in terms of fertility interventions from your organisation?
From the Catholic Church's position, or?
Yeah, and
Sure.
from your perspective as well as obviously.
Sure. Well, the Catholic Church, the Catholic Women's League, New South Wales, is, follows what we call the magisterium of the Catholic Church, and the Catholic Church clearly states that IVF is morally illicit, so it's not something that we can make use of. There are some other kind of NAPRO technology and other investigations and treatments that we understand Catholic physicians perform here and overseas that may be little known in the community, that are cheaper and apparently produce very, very good results. So I think just in terms of diversity, because not everyone in the community actually wishes to take part in IVF, but still wishes to try to correct any defects that can be corrected. That's something that the state might look at in terms of elevating discussion and informing medical people and the community that they do exist. It really is a medical question, though, Chair, and I think I would defer to Dr. Little to expand upon that. She'll do a much better job than I can do as a lawyer.
I was just interested, I guess, in terms of your views as well, so thank you for that. And again, this might be more medical as well, but I suppose there's a call out around the personal development curriculum in schools to help incorporate sort of better information about female reproductive health science and systems. I guess in terms of your members and your organisation, is that something that is raised in discussion, with the women that you represent?
Chair, I'm not sure I quite understand the question.
So one of the recommendations is calling for having personal development curriculum in schools to incorporate female reproductive health science and symptoms in their interpretation.
Yes.
So I guess I'm just after sort of your views on, is that something that you think isn't covered appropriately in schools? Do you think there needs to be more awareness about people's own fertility?
Yeah. Yes, Chair, I think that's the view that Dr. Little produced in the federal submissions, and we would stand by that. That it's important for women to understand how their body works and not to move immediately to perhaps certain practices that are considered mainstream and what have you, but that they explore that and understand their body and be able to make the choice as to whether or not they wish to go down the route of IVF, for example, or more NAPRO technology.
Okay, thank you. And then just one more from me. You mentioned, I think earlier, Dr. Walsh, just about the need for more research into some of these issues, and I know that your submission does go to a few different sort of journal articles and things, but there is, you have, I think it's within the terms of reference to Part H, your paragraph 6, and it says it's noted in your federal submissions, but it says surrogacy is harmful to the mother and child, and it is an abuse of the child and the mother. Now, that's quite strong language, and you're entitled to put that in there. But I just wondered, in terms of sort of the evidence base behind those submissions, are there examples of research that's been conducted that you're aware of that go to some of those issues that you've raised?
That are not already in the submissions?
Yeah.
Well, I'd stand by what are in the submissions, and I'd just stand by common sense and the fact that there are many groups who will appear before you during this hearing who would have the same view. That are we talking about altruistic or commercial surrogacy or both?
Well, you say surrogacy is harmful to the mother and child without the distinction. So I
that
just
would be our view. Yes.
Want a chance for your views. Yeah. Okay.
Yeah. So we would take that from a first premise situation that the actual nature of the act of surrogacy is it's a strong word, but degrades reproduction. It's harmful to society because it really is disrupting the natural understanding of family and the bond that a child creates with the woman who carries them for 9 months, nourishes and protects them, and is suddenly then taken away from them. There's some imprint of that bond physically and in other ways, emotionally, that maybe we don't know the full research yet of. But it's something, if the state wishes to make it lawful, it needs to be very, very sure that there is no harm that comes to the child from that. And I don't know that you can be sure of that. At least the state should be maybe engaging in research in this area. I was thinking actually as I was walking in about things like, years ago when they had IVF, they used to have a lot of privacy rules around people who donated, and they changed that after years when they heard from people who were the product of IVF and donor gametes who wanted to know their heritage, and now that's required to be recorded. So that there is wisdom that can be, gained over the years, continually reviving the subject to hear from other people. So no, I can't say that we have a great swath of research to back up what we've said. It's kind of like common wisdom, enhanced with some research, limited research that has been done, and we hope that more will be done into the future.
Thank you. I'll move to crossbench time, so I'll hand to Dr. Conn.
Thanks, Chair. Just to follow up one of the lines of questioning from the Chair, you've made a number of recommendations in this submission relating to medical education. They're provided by the colleges such as the Royal Australian College of GPs and the Australian College of Rural and Remote Medicine, and also about university curricula. Can you point us to any research or evidence that supports those recommendations beyond that testimony from an individual practitioner?
Sure, Deputy Chair. I think that question, to be useful to the committee, should be answered by Dr. Little as the medical expert from the Catholic Women's League, because I don't have that information for you today.
Sure. In your written submission, just to confirm my understanding, you've made a number of references to the determination of what's in the child's best interests, and have I understood correctly that it's your view that it's the birthing parent who should determine what's in a child's best interest?
No.
Okay, that's right. And then I've misunderstood that part of your submission. I also wanted to ask, you made a statement in your written submission, and I'm quoting, "No one has the right to have a child, whether they are heterosexual, homosexual or single by choice." How do you reconcile that with the World Health Organization position that individuals and couples have the right to decide the number, timing and spacing of their children, and that infertility can negate the realisation of these essential human rights?
Yeah, well, we're a Catholic faith-based group, and our religion teaches us a certain perspective in relation to the founding of a family. There's a deep need people have, a desire, I should say, to have a child, to love, but our faith teaches us that the best place for that to happen is within a marriage between a man and a woman, which is for life, that gives the child the security they need and the best, approach to flourishing. So we would disagree with that kind of wider view that anyone who desires a child should be assisted through the law to be able to achieve that end.
I'm sure that all members of the committee would agree with any individual's right to live their life according to their own religious beliefs, but the recommendation you're making to us is that the whole state of New South Wales should be governed based on Catholic beliefs?
Well, they're not just Catholic beliefs. As I've said before, there are beliefs that other people hold as well who are not faith-based groups.
I also wanted to pick up in your submission, you've written, quote, "It's a pity that the extraterritorial reach of the law for commercial surrogacy arrangements is not enforced against commissioning parents who willfully ignore the law. It's possible that seeing people put in jail or being subject to a significant financial penalty might function as a deterrent." So just to clarify that submission, we have received a number of submissions and we will be hearing as witnesses from parents of children born to commercial surrogacy arrangements who are happy, healthy, thriving, functioning families. Is it your recommendation to the committee that we recommend that those parents be thrown in jail?
I know it's a very strong statement to make, but I guess in terms of if we're abolitionists in our approach, we really do believe that surrogacy, whether it be altruistic or commercial, is against the best interest of the child and not good for society. If the law has made it, this legislation is extraterritorial reach, which enables, this is the lawmakers who have made this law, that there is a remedy for a breach of the law. Okay. We think the law should be, it should be actually, exercised. But that's something that's in the statute itself, and perhaps that would act as a deterrent for people not to do this. And it's so very extreme. I get that it's very extreme, and it hasn't been exercised. But it's all obviously with the discretion of those people who can prosecute that.
Yeah. So I'm specifically
examples.
asking about the practical implementation of the argument that you've made. You're arguing that it would be in the best interests of the children currently living in New South Wales in happy, healthy families for their parents to be incarcerated.
Well, I believe in the rule of law. That's what the rule provides, that if you breach the law, there's a serious penalty in relation to that. But I'm not a judge, and I don't prosecute these things, and discretion is exercised when those people who have that power decide to prosecute a particular case.
I'm aware from your submission and others that there are a number of jurisdictions that do ban commercial surrogacy altogether with various penalties. Is there ever any evidence you can point us to that those legal provisions actually improve safety or well-being of birthing parents or of the children born to those arrangements?
Well, no, I don't think I can point you to that, no.
Thank you.
So the opposition will take the rest of the crossbench time, so I'll go back to Ms Carter.
Actually, just a follow-up to that question from my colleague Dr. Conn. With respect, for example, to the prohibitions in place in Thailand and India, are you aware if they were introduced as a response to what was seen to be exploitative practices of Thai and Indian women?
Yeah, well, that's our understanding, that it's considered to be degrading, exploitative and coercive. Not something that is good for women who feel they don't have any other choice in order to
and because of the experiences
and the
in
experience
those countries,
of those women,
those governments chose
horrific.
to regulate.
Yeah, that are quite horrific.
Yeah.
Sets a standard in terms of the act of commercial surrogacy itself.
One of the arguments you're making is that an intrinsic problem with surrogacy is that it breaks the bond between the birth mother and the child, and you go through some evidence in relation to the experience of the child in utero and their familiarity with the birth mother. I wonder if you could highlight what out of that evidence you think demonstrates that there is, at the time of birth, an already established relationship between the birth mother and the child that will be severed by a surrogacy process.
Well, as we stated in our submission, there is research, limited of course, in relation to things like the microchimerism, where there is DNA from the child carried in the body of the mother for life as we understand it. It's also language and speech bonds, so that they have done some research, limited again, that relates to the fact that the child has been in utero for 9 months, has gotten used to aspects of the mother, such as her accent, for example, the sorts of food that she likes to eat, and the children have displayed after birth a preference for those sorts of things, as well as sleep patterns, which get regulated by the mother, as well as smells and tastes. So they're just very interesting findings that suggest that a bond has been created after 9 months at a very early stage of development that is then obviously clearly severed by the relinquishing of the child to the commissioning parents. We think that at least raises a concern in relation to it causing some type of psychological or developmental harm to the child. More needs to be known, of course. But if this is something that the lawmakers think is good, they probably should ensure that there is enough research to suggest that any harm is incredibly minimal or can be averted by some sort of practices or interventions in the future. We don't think that there is that evidence.
One of the key differences between commercial and altruistic surrogacy is that often but not always the altruistic surrogate remains part of that child's life, whereas commercial surrogacy, there's generally by design no ongoing relationship, especially the case if it's an overseas commercial surrogacy arrangement. Is it your understanding that there would be any different impact on a child if the birth mother continued to have some role in the child's life, or if the child was never to see the birth mother again?
Well, obviously, the intentions and motivations of the surrogate mother in altruistic surrogacy would be different to that of commercial surrogacy, but it doesn't change the nature of the act itself and the severing of it. The continued presence of the surrogate mother in the child's life, I guess it could cause confusion in relation to family relationships and what have you. It sort of sets a tone for how that is to be managed, and human nature being what it is. Whilst there may be stories of happy, healthy children and families born from a surrogacy arrangement, that has to go over the whole of the child's life. And again, one can use common wisdom to consider, conflicts and problems that might arise into the future that we don't maybe yet know of.
With respect to the welfare of the birth mother, you refer part of your submission to the fact that surrogacy puts the mother into a coerced position and coerced decision making. Why do you say that coercion is inherent in certainly commercial surrogacy arrangements?
Well, I guess the surrogacy arrangements for altruistic surrogacy, as I understand, are not enforceable. We're not at a point yet in society where an arrangement made before the conception of the child will be held to, where the child will be ripped from the mother's arms, so to speak.
So just to stop you there, is it possible to make a legal arrangement that whereby a surrogate woman would not be being coerced into giving her child up?
Yes, I think you probably could. But we would take the view that the informed consent is just a starting point for whether or not something is ethical, let alone whether it is lawful. And so we again start from that position that we don't think surrogacy is overall
What
good.
information would a birthing mother need to have to be able to give informed consent?
Well, this is a hard one because I guess we take the view, we take the view that we don't really want to give you recommendations of how to make things better because we're not sure that it can be made better, and so I'd only be guessing at hypothetical things into the future.
So why can't it be made better? What are the essential issues which means that we can't have a good commercial surrogacy arrangement?
Because at the end of the day, the act of surrogacy itself is, what would you call it?
Abusive to the mother, the birth mother. And,
yeah.
Is what, sorry?
Abusive to the birth mother, I would say.
So abusive to the birth mother because?
Because she carries a child for the 9-month span of pregnancy and then has no right and no connection with the child after birth. And would you say that that's understood in a commercial arrangement? Would she know that she wouldn't have any connection or relationship with the child after birth?
Yeah, so that'd probably put into the surrogacy arrangement, but all before conception has taken place, and then the bond is formed thereafter that. So
is it a fair summary to say that commercialisation of fertility is always likely to be coercive, and that women are being asked to make decisions about their fertility and their childbirthing before they have had the opportunity to form a relationship with the child they are carrying.
I think the experience itself of being pregnant and giving birth could change the views they had prior to entering into the agreement. And, you know, informed consent and coercion, the law has such a high threshold for when we consider something to be coercive. You know, a guns to your head, there's financial coercion. The goings on in people's mind and the different pressures that they have to do certain things we'll never really know about. Even the person themselves can be unaware of those things. But those agreements about how they will act into the future come before something very important, which is the conception and the carrying of the child, the birth of the child and the bond that is likely to be formed.
Okay, thank you.
Thank you. We'll move to government questions now. So, Mr. Donnelly.
Thank you, Chair, and thank you both for coming along. Appreciate the submission, thank you for it, and the way in which you've addressed the matter of altruistic surrogacy and commercial surrogacy, and express a position about opposition to surrogacy itself as a practice. With respect to the matter of commercial surrogacy, and this is not knowing what's in the future, but sort of just trying to understand what we have observed, you know, in the world at large. Are you aware of where, and you can take this on notice if you like, where one could go about finding a good range of examples of commercial surrogacy agreements to enable us to try and see firsthand what's in the agreements? Part of the problem I'm having with all of this is that commercial surrogacy is being, certainly through some submissions, pressed very strongly as a legislative reform in Australia, and of course that's on a state and territory basis because that's how surrogacy is regulated. But, and please take this on notice, you're not aware internationally or through some NGO or some other body where one can go to and see a range of surrogacy agreements to enable us as a committee to I guess look at them closely and see what's in them. Because the one thing that's exercising my mind in addition to what I've said is that a surrogacy agreement or contract essentially is a commercial arrangement. What I'm particularly concerned about is that what is the circumstance for the surrogate mother with respect to rights, and I'm not advocating support for commercial surrogacy, but as a matter of law, the issue of the rights that she would have beyond the birth of the surrogate child and the handing over the child to the commissioning parent or parents. Because my general understanding is that these surrogacy contracts contain provisions within them which are essentially almost commercial in their nature. But what happens, for example, if the woman has a physical or psychological injury or impact arranging from the surrogacy? What obligations do the commissioning parents have, for example, to the surrogate woman beyond the handing over of the surrogate child and, dare I say, the completion of the relevant paperwork? So it's a bit of an open-ended question, but trying to understand what's in commercial surrogacy agreements, where does one go to look for that?
Well, I know that if you simply go to the internet, you can find actual examples of surrogacy agreements. They mainly pertain to conditions and clauses for what happens during the pregnancy itself, and there's some pretty interesting clauses that people will agree to. But beyond that, after the child has been relinquished, I'm actually unaware of any continuing contractual provisions regarding payment, for example, of psychological counselling should the surrogate mother have an attachment to the child or any of those sorts of things. So maybe you could take that question on notice.
I mean, what strikes me is that beyond birth, it is not unknown that women, for example, could need and require certain surgery or treatment etc., strikes me that under a commercial arrangement, at least from what I can understand, that all falls to her. The contract effectively has been executed.
It would seem that way from what we've looked at on the internet in terms of standard surrogacy agreements. They do kind of end after there's been that relinquishment.
Can I just take you to your submission, and thank you for your submission on page number 6, and thereafter you specifically make reference to relevant national and international laws that impact on surrogacy arrangements in New South Wales. I'm wondering, is there anything within that particular section? So you're specifically referring to terms of reference number J, or J. Is there any particular aspects of this part of the submission you'd like to make any comment on? About the international treaties, obligations, etc., that Australia is a party to?
Yeah, certainly. Well, obviously we've mentioned the Convention on the Rights of the Child as being incredibly important and something that forms a basis for which there should be concern about surrogacy, both altruistic and commercial. There's also the Convention on the Rights of the Elimination of Discrimination Against Women. There's other conventions that relate to torture and inhuman conduct that is highlighted when people oppose surrogacy because of the nature of commercial surrogacy, its exploitative and coercive nature, and the evidence that is readily available regarding the experiences of women who have had horrible times in actually becoming surrogate mothers commercially. There are many countries that have banned commercial surrogacy outright, or it's a continuing conversation. I guess we would say that it's not something out of the blue that people would be concerned about commercial surrogacy, and there's always the courage to turn things around with further evidence and to look at things that are happening in other countries and evidence that they have of things that have happened there, to consider whether or not this is good for the people of New South Wales, to expand access to surrogacy by allowing something like commercial surrogacy and thinking that we can somehow do it better here in Australia than has been done in perhaps other countries considered to be third world countries.
If we could take you to the top of page 8, where you cite that the European Union, the Charter of Fundamental Rights of the European Union has banned commercial surrogacy, and then goes on to explain how that was done and the terms of that banning. I mean, is it your submission to the inquiry that in terms of consideration of going down the path or not with respect to commercial surrogacy, it is appropriate and indeed valuable for this committee to reflect on what has been done overseas with respect to the banning of commercial surrogacy?
Well, certainly a lot of effort obviously went into creating that particular ban from a number of European countries who were looking at what was happening in other countries and just considering the nature of surrogacy itself. And the New South Wales Parliament should obviously pay some attention to what is happening overseas when such a strong action such as prohibition has been taken.
And it would be the case that something like the Charter of Fundamental Rights of the European Union with respect to the banning of commercial surrogacy isn't itself animated by a religious ethos in terms of mandating a position with the way in which we deal with, or the proposed dealing of commercial surrogacy. The European Union isn't a religious body, is it?
No, it isn't. And we certainly came here today to speak about this issue in terms of common wisdom, and that's why we pointed out that there are actually other people, stakeholders who will be presenting before you who are not faith-based groups and who have the same view that we do about the concerns about surrogacy.
Perhaps just my final question, hand over to my colleague. Are there any other matters in your submission that you would like to particularly draw to our attention whilst you're here?
Well, maybe I just highlight again. I mentioned that my law students are doing an assignment on the Surrogacy Act and specifically about parentage orders, and we we've just been talking about in class, like statutory presumptions, and where they are rebutted by a clear and unambiguous language of the legislation. I think lawmakers should really consider Section 3 of the Act, which talks about the guiding principle being that in relation to surrogacy agreements, the best interests of the child are actually paramount. I think there's kind of two ways you can look at this. One way is to assume that Parliament has enough evidence to say that a child will never be harmed by a surrogacy agreement. The second way to look at it, and then I'd ask, well, what evidence do you have in relation to that to be so sure about that? The second way to look at it is that the surrogacy agreement predates the conception of the child, and maybe that clause is seen in the context of that. And if it's seen in the context of that, then when you're looking at the best interests of the child, it's in the context of there already being an elevated surrogacy agreement, and all you're looking at now is, well, the child's already in existence, they're already here, what are we going to do about that? That would suggest to me, if that were the correct interpretation, that Parliament, in clear and unambiguous language, intends to rebut the presumption against international law and against the fundamental rights of people. And that's a pretty big statement to make. I think it's ambiguous, and I think my law students would probably, taking everything into consideration, would look at the Convention on the Rights of the Child, for example, and say that can't be so. That you can't, not everyone can be a winner in this. If you're going to put the best interests of the child paramount, then the pre-existing surrogacy arrangement has to go lower down, and the best interests of the child have to rise. And that can only lead to a conclusion that you can't have surrogacy at all. And that would be our position. We don't think that we need to have all this research to prove that, because we come from a first premise-based position about the nature of that. And so that's why we don't come with any kind of recommendations to improve altruistic surrogacy. We just don't think you can improve something that in its nature is not good for the flourishing of society and the child in particular, and we would say the surrogate mother.
Look, I think, thank you very much for appearing and for your evidence and your very detailed submission. The questions that I had prepared were for Dr. Deidre Little, so I just wanted to clarify whether they're best given to you to take on notice, or if it's the case that I should perhaps put them to her separately if she'll appear at a different date.
Yes, I believe she is on the schedule to appear, okay. And as a medical doctor and an author of the federal version of our submissions, yes. I don't want to waste the committee's time by attempting to answer those questions where she has that expertise.
That's fine. I might keep them then.
Thank you.
I'll hand back to the chair. Thanks.
Well, there's still a minute and a half. Do you have any more questions, Greg? Or it's technically your time if you want.
Oh, thank you.
Yeah, sorry.
No.
You might get a quick one.
Just quickly, I just noted that in 2016, the Commonwealth Parliament, the House of Representatives Standing Committee on Social Policy and Legal Issues, produced a report, Surrogacy Matters, Inquiry into Regulatory and Legislative Aspects of International and Domestic Surrogacy Arrangements. And recommendation 1 says, the committee recommends that the practice of commercial surrogacy remains illegal in Australia. Can I invite you to take on notice your thoughts, unless you're able to provide them now, I'm not meant to put you on the spot, that this was essentially a decade ago or thereabouts, this inquiry, where there was this definitive clear position made by a committee, which, can I just say, was cross-party. So it wasn't a committee that was in any way biased, but a cross-party committee which made such a definitive statement. What I'm sort of exercising my mind about is what really has happened in a decade, that we've gone from a position of very clear no to the introduction of laws which would create commercial surrogacy as a legal practice in Australia, to a position where we've got various witnesses who are absolutely clear that this is the right way to proceed and the opponents should get out of the way. Happy to take it on notice if you want something.
What has changed in society over the last 10 years?
Well, yeah, your thoughts about that. And I don't want to, I mean, it's probably a bit of a complex question. You can take it on notice if you wish, but it just strikes me as a pretty major change where we're facing now very strong pressure from certain stakeholder groups to legalise commercial surrogacy?
I guess there's the experience of people actually going overseas to undertake commercial surrogacy and hearing their stories in the media. There's a lot of celebrities in various countries like the United States where they have commercial surrogacy that it's considered to be quite normalised over a period of time. And there are people who don't get married, who are single people who can't find someone to procreate with, and as I mentioned before, sterile couples, whether they be maybe older in age or they're same-sex couples that can't procreate on their own, who have that very natural desire to want to love something, and so that's probably where we're going here. But we would say that the federal government was correct 10 years ago that nothing has changed in terms of the nature of surrogacy that leads to that desire being met by legislation that permits this to be a legal right with obligations that flow from that.
Thank you.
Thank you. Well, that concludes our time with you today. Thank you for your appearance and for giving evidence. The Secretariat will be in touch just in relation to any questions on notice or supplementary questions that might come from the committee. But thank you for appearing.
Thank you.
Thank you very much.
Well, thank you for appearing. I'll just ask you to state your name, position, title, and swear either an oath or affirmation for the committee, please.
Dr. Cheryl Four, Friends Cog, a member representing the Royal College of Obstetricians and Gynecologists, and I'm a fertility specialist and subspecialist.
Excellent.
I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Excellent. Thank you for that, Dr. Fuller.
Thank you.
Would you like to make a short opening statement for the committee?
I guess thank you for inviting Ranscock to discuss and put forth this submission. We note that there's been a big, vast difference in terms of access to fertility treatment and reproductive care all across the board. There's a vast majority of rural and remote patients that are unable to access care. Mm-hmm. We commend the Senate to say that after telehealth, that's helped things a little bit in terms of being able to assess these couples, women, single women, as well as couples or women trying to start a family remotely. Mm-hmm. However, there's still a lack of access in terms of equity of care for them to access things like ultrasounds, blood tests, fertility treatments, or even surgery if need be, or even simple things like sperm analyses for the male partner in rural and remote regions. Mm-hmm. Secondly, there's a big wide dearth between publicly funded IVF and fertility services versus the private sector, and there are only 3 publicly funded clinics at the moment, of which have at least, where I work in RPA, there's about a 6-month wait list for people to access care. Mm-hmm. And as we all know, fertility is quite time sensitive, and a lot of these patients are even unaware of the provisions of that.
Mm-hmm. Thank you. So the committee's resolved to equally share the time between opposition, government and crossbench members. So we'll start with opposition questions, which is myself and Ms Carter, so I might kick off. I wanted to ask you, you talk a little bit in the submission just about declining birth rates and the impact that that's obviously having, it's a national conversation. But I suppose in terms of your expertise and experience, that demand for ART, are you seeing that grow, and what are some of the factors that are contributing to that in your experience?
in my experience, the demand for ART is growing rapidly due to the delay in childbearing for various reasons. Women or men might not feel ready. The current climate means that things are a little bit more unsure, and so people are trying to delay childbearing. The average age of first-time mothers in Australia at the moment, according to ACID, is more than 30, which is the oldest it's ever been. Also, there's been more babies born to mothers aged 40 and above than teenage moms for the first time since we've started to collect data. So that's all really important to suggest that childbearing as a sort of overall choice is being pushed back. With looking at ART, if you look at post-COVID numbers, the number of patients accessing treatment has skyrocketed, both from fertility preservation in the form of egg or sperm or embryo freezing, as well as ART for infertility treatments. This stems from a variety of things, potentially people deciding to start their families a bit later, increasing medical issues, for example, women having troubles like cancer diagnoses when they're younger, autoimmune conditions, more severe medical conditions that mean that they cannot fall pregnant at the time of their choosing and have to defer it to a later time. And also things like more diverse, like LGBTQI patients that are trying to access things like donor sperm, donor eggs, or as we heard before from this previous submission about surrogacy and how difficult it is, thereby pushing their choices back.
And the issues around the geographical access, and I don't know, you may or may not have been watching this morning, but we heard from Health and also from Westmead as well. And I live in a rural community, so just conscious of that extra barrier, I guess, to access that sort of fertility and reproductive health care. One of the things that has come up has been effectively if we had more publicly funded services, maybe satellite clinics, that would help people. Do you have a view, I guess, on behalf of RANZCOG, what do you think would be any barriers to sort of expanding public access? Is it just funding? Is it workforce capabilities? Where are the gaps that you see that need to be addressed?
It's exactly what you mentioned. So it's the funding as well as workforce capability due to the amount of training needed. But in terms of satellite clinics, from what I understand, the furthest lab, and in ART you need clinicians, so doctors, nursing staff, you need the ability to do blood tests and ultrasounds. You also need a place in which to perform the procedures, for example, an egg collection, a sperm retrieval. Then you also need the incubator or the lab, which then starts to add on to the complexities of being able to have a mobile clinic, like you can, for example, Breast Screen New South Wales. And so satellite clinics where you might, say, have public offerings at various rural remote locations so that patients can present there. For example, like I know a lot of cancer patients, they go and have remote clinics over there, see patients there, so they offer them a comprehensive workup. They could have a mobile sperm assessment portal, blood tests and ultrasounds perhaps at the same time to allow for patients to get into the system. And then their only travel may be, hopefully with IPTAS coverage, for the actual procedure for IVF or whatever other fertility treatment they might need.
And that's obviously come through, and I think your submission very strongly supports increased investment in those publicly run clinics, which I agree with. I also was interested, we heard earlier, again it was from the doctors from Westmead, but about some of the sort of the less invasive procedures that people could potentially have rather than going to IVF. And effectively their evidence was, because there is the subsidy available for IVF, sometimes patients will go down that route rather than maybe exploring sort of less invasive measures first. Is that something that you have seen in your sort of clinical practice as well? Do you think there's scope for improvement in other offerings in this space rather than IVF on its own?
I think there definitely is, and apparently especially so with rural remote patients because of the lack of the timeliness of things like getting a blood result back, getting sperm result back. They might be living a few hours away, so we can only get them in on this specific day. And in terms of overall logistics, sometimes it might be safer for the patient in which to move on to, say, IVF versus something else that might be more suitable but might take a little bit longer. But due to access to care, safety and ability to get results back in a timely fashion, that might be limited.
And then just one more and then I'll hand over to my colleague. Just back to that sort of concept of rural and regional offerings, satellite clinics. And I suppose I would like to understand from RANZCOG's perspective, the training that would be needed in some of those rural and regional communities, and obviously, there's a vast difference between, an Albury or a Hay or, Gunnedah to Brewarrina, or, different communities have different sort of clinical levels of capability even now. So would there be things that you could recommend, and I'm happy if you need to take it on notice, around what sort of clinical supports there might need to be for existing health staff, or training mechanisms to help the provision of these services more broadly?
I'll take that on notice back to RANZCOG, but there are already some satellite clinics, for example, in Tamworth and in Double, that are run currently, not publicly, but privately funded ones. So there is no reason to see why the local staff can't be upskilled in those initial assessments to try and help patients get into that system so that it can be assessed in a more timely fashion.
Yeah, okay. Thank you. I'll hand to Ms. Carr.
Yeah. Actually, just a follow-up in relation to that. We've heard in other settings that there are issues with the availability of obstetric services across the regions, and women often have very limited choices about giving birth and support. Is this an example of a greater problem, which is that we don't have appropriate obstetric services available equally across New South Wales?
I think this stems from that because it's the start of an obstetric journey, because the aim for patients in which accessing fertility care is to get pregnant, and so after they get pregnant, then they need to then move on to that service. So I agree, yes, it's a greater problem in terms of funding and how best it is that we get qualified obstetricians to go work in those areas.
Any ideas how we get qualified obstetricians to work?
Starting with
trying for a long time. It's been a problem.
I'm happy for you to take that on notice.
Definitely.
So, thank you. I note in your submission that you indicated that Westmead and the Royal frequently reach capacity, but we heard from Westmead earlier that they have capacity. I'm just wondering, is there an issue about patchiness of funding that means that Westmead has capacity where other places don't, or do you have any comment about that?
So I work publicly at Royal Prince Alfred Hospital, which is a third publicly funded unit, and so I can only speak for that unit. The problem is the flow of funding through the system because of the public health system. It's great access. I've got lots of patients. I actually just get the GPs from Wagga to email directly to my health email because it's easier that way. However, the funding happens at the level of the hospital executive. And by the time it filters down, there's always a bit of a delay in terms of timing of ability to employ more staff, the appropriate number of staff. Staff that have left or have taken long service leave aren't always sort of backfilled in a timely fashion, and that leads to this 6-month delay. So if I saw someone in my clinic tomorrow, they can't start IVF till October in the public system, which is a problem.
And is that, did I understand you correctly, that is an issue with lack of autonomy in the units to decide staffing and funding?
And in terms of how quickly we can process, for example, putting out an ad for a nurse or several nurses that we might need, to hiring them, to them starting on the floor.
And could that be addressed by a different model which gave directors of units more autonomy? Is that the appropriate level?
Possibly, because I think Westmead runs slightly differently to Randwick and RPA, which is why they've got a little bit more capacity because they're a little bit more autonomous under a public setting.
Okay. Is that because of their link with the University of Sydney?
Correct.
Right. Okay. Thank you. And the last question I have, we've had evidence from a medical practitioner that a number of women and doctors are not educated with respect to understanding a female menstrual and fertility cycle. Just wondering if you had a comment on how much education, for example, just reflecting on your own experience, you received through medical school and through your specialist training in relation to understanding natural patterns of fertility and how they can be maximised and assisted.
I agree with that previous clinician in that it's very poorly taught fertility, especially the decline in women's fertility due to egg quality and quantity. I see even in obstetrician and gynecology trainees, my own trainees, that they have a very poor depth or breadth of knowledge about this. And so I've gave a talk, for example, to the urology trainees, and a lot of female urology trainees were horrified at the rapid decline in female fertility past the age of 35. So I think that much like what we did for contraception in schools before, fertility awareness and education is very important, because there's a lot of sort of people within medicine and more so in the general population that are unaware of age and fertility, and they think that being healthy will be able to overcome the biology of women's ovaries. Sadly, it does not.
Can I, it follows on from that actually, but just, and I guess more broadly, not just for sort of the training for doctors and clinicians, but just for general population. I guess in your experience, more information for people about what they should be aware of with their own fertility, and then do you think there needs to be more education around things like endometriosis, around male infertility and some of the
all
issues
of the
there?
above.
How would the committee sort of best recommend changes in that space in your view?
I think it's a public awareness campaign needs to start from the ground up in order to inform teenagers and younger adults about their fertility. It's not something that's taboo anymore. We need to talk about it. There are many options available now for everybody, depending on where their interests lie. And I think it's really important.
Yeah. And I guess just sort of as part of that as well, I'm interested in, and we don't talk about it a lot, but the male infertility part of things. And I know a lot of women potentially, this is a bit anecdotal from friendship groups and the like, but get to certain ages and think about egg freezing or what they should be doing. And obviously there are appropriate conversations to have on an individual basis with their own doctors and support. But I guess the awareness around male infertility, do you think that there is enough done in that space? Do you think men generally understand sort of the role that they play, which is quite important?
I don't think so, and I think that more needs to be done as well, because again, things like the incidence of testicular cancers and all these things are going up as well. So I think even more so, men also need to be educated about their fertility.
Yeah, okay. And then I guess in terms of, you talk about, I think you actually call them ART deserts in the submission, but the need to do that. Do you think it would be sufficient if government of any persuasion but said, we want to invest in this, we're going to open more clinics, that it's better to be associated sort of with a university like Westmead is, with the University of Sydney? Are they things that can be done in their own right, noting that obviously some of the private clinics do offer more services than just metro areas? Is there a preferred model, I guess, of delivery?
I'll take that on notice.
Okay.
I don't think there's a preferred model, but I just think that access is important.
Yeah.
And I think in terms of equity to access, it's financially, physically, and emotionally challenging anybody accessing fertility analysis, evaluation, and treatment. So I think that if you could partner with a university and making sure that outcomes and financial sort of outcomes are tied together, that's probably going to be the safest for patients moving forward.
Thank you. I'll hand now to Dr. Con.
Thanks, Chair. Thanks for being here this morning and for your submission, and I note the real focus that the college has taken on equity and equitable provision. You made a specific recommendation that the government should prioritise direct investment in ART services and structural reform over increasing rebates.
Yep.
Could you talk us through the rationale for that recommendation?
So the direct access means that there will actually be people and patients in rural and remote communities that can access treatment and care. Increasing rebates, while in the past seems to have been helpful, has not actually helped in terms of moving provision of care to the areas of need. It's only just raised prices in the metropolitan areas, sadly.
Thank you. You also made a recommendation about improving access and outcomes for First Nations and culturally and linguistically diverse communities, and I hope the committee will separately speak to representatives of those communities, but could you talk us through what that might look like in practice, or what types of initiatives we should consider?
So things like close the gap for our rural and Indigenous population, so things are covered in terms of medication costs and everything, and also being able to offer treatments to these various communities will be important so that they can actually access it, because a lot of them refuse to travel out of their homes and areas, and it's very tricky if they're needing fertility care.
There was an earlier discussion with one of the service providers about opportunities to provide satellite clinics to support rural and remote communities, and there was also a discussion around perhaps a minimum volume of patients that would be required to sustain a service in terms of its quality and safety, and the experience of the practitioners. There's obviously laboratory technicians and other types of experts involved, not only obstetrician gynecologists, but from an obstetrician gynecology perspective, is there a view on kind of a minimum number of procedures that would need to be undertaken per year for a service to be safe or sustainable?
I'll take that on notice because we do have GPs that are versed in fertility procedures that are doing it currently. So we do have a framework for that as part of RANZCOG.
Terrific. Thank you. Appreciate that answer on notice. I also wanted to just clarify something in your written submission. It referred to 4 clinics.
Yeah, it's only 3.
Thank you.
Yeah.
So it was a typo.
Yes.
That's all right. I wanted to know what the 4th clinic was.
Yeah, no, so did I actually.
And finally, I just wanted to ask about, there's been a discussion at a federal level last year about expanding the definition of infertility.
Yeah, it's already been accepted.
My question was, did the college have a view on that?
Yeah,
how
we've
does the
ratified
college...
that. Yeah.
Okay, so you support the new definition?
Yes, and the New South Wales rebate for fertility testing has also adopted that in their new. So it's really good to see.
Terrific. Thank you. Thanks, Jen.
That's all? Okay. I will take a couple more and then we'll hand over to the government. Your submission talks a bit about some of the, I guess, challenges with private equity investment in ART clinics and obviously the sort of privately funded ones. And I know there's been quite a few issues that have been reported publicly over the course of the last sort of 12 months or so in relation to some of those challenges. But I was interested where you say that the college asserts that the presence of affordable alternatives would compel high cost private clinics to improve their quality or reduce fees. Can you just speak to that a little bit more, I guess, presuming that if you have more service availability, then that would compel the private operators to lift their standard, but why you think that's necessary as well?
I'm not sure, like standards is lifting their standards more so to try and close the gap between the publicly funded clinics cost point as well as the private clinics.
Okay.
Yeah.
Okay,
correct.
so it's more about cost than quality.
Yes, because again, most IVF clinics have to report their success rates to yourivfsuccess.com.
Yep.
And that's the other thing in our submission is that we think that all clinics should do that for it's transparent. For transparency for patients to be able to access to see a clinic's performance.
Yeah, okay. And in terms of that data provision, do you think there's, other than obviously making sure everybody provides it, do you think there's gaps in what data is publicly available that should be improved?
I'll take that on notice for now.
Okay, thank you. Did you have any more, Ms. Carter?
No, I don't.
No? Well, I'll hand over to the government then, if you're ready.
Chair?
Yep.
Yeah, thank you. Thanks so much for appearing today
that's
and for your evidence so far. I wanted to ask, in your submission, and it was touched on earlier by my colleagues, you emphasise your preference for, you acknowledge rather that increasing rebates is unlikely to address the underlying equity issues, and show a strong, obviously, support for the expansion of the publicly funded clinics. I just wanted to delve a bit more into the rebates, if I can. Are you aware of any evidence to suggest that in practice the provision of rebates has led to an increase in people being able to access IVF or otherwise, or is it the case that really we can't test that?
I think it's tricky to test it, but I can say that from anecdotally, when the New South Wales rebate came in before it was means tested, that allowed for a lot more people to access fertility treatment in a more timely fashion versus waiting for the lower cost options in the public clinics.
And with the means tested sort of option, are you aware of, we heard earlier from Health in terms of the number of people that have accessed that rebate, in terms of the pricing that providers are charging, are you aware of any sort of correlation between an increase in pricing at the time of that rebate?
No, there has been no increase over their normal CPI increases, if that's what you're asking.
Okay.
Yeah.
And do you have any visibility over what the current gap is between, say, the amount charged by these low-cost providers and
So low cost providers out of pocket range anywhere from about $1,000 to about $2,500 per IVF stimulated cycle. So that's when women go through injections, egg collection, etc. And in a private clinic, it could be anywhere from $6,000 to $8,000, depending on health fund coverage.
Oh, and that's okay. So depending on health fund coverage, all right.
Yeah.
So that's quite a significant difference.
Correct. It is, and that's why that rebate. It's sad that the means tested got brought in, but that's why that additional rebate for the first cycle in the private sector was very helpful.
In terms of the expansion of access, I wanted to ask in terms of the GP training, is it the college provides training to GPs or?
No, the GPs can opt to do additional training via the college.
And what is involved in that additional training?
I'll take that on notice, but I think we've got a list of, they've got different modules that they have to go through, but I'll take that on notice.
Yep.
And we can provide you with more information.
That would be helpful. Are you aware of whether or not that is something GPs have to fund themselves or?
They have to fund it themselves.
They have to fund it themselves, so that's presumably an extra barrier to access. Is there any sort of evaluation of that training or,
No.
in practice?
Not once they've got the
Okay.
qualification, if that makes sense.
Has there been, have you noticed any increase in GPs looking towards that training or opting into that training, or has it been sort of a
Pretty
static
much the
figure?
same.
Yeah, okay.
Yeah.
Would having more GPs trained in this area, do you think that would assist to complement the existing model of?
I think in rural and remote communities, yes. In metropolitan Sydney, probably not so much.
Okay, all right. I might just pass to my colleague while I gather my thoughts in terms of next questions.
Today, and thank you for the submission. With respect to the matter of the surrogacy treatment practices and procedures, can you provide, if you're able to do so, an overview of where that's undertaken? We had some evidence earlier today from the Westmead Fertility Centre that they don't deal with applicants with respect to surrogacy. But it's obviously undertaken in other facilities.
Correct.
Are you able to give an overview of where they're likely to be undertaken?
They're usually undertaken in the private fertility clinics at Royal Prince Alfred Hospital, where I work currently as well. We do not offer surrogacy arrangements because we do not have the capacity from a legal, counselling and medical standpoint to do that, because we've got to go to the ethics committee and etc. Currently, though, it's under the ALRC, so Australian Law Reform Commission has a separate review on the surrogacy process in Australia, and that's going concurrently on the other. Yeah.
So, okay, so that's clear. So the actual surrogacy, call it service.
Yes.
Describe it that way.
Yep.
That would require other aspects of, dare I use the term, due diligence that would need to be undertaken to enable that to be actual.
Yes.
And with respect to the private providers that are in fact providing such services, do you have any insight into those at all, those services, or?
A little bit. So from what I know, from what I gather, most private IVF facilities would offer surrogacy. So as part of
there's various in the marketplace,
Correct.
large ones through to not so large, and
Correct.
it's probably likely that they would.
Correct.
Yeah.
So the framework, so I work privately in a private clinic, the framework is that if someone seeks surrogacy for medically indicated reason, then there's various steps in which we have to tick off before they're allowed to proceed with treatment and before it gets approved by the ethics committee at a minimum. They also have to organise their own independent legal advice, and the surrogate and the commissioning parents have to undergo mandatory counselling.
If I can press you a little bit further to the extent you're able to help in my understanding, with respect to the legal advice,
yes,
that's something that is put to the commissioning
couple
surrogate, that this is something that she should go and obtain? Is that how it's presented?
Has to obtain, yes.
Has to obtain.
Yeah. And Stephen Page will speak more about that this afternoon, but yes, they have to have legal.
And with respect to that legal advice, once a request's been made and the commissioning surrogate comes back and says, I've obtained legal advice, that's accepted or that needs to be established that it's been done?
That has to be established. Yeah. So both the commissioning parents and the surrogate both have to obtain independent legal advice.
And with respect to the surrogacy arrangement, we don't have commercial surrogacy in New South Wales. No. We have what's referred to as altruistic surrogacy. In terms of obligations, requirements that the commissioning parents seek of the commissioned surrogate, are they usually put in writing?
Usually, yes.
And they are in a document which I presume is called a surrogacy contract or agreement between the commissioning parent or parents and the actual commissioned surrogate. Those arrangements are examples of templates of those arrangements available somewhere to be obtained to have a look at? To see what's in them?
Taken on notice, but Stephen Page would be a better person to ask about those templates.
Anyway, if you could take that on notice, that'd be great. Yeah. Thank you.
There's some more. There's actually, that's only the start of government time now because we didn't. But there's more time if anyone has any more questions. But I've got one if we're just freewheeling.
Just a couple. Yeah. Sorry. Thank you. Thank you, Chair. Just on the and your submission is very valuable, and thank you for it. Go to the top of page 2 of your submission, the cost consideration. So, for-profit business has really entered this, I'll use the word industry, ART industry, is that a reasonable term to use, in quite a significant way, over a period of time, of course. Do you have any percentages that you can provide or on notice obtain about the relative number of treatments undertaken by patient or client with the for-profit businesses vis-a-vis the ones that are like...
Yeah, I'll take that on notice, but we can provide that.
Yeah.
Yeah.
That information, is that available somewhere, or that's...
available.
Where would one, just out of interest, where would one go looking for that?
I'll take on notice, but you can look at it as part of NZARD, which is published by the University of New South Wales.
Right.
Yeah.
Okay. I might just leave it there, Chair.
Yeah, sure. I just have one more, and then we might finish a little early, which is fine. You talk a little bit in the submission, and Dr. Con mentioned this earlier too, but I guess the experience for First Nations and cold communities in this space, and the submission talks about how there's limited representation of cold populations in fertility research and how that contributes to sort of gaps in understanding. Why is that the case, do you think, that there's those gaps in the research?
I think it's very difficult to engage sort of First Nations and cold communities, and we don't really have a good provision, nor do we have a spokesperson to allow them to come across to understand what we're trying to help to improve their access and experience in their fertility journeys in general. And so that's why I think it's really important to also look into that space. Yeah, and do you think that the committee could or should be making some recommendations around, and particularly making sure that it's culturally safe and appropriate for access, but also for research to help better inform the access issues as well? Definitely. For example, like I know for obstetrics that we routinely have Aboriginal midwives and etc. and cold midwives. There is in the fertility space is quite a lack of these resources. Yeah. No, thank you. That's great. All right. Has anyone got any?
I just have a final one, Chair. Sorry, thank you. In terms of the alternate ART options, we heard earlier from Westmead Fertility Centre this morning around think there were two other options that they suggested being included within the low-cost funding model, which is currently only for IVF. They were, I think, ovulation stimulation and another one.
IUI?
Sorry?
Intrauterine insemination?
Yes, that's right, yeah. Were there any others, and do you support that as a general view?
Yes, we support that because that's part of the fertility treatment sort of arsenal that we have, and not everybody requires ART. It's a bit like fertility preservation in the setting of pre-cancer treatments for my younger patients. It's really important that all of that gets included as well, because that might be their only chance of preserving their fertility at that time, after which they might go into something like early menopause.
Yep. And so it's the case that currently when you're seeing a woman that is not currently available to them, but that you may or otherwise have recommended, or they will have to fund that themselves.
Correct,
is that
the
right?
funding, but the funding will still be slightly lower than, for example,
The privately
IVF.
run
Correct,
clinics.
IVF, you see. So,
Okay.
yeah.
Okay.
So in and of itself, it is a barrier, but not as great a barrier as IVF treatment, if that makes sense.
Sure, yeah, that does make sense, thank you. In terms of the cost, are you able to provide us on notice what the cost of those other treatments currently are for the service?
In the public clinics?
Yes.
Yeah,
Yeah.
on notice, yeah.
Because that would be very interesting for us to know. And the other thing is whether there are other treatments that also ought to be considered that are currently available. This is an area where, the research and technology is evolving very fast. So whether there are other methods that you would like in your arsenal, so to speak.
Those are the three main funded treatment options that we would think would make sense to go to be funded, yeah.
Yep, okay.
But we'll take on notice because, yes, we can give you a cost
Thank
for
you.
each option.
Thank you.
And can you, this is just my ignorance or my interest maybe is a better way to put it, but just the difference between, for a patient with IVF or IUI, I think was the other acronym, what does that look like for them in practice, I suppose? Because we hear about it being less invasive. But
So I guess taking a step back, just if a patient comes across and if, for example, they're trying to get pregnant, there could be various issues leading to their delay in fertility. If someone is having problems releasing an egg every month, that's something called ovulation dysfunction, in which they could have too many eggs, for example, polycystic ovarian syndrome. They could have a problem with their brain signals that lead to their ovaries being shut down and not releasing an egg. Then they could benefit, sort of other factors aside, assuming sperm's normal and their anatomy is good, that they could benefit from something like ovulation induction, whereby they either take medications for 5 days in the month, or little tiny injections to override the brain signals, in which to then make the ovaries work in a natural form again if possible. And then they either have intercourse at home to get pregnant, or sometimes they have what's called intrauterine insemination. Very technical terms of turkey basting, where we prepare the sperm in the lab and insert the sperm into the womb to try and get it closer to where it needs to get to, which is down to the tubes, to the eggs. And that optimizes their natural fertility if there was an issue with sperm movement or with egg release. In terms of what a patient looks like from a logistical sort of impact on their life, because don't forget, people are working at this stage. We're working. You don't have the time for me to ring you at lunch and say, hey, Cheryl, your blood tests show that you're not quite ready. Can you please come back on Friday?
yeah.
Nobody likes to take that phone call when they're at work. And so what happens is with those treatments, there's usually a lot less blood tests and ultrasounds included in them. Side effects are also a lot less and the risks are lower. With IVF, we are overriding the brain signals altogether, and women need about 10 to 14 days in total of usually 2 injections to stimulate or grow as many eggs as possible within both ovaries. So this is why people have horrific side effects. They sort of can't travel overseas. They might need to take more time off work. There's more intense monitoring for this phase, so they have more blood tests and ultrasounds, which then usually only happens in the morning because we need the blood results to be back by the afternoon, which then limits remote and rural patients as to when we can get their results back. And then they have to go through what's called an egg collection, which is day surgery. It takes about half an hour, where eggs are retrieved from the ovary with a little needle. Following that, eggs and sperm are then incubated together in the laboratory and grown over a few days before implanting it back into the woman's uterus.
Thank you. It's just good to get the technical expertise on the record for the committee and for those of us who are not medical like myself. But thank you. That's very very useful. Just checking that there's no more last ones. No? Okay, great. Well, thank you so much, Dr. Fool, for being here today. You did take some questions on notice. There might be some supplementary questions from the committee, so the Secretariat will be in touch. But thank you for appearing. Thank you. No, it was great. Thank you so much.
Thanks, Doctor.
Okay, so we'll now break for lunch, 6 minutes early, and we will resume the hearing at 1:30 p.m. Excellent. Thanks, everyone.
Thank you.
Thank you.
Well, welcome back, everybody. We've now moving to hear evidence from the Health Services Union, so thank you for being here, Ms Marshall. Could you just begin by stating your name, your position title, and then swearing either an oath or an affirmation, please?
Sure. So my name's Kate Marshall. I'm the National Senior Assistant Secretary at the Health Services Union. And I've got an oath here. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Would you like to begin by making a short opening statement?
Absolutely. Thank you. Firstly, I'd like to thank you for the opportunity to appear before the committee today. I welcome the chance to address the relevant terms of reference, mainly the current supports for individuals and families, economic impacts of reproductive health challenges, and the barriers that impede access to fertility support and assisted reproductive treatment in New South Wales. As stated before, I appear on behalf of the Health Services Union, and our members see daily the significant impacts that reproductive health conditions and fertility challenges have on workers' well-beings, their families, and their capacity to participate fully in the workforce. At present, the supports available to them are inadequate. Employees are currently required to rely on personal or annual leave to manage reproductive health-related absences. There is no dedicated entitlement for those undergoing fertility treatment, including assisted reproductive technologies, nor for those managing chronic reproductive health conditions such as endometriosis, polycystic ovary syndrome, or other conditions that impact severely on fertility. The HSU submits that New South Wales should consider introducing 12 days paid reproductive health leave annually. This entitlement is based on expert medical advice and aligns with the nature of many reproductive health conditions. It would allow individuals to manage symptoms such as severe bleeding, pain, cysts, endometriosis flare-ups, and would support those undergoing fertility treatments who often require multiple appointments and recovery periods. This is especially so for those people living in regional Australia who may need up to a day to travel to specialist appointments. We also submit that flexible work arrangements and reasonable adjustments should be made available to workers experiencing reproductive health issues. Small adjustments to hours, duties, locations can significantly reduce the need for additional leave and supports continuing workforce participation. Reproductive health challenges affect a substantial proportion of the population. 1 in 10 women have endometriosis. 1 in 6 couples experience fertility issues. 1 in 4 men over 40 undergo vasectomies. These are mainstream workplace issues. Other jurisdictions have already acted. Both Queensland and Victoria now provide paid reproductive health leave to public sector workers. New South Wales now has an exciting opportunity to align with these developments and provide equitable support to its own workforce. To assess the economic implications, the HSU, together with Queensland Council of Unions and also Aware Super, have commissioned Bankwest Curtin Economic Centre to do some research about what this would actually cost the Australian economy. Their findings are compelling. Reproductive health conditions result in $21.3 billion in lost productivity nationally every year. By contrast, the average direct cost of reproductive health leave is $296 per worker per year, reduced to $140 after efficiency savings. This means the cost of implementing the entitlement is nearly 10 times lower than the productivity losses it seeks to address. Among HSU members in New South Wales, 80% consider this leave important, and nearly 50% said that they would use it or would have used it had it been available to them when they were going through fertility trials. In summary, the introduction of 12 days of paid reproductive leave would support individuals undergoing fertility and reproductive health treatment, improve productivity and workforce retention, enhance workplace equality, and provide a meaningful, evidence-based entitlements for workers across the state. Thank you once again for the opportunity to address the committee, and I welcome any questions.
Thank you. So the committee's resolved that we will separate the time equally between opposition, crossbench and government members, starting with opposition. So I might just ask a couple and then I'll hand over to Ms Carter. Thank you for your submission, and it's a really important point of evidence to hear from you, particularly around the need for reproductive leave. I just was interested, obviously the survey of your members was very high, almost 80% of people said that it was important. I guess in terms of how often this issue is raised amongst your members, is it something that is, those data points would suggest it's very important, but is this a regular or frequent topic of conversation amongst your members in terms of the leave? Yeah.
It is a frequent topic of conversation, and it wasn't till we actually sort of started surveying about this in about 2020 that the stories, both good and horror stories, started flowing out about how important this actually is. Since that 2020 time where we started the conversation about it, we have heard multiple workplaces have now got it in their enterprise agreements before the Victorian government and the Queensland government implemented it. Since then, we've been hearing such wonderful stories back saying that they have been able to be more open with their employer, they have been able to address their fertility treatments, a lot of conditions like endometriosis that they knew that there was a problem, but they weren't actually getting help because it was always on the back burner because everyone was always too busy. They now actually have time carved out for them that they're able to go and seek the treatment that they need. The other thing that we heard, which was quite heartbreaking, was quite a few of our members have come to me in particular, but also our New South Wales office, and have said that they've had to forego fertility treatment. So they've exhausted all their annual leave, their long service leave, their personal leave. There was nothing further for them to do, and it was because of those workplace challenges that they actually stopped fertility treatment, and they don't have a family. They have come and said, it would have been wonderful to have had access to this. 12 days isn't going to change the world. I'm under no illusion that it's going to, fix everything. But I think that having a dedicated leave for these purposes alone would really help, not only allow people to get to appointments, that would also help break down that stigma with employers. People are able to be more open with their employers about what their challenges they're facing, and that then also allows employers to plan for the future as well.
Do you find, and it's more anecdotal, I guess, than anything else, but I was at a conference last year in the UK, and they were talking some of the changes they're making over there around different types of leave, and it was more with miscarriage leave, but that there is some concern sometimes from employees not wanting to be so visible in terms of their fertility journey, particularly with their employer as well. So I guess my question is, if it was something that was quite general in terms of the reproductive health leave, as you said in your opening statement, that can cover a whole range of different issues, whether it's endo, whether it's male infertility or vasectomy. Do you think having that broader definition maybe removes some of the stigma or concern for people to seek that sort of leave?
100%, and that was the feedback we got. That's why we titled it reproductive health leave for that reason. However, we've also found that if people had needed to access it, they have been willing to be more open with their employer as well. Understand that there is miscarriage leave available in some jurisdictions as well. But I suppose having that banner of reproductive health leave allows them not only to deal with that miscarriage, but also any other fertility or surgeries or procedures that they need after that miscarriage.
Great. Do you have questions?
Yeah, just a couple. Thank you for being here. I'm just wondering if you've got any data on how commonly it is that somebody will have exhausted all of their sick leave and then need the extra 12 days reproductive health leave.
So I can only talk on behalf of our members. I don't think the Bankwest survey didn't go, research didn't go into that. So for our members, for those undergoing specifically IVF or assisted reproductive treatment, almost 100%.
Yeah,
exercise. And I can speak from my own personal experience. I've got lived experience in this. I had a miscarriage, which then had complications afterwards. So that was a good 6 weeks off work. Then I had 2.5 years of IVF. And then after that, I thankfully had a twin pregnancy, but had to then, before I got all cleared at that 6-week mark to be cleared to go see an obstetrician, I had checks every single week, sometimes twice weekly, to ensure it was all going okay. I had a very good employer and I didn't think twice about it. I didn't need to take any personal or annual leave. And I didn't realise how lucky I was until I spoke to some of our members out there who either had to quit their jobs or forgo family. And for me, that's where I became very passionate about this issue. It shouldn't be a matter of choosing between a job and a family. We should be able to find a way to support both.
I note that on the list of, you've got things, for example, like vasectomies, which I assume is a one-off, not an annual occurrence, and unlikely to need 12 days every year. So I just wonder whether it's possible to be a bit more specific about for whom this leave is intended or available.
Yeah, so for us, when we went into this, we really, females' fertility, we see also has a big impact on men as well. So whether it be their role in the fertility journey, whether that be, either getting a vasectomy or a reversal, or whether that be going to an IVF clinic and partaking in the fertility journey that way. But it also, for us, goes a way to supporting their partner as well. I think we've got stats here that, a typical IVF cycle requires 6 to 8 visits. So that's consultations, ultrasound, blood tests, stimulation monitoring, egg retrieval procedures, embryo transfers and pregnancy scans. But they also then saw that with not only themselves, the person going through those treatments, but also their partner, there was a 47% of people who experienced depression. And more concerning, 1 in 10 experienced suicidal thoughts while going through that. So we thought by making it all inclusive and allowing men to also access reproductive health leave.
Can I just clarify? You're saying that your figures show 1 in 10 people going through IVF experience suicidal thoughts?
Yes.
Wow.
Yeah.
That's the first time I've heard that. Yeah, thank you. Yeah.
Dr. Khan?
Thank you. Thanks. Thanks so much for being here today and sharing your own experiences with us as well as those of your members. You already talked a bit about your members who've made reproductive choices based on their workplace requirements, which is compelling. I'm also interested in the question of presenteeism. Your members are obviously employed in the health system and are performing a really critical role for people who need health care. I can only imagine that someone who's been to an appointment where they've received distressing news or going through this very deeply personal health care, promptly having to come back to work, I imagine they wouldn't perform as well, and I'm wondering if that's something that you've looked at.
100%. So again, from personal experience, after I had my miscarriage, I showed up to work because I didn't want to let anyone down, plus I was at that period where you don't tell anyone what you're going through. So I came back to work very quickly and I hemorrhaged at work and had to go back to hospital. And that is the reason why we're saying that we need to allow the time to heal or to get further treatment. Presenteeism is huge. So that actually accounts for a huge amount of that $21.3 billion loss that we're seeing in productivity at the moment. It's not so much that people are skipping work or, are putting in for personal leave. It's people who are actually showing up to work, but who are in huge amounts of pain or are going through anxiety, depression, whatever it may be, and are not actually being productive in the workplace. So presenteeism contributes to a mass amount of that $21.3 billion loss that we're seeing right now in Australia.
Thanks. And just circling back to something that the chair was asking you about, I'm interested in this question of kind of privacy and disclosure.
Yes.
And in your written submission, you've talked about existing reproductive health leave that's offered to public sector workers in Queensland and Victoria,
Yes.
and how that operates in practice. What are employees required to disclose? Is it just enough to say, I need reproductive health leave?
Yes, so what we've seen is a medical certificate, and it just says that, Kate Marshall is suffering a reproductive health condition and will need X amount of time off work. We're finding that employers are finding that quite satisfactory. However, in speaking to employers, we're actually finding that the conversation of actually sitting down with an employee and them saying, I need reproductive health leave, that stigma, as I said before, has been broken down, and the employer is actually getting more information voluntarily from that employee because they feel safe in asking for that leave because it's an entitlement. But it's also allowing them to have a proper conversation about what the next 3, 6, 12 months might look like, and allowing the employer to be able to plan around any absences.
Thanks. And I think you've led nicely into my next question, which was just in terms of that Victorian and Queensland experience. How well is that being implemented on the ground? Are people who are entitled to access that reproductive health leave receiving it in practice?
Yes, so those who are asking for it are receiving it, so it is working in practice. We're actually seeing a very similar parallel to when family and domestic violence leave was introduced. A lot of people probably should be asking for it and yet are not. So we're hoping that the message gets through that they are able to ask for it, that there has been no retribution for anyone that I know of that has asked for it. They've all received it. We're hoping as it becomes more commonplace in workplaces that stigma will continue to be broken down. But in saying that, as I said before, a lot of people are saying, well, the sky will fall in. Businesses can't afford this. Businesses are already paying for it. It's the cost to implement it, as I said before, is $140 per worker per year, and that is if every single worker in that workplace takes that leave, which they're not. So the sky's not going to fall in. We can't see corporations going bankrupt over the introduction of this leave. We're hoping it actually retains people in the workforce for longer, especially women. We don't want to see women leaving the workforce when they don't have to, and that then just widens not only the pay gap but the superannuation pay gap, which then feeds on to their what happens after they retire. Do they have enough money to retire? Is there more reliance on government pensions? We see this as an empowering entitlement that will allow women to take control over their fertility and allow them to plan around IVF cycles and plan to get time away from work, but it also allows them control over their employment as well when they leave. They're not forced out early because of fertility issues.
I understand this is something that yourselves and other unions have been talking about for some time,
yes.
Well before today. So I imagine that this has already been pitched to the New South Wales government before today. What kind of response have you received from?
I personally haven't pitched it, so I'm not 100% sure on the answer to that. I'd have to go back to the New South Wales branch and check on that. But I know that our New South Wales branch has been very successful in getting this entitlement in agreements, which has been fantastic. So it is getting out there here. I'm not sure of any conversations directly with government around this in New South Wales.
And just so coming back to those other jurisdictions, it sounds like from your previous answers there's probably a need for additional education for employees and employers about it. But are there any other particular lessons from that implementation journey, if this were to be rolled out in New South Wales, to learn from those other jurisdictions?
I know in Victoria that there has been some education around, particularly around sensitivities of what, how far is too far in asking what reproductive health ailments that people actually have. But on the whole, the education rollout has been pretty straightforward. There's been nothing too complex. Payroll went through a similar education process as they did through family and domestic violence leave. So it's all basically around that sensitivity, being open to the communication, So it was basically almost identical training, obviously very different subject matter, but similar training to the family and domestic violence leave rollout.
And one last quick one from me before I think we've got to government time. Your survey results, which were very helpful, thank you. Can you tell us how many people participated in that survey?
Yes, so that was about 660 from memory.
Thank you.
Thank you. Government time?
Thanks, Chair. Just at the outset, obviously, just for the record, I'm a member of the HSU, as you all know.
I'll allow it.
Very proud member. Thank you, Kate, for your submission and for appearing today. You mentioned the experience in Queensland and Victoria. I just wanted to check for Victoria, how many days of reproductive health leave is it there?
10.
10 days also.
Yeah.
And is there any data available that you're aware of on the take-up of that leave or anything, or is it still too soon?
I think it's still too soon. So we have asked that of Victoria just last week, actually, and they said that they're still getting all the data. It's also feeding into the gender equity data as well. So we're awaiting that information. Yeah. So they don't have it as yet, but they said that they will pass that on as soon as they're able to get it.
Thank you. In terms of some of the evidence we heard earlier today in the committee, which I don't expect you to be across, it was sort of stated that some of the low-cost clinics that we have available here in New South Wales, the costs of accessing them can range up to about $2,000, and private clinics are in the order of between $6,000 and $8,000. Does that sort of align with your experience?
Yeah. Yeah.
And in terms of that figure, in particular the $6,000 to $8,000, when you look at the membership of the HSU and the sort of the workers, that you represent, is that something that is affordable for them?
No, it's not. It's not affordable. Our members nationally are over 80% female, and they can be on anywhere between 40 and 50K up to I think the norm's sort of 80, 90. So when you're looking at repeat IVF cycles that hit, they can go up to 10 grand. And unless you've been formally diagnosed with something, if it's unexplained fertility, it's questionable whether you'll get a rebate back. So again, through my own personal experience, if I got a diagnosis or something and then I was eligible to get 50% of that money back, if you don't have that diagnosis, then they may not be able to get that rebate, which is more out-of-pocket expenses.
So when you're looking at the lower cost clinics that we have available, really for people that are on lower incomes, like your members, they would probably be, if not the only option, really.
100%.
Yeah. We heard earlier about just sort of the merit of them, and some of the voices in support of, I suppose, expanding that model. Is that something that you would also support, these sorts of low-cost centres?
Yes, 100%, especially in regional places around the state as well. We hear some horror stories of women having to catch light aircraft to a major city and then having to catch trains to wherever, and that is a full, day, sometimes 2 days, stay the night, go back, and to have to do 6 to 8 appointments every IVF cycle. That is a lot of extra money in flights, accommodation, and time away from work simply because of where you live.
Yeah. And presumably you have members that work in some of these private for-profit clinics also.
Yes.
Your membership extends to there. I'm interested in what their experience is of working in these clinics, if you have any feedback from members and delegates.
So the only feedback we've got is from Melbourne IVF.
Yep.
The staff there are incredibly supportive of this. They have said that they have seen quite a few patients going through distress when cycles haven't worked, but it's not through not only through the failure of a cycle, but it's also I have to go again. How can I afford to go again? And the rate of psychology appointments are going up, but again, at a private clinic, that is again an extra cost, which means that again, it's not going to be available to everyone, which feeds into that that number I said before, which I think was 47% experiencing quite severe depression.
Yeah. And so when you say they're supportive of it, they're supportive of the introduction of
the leave,
reproductive health.
Yes.
And you mentioned also the New South Wales branch have managed to get this entitlement in some agreements.
Yes.
Are you able to let us know, whether it's on notice or otherwise, what those are and how successful that they have been?
I can take that on notice and get a list. Yes, absolutely.
Okay.
I should just qualify my answer earlier in your... Victoria did start off at 5 days, and it's increased to 10.
Okay. Thank you for also including in the submission some of the like the lived experience stories from workers and delegates about the impact on them. In terms of the research, now just turning to that, I was interested in the survey that said 65% of respondents with reproductive health issues did not tell their manager because they were concerned about stigma. Is this something that you think, regardless of the introduction of the leave, we are still going to have to do some work to overcome that?
Yes.
Is there anything that you can suggest?
I think it goes back to the point that that was made previously around further education. There really needs to be... we can learn from what we've done in family and domestic violence leave and the education and the breaking down of that stigma. We've still got a long way to go there, but I think we can learn of what has been learnt there and carry that over into this topic. I think, we do need education, but we also need people to be open about their stories in order to educate people as well.
And just finally, the research also cites, in terms of public perception, fewer than 8% of the survey respondents believing that reproductive health leave would lead to higher company costs. So clearly, without even looking at some of the economic modelling that you've done, which shows it's actually a significant saving, businesses don't think this is going to be, at least cost isn't the deterrent. So what is, do you think?
So cost is certainly the first thing that came up when it's a nice sort of veil, I suppose, for some corporations to hide behind. When we've come to them and said this is the costing, the sky's not going to fall in, it's going to be okay. They then turn to the fact that it's a privacy issue. It might be uncomfortable for people to talk about their reproductive health challenges. And my question to that is, well, uncomfortable for who? Because they're already in either a lot of pain, discomfort, anxious state. You're not getting any productivity from them. If we're able to sit down and have an honest conversation about what is going on, you're going to have a more productive employee who is able to go and get the help, the assistance that they need. We just see this as a win-win for both the employer and the employee.
Thanks, Jo.
Thank you. Okay, that brings our time to an end. Thank you so much for appearing and also for sharing your personal experience, and I'm sorry for your loss, and it was very important for us to hear from you today, so thank you for being here.
Thank you so much for having me.
I think you took something on notice. There may also be some supplementary questions from the committee, so the Secretariat staff will be in touch with you in relation to those. But
Thank you
thank
so
you for
much.
appearing. Thank you. All three of you for being here today. We're just going to start beginning with the witness on my left. For each of you just to state your name, your position title, and then to swear either an oath or an affirmation for the committee, please. So, yep.
Hi, my name is Sarah Adinger. I'm Senior Research Officer at the University of Sydney in the Faculty of Medicine and Health and in the Law School. I'll do the affirmation.
Mm-hmm.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hi, I'm Professor Wendy Lipworth. I'm a Professor of Bioethics at Macquarie University in the discipline of philosophy and co-director of the Macquarie University Ethics and Agency Research Centre. And I'll do an affirmation as well. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hello, it's Dr. Mariam Naksh-Najad. I'm a Senior Research Fellow at the Centre for Health Economics and Evaluation at the University of Technology, Sydney.
Mm-hmm.
And here's my affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Excellent. Now open to any or all of you to make a short opening statement if you would like.
Sure. Do you want to go
Start
first?
with
Sure.
Yep, sure.
First, thank you, Chair, and members of the committee for giving me the opportunity to appear today and give evidence on this important inquiry. My research focuses on intersection of health, labor markets, and gender inequality. I also have lived experience of IVF and infertility myself that has deepened my understanding of the challenges faced by those going through this process. My submission to the inquiry draws on a major research study I conducted with Dr. Fabio Martinelli using population-level linked administrative data covering more than 120,000 Australian women initiating IVF between 2011 to 2021. Mm-hmm. Our study is the first of its kind in Australia and globally to quantify the hidden economic cost of IVF at the population level. Our findings reveal three things the committee should be aware of. First of all, infertility imposes a substantial mental health burden. Women who remain childless after initiating IVF experience significant and persistent declines in mental health. Prescription medications used for mental health conditions rose by up to 30% within 2 years of starting treatment relative to pre-treatment period, and these remained elevated up to at least 5 years. This is how long our study allows us to follow these women, and not the meaning that it's fine afterwards. Second, IVF carries real economic costs that go well beyond out-of-pocket medical expenses. Women who remain childless after IVF experience annual income declines of around 14% relative to their pre-treatment earning. These women did not have children to have the so-called child penalty. They still had declines in their income. This means that the treatment process itself independent of whether it results in parenthood, generates measurable economic impact. Third, the true cost burden of IVF is significantly underestimated. Beyond the approximately, within our data, 2,000 per cycle in direct out-of-pocket cost, women face lost earnings, increased mental health service utilization, and long-term career disruptions. These hidden costs are borne disproportionately by women and are not currently recognized in policy settings. On the basis of this evidence, I urge the committee to consider 4 areas for action. 1. Recognize infertility as a health shock with economic consequences, not simply a medical issue. 2. Strengthen financial protections and improve equity of access, particularly for low-income families who face the highest barriers. 3. Introduce workplace protections for people undergoing IVF, such as IVF leave, flexible scheduling, and protections against career disadvantage during treatment. 4. Integrate accessible, publicly funded mental health support into IVF treatment pathways, especially for those who remain unsuccessful following the process. I'm happy to take questions from the committee and provide further details. Thank you so much for having me.
Thank you. Hi. Thank you to the Chair and Committee for this opportunity to present. We'll be talking about another major research study that was funded by the National Health and Medical Research Council between 2020 and 2022, so going back a few years now. This was on the other end of the spectrum in terms of methodology to what you just heard about. It was a qualitative study, primarily doing in-depth interviews with professionals and consumers undergoing IVF or considering undergoing. The project was large. We had a team of 10 chief investigators, 7 associate investigators, and a range of research assistants and postdocs. And I'd just like to emphasise that the evidence we're giving today is given on our own behalf only. We haven't agreed with everybody about everything and won't agree. So we're just speaking on our own behalf today. We did interviews, theoretical work, and a scoping review of existing literature. Our main interest was in commercialisation of healthcare and corporatisation of healthcare and the kinds of effects that has. And in a way, assisted reproductive technology was a case study for that phenomenon rather than being the primary reason for doing that work. But it ended up being a very interesting and sort of troubling case study in many ways. In terms of our findings, participants definitely told us some positive things about the impacts of commercialisation on assisted reproductive technology. So at least for people in metropolitan areas, there was a view that access and choice were facilitated by the existence of commercial clinics, obviously partly because there is no public alternative at the moment, really. But there was a sense that people could choose what models of care they wanted and where they wanted to go and who they wanted their doctors to be and so on. There was a view that there were consistently high technical standards across the system, and that the commercial clinics were supportive of clinical and technological innovation. On the other hand, though, participants did tell us about high and rising costs, both to themselves and to government, as a result of the current models. The access that some participants told us about were obviously not shared by those with lower incomes and those living in rural and regional areas. In terms of the actual quality of care, there were concerns about the adequacy of informed consent, around the evidence base for treatment, and also around the costs of treatment. So people didn't always feel like they really knew what they were getting into financially. There were some concerns about some of the care models being distorted by incentives and disincentives that clinics have, and a sense that in some cases care was over-protocolized. So people sometimes described feeling like they were a number in a system that churns a lot of patients through. So those were kind of the main, that's a snapshot of both the positives and the negatives that people told us about, and we'd be happy to take any questions you have.
Fantastic.
Yeah.
Thank you. Thank you for those submissions. And Dr. Nagashnajad, thank you for sharing your personal experience in with the committee as well. So we have resolved that we're going to equally split the time, and I think you've been here, so you've probably seen. We're going to do 2 rounds with you, though, because we've got an hour, so about sort of 10 minutes, and then we'll go again. So we'll start with opposition questions, and I'll hand to my colleague, Ms. Carter.
Thank you all for being here, and thank you for sharing your research with us. It's really appreciated. Dr. Nagashnajad, if I could start with you, I'm interested with your comments in relation to the policy implications with respect to the mental health impact of treatment and going forward. Are there specialist mental health practitioners who are skilled and trained to assist primarily women, but I assume also men, or is this an area we need to develop?
I want to emphasize I'm not a mental health specialist. I'm not a psychologist. I can just tell you what we have found, which is these declines in mental health and persistent increase in reliance on mental health services and prescriptions. What I can add here from when I work with patients within infertility community, whether through my own experience and then also as a researcher, is often the clinics are not well prepared. It's more ticking a box to offering a counseling service rather than a well-integrated service. However, there are, of course, psychologists out there that one can pursue through their own private initiation to get help. I do believe there are out there. I don't know whether they're adequate or not. Okay, that's not my expertise. But what I can tell you is what it is right now is certainly far from what these women need. And especially, at least from what we can see, those who are consistently unsuccessful going through the system.
I wanted to ask you about that, and I don't know whether you're able to comment, but based on your research, the persisting mental health issues for women in particular, and I presume also their partners who go through this process and are unable to conceive. Do you have any recommendations, or are there people that you can point to who may help us? It just seems, just from human understanding, that if one's entire focus for a period of 4 or 5 years is on conception and that is not possible, that of course is going to have a toll. Are there different ways we could structure the fertility process so it was more measured, more supported, less intensive, and this might have better mental health outcomes for that group of women?
Absolutely. I do think giving and this is not coming again from this research. This is coming from the experiences and talks that I've had with other patients. I believe if patients knew more about the realities of IVF, what are the potential outcomes are at the get-go, and those would have been explained to them maybe in more detail. Potentially that could help, but this is not something I'm an expert at. But I can only suggest that the current situation is not helping women.
Perhaps Professor Upworth, you might have a comment about that. I know your research suggested women felt cogs in a health machine. Is there a need for greater education about a range of possibilities, and that might lead to greater patient autonomy?
I think so. I think the issue of consent was one that comes up very frequently in our work, and there was a sense among some participants that they just weren't prepared for what was ahead of them, and to some extent that's the nature of healthcare. People are often told, given a lot of information, but you can't convey the intensity of experiences, particularly those that involve hope and grief and are ongoing. But people did seem to suggest that they were nonetheless surprised, both about the likelihood of success, the the need for ongoing cycles, and also the costs on top of that, which were often for treatments that are referred to as add-ons, which are non-evidence-based interventions. Well, that's an oversimplification. There might be evidence for them in some populations.
Can you give us an example of what an add-on is?
So there are a whole range of interventions that are added on. It's not a very technical term. Added on to standard IVF cycles, and they can happen at different stages. So they can be done.
What would be an example of one?
Embryo glue, for example, to try and get the embryo to stick to the lining of the uterus. Various imaging techniques to try and choose the best embryo. So they're things that happen in the lab and things that happen in the clinic. Giving additional hormones on top of the standard hormonal treatment. Right. There are quite a few of them, and that's a big area of inquiry. So that can often add unexpected costs because, of course, those are not covered or reimbursed by Medicare. So they're those kinds of surprises that people get along the way. So I agree. I mean, to the extent that you can prepare and inform people, that would be a worthwhile thing to do.
And is that sort of push for add-ons, and perhaps Ms. Adinger, you've got a comment on this, is that what you were referring to in your submission when you talked about commodifying patient vulnerability?
That's one of the ways in which that can happen. People are in extremely vulnerable position when they undertake this process. And when a doctor says, we have this thing, it's very difficult then for a patient to say, no, actually, I don't want it because I don't think the evidence is strong enough. Just the mere mention of it can be very compelling. That is in turn exacerbated by the fact that clinics advertise these add-ons as part of their marketing. So people hear about them, then the person might actually ask for them. So they're in a very vulnerable position, and wouldn't suggest for a moment that that's always being commodified or exploited, but that is certainly something that can be. And Sarah might want to.
You mentioned there of marketing. Is this an area of medicine which is open to more direct to consumer marketing than other areas of medicine, and is that good or bad?
I can't comment on the statistics around that, but you certainly do see quite intensive advertising on the back of buses and so on when you're driving around, and so yes, there is the clinics do market quite heavily. I don't know if Sarah's got any more detail about that.
I don't have any sort of comparative statistical evidence similar to what Wendy said.
But we don't see cardiologists advertising on the back of buses, do we?
Yeah,
that's true. Or oncologists.
And is this marketing beneficial in the sense that it provides more information to potential patients, or does it drive this exploitation of vulnerability that you've pulled out?
I'd say both, probably. It certainly raises awareness, and come along to our discussion about egg freezing, which we're holding at a restaurant or whatever. People may not have known that was an option, and in some senses that's only a good thing. But then people will go to the websites and see a suite of interventions offered, and so I think it's a double-edged sword.
Thank you.
Dr. Cohen?
Thanks so much for coming to share your research and expertise with us today. I'm interested in the study on commercial influences first, particularly noting the challenges you would have had methodologically, that there are so many private for-profit clinics and so few that are publicly funded or not-for-profit clinics, whether you were able to make any comparisons between those two models. Was there any difference in responses from people working in the
We really
public
can't
clinics?
say. With qualitative research, it's always difficult, and it's not really our goal to make those sorts of comparisons because we just don't have the numbers. But as you say, we really can't say. That's based on our study.
Okay. I wanted to ask about one of your findings in your written submission that was fairly horrifying for me as a practitioner, which was the example you provided about the code of conduct requiring doctors to act in the best interests of the company, which struck me as actually potentially counter to their legal and ethical obligations as practitioners to their patients. You gave that one example of one provider, but can you speak further to that finding? Was that widespread?
Sarah, do you want to talk about that?
I can speak to that. So the reason that we were mentioned that particular example is because Monash IVF, as a public company, has more publicly available documents. So they have they've published their code of conduct, so we were able to access it. But a lot of the other clinics aren't structured that way and don't have as much public information. So we can't say whether or not they have the same internal code of conduct similar to Monash IVF.
Thank you. One of your potential recommendations was around increased regulation, particularly of those commercial or corporate models. I suppose one of the things that the committee would consider is a further rollout or public funding of those not-for-profit or public models. Do you think that regulation can actually fix these issues completely if we were to persist with providing rebates to these commercialised services?
Sorry, could I just clarify? Are you asking can regulation manage some of the issues that we've raised, or more public services manage the issues, or both?
I'm asking both. Yeah. So could regulation manage these issues, and if so, what regulation? And then separately, would it be a better approach to just move to a public model?
That's a good question. Do you want to answer?
Yeah, I don't know the answer to that. Just going on what our participants told us, there was no clear pattern in terms of everybody suggesting one particular regulatory response or replacing a private system with public system. It seems to be more that we need to come at it from a number of different directions and maybe increase public offerings without necessarily losing the benefits that people do recognise come with having commercially provided care as well. That's really just going on what people told us. I don't think we really came to a conclusion in that regard.
I think it also depends on what particular issue we might be talking about. So the example of having a code of conduct that at least appears to create a sort of conflict of interest between a clinician whose obligations are to their patient and patient care, and then the sort of environment in which they're working, that probably could be dealt with a particular kind of regulatory response, whether legislative or some other form of licensing condition. But there might be other issues that require different approaches.
I also wanted to ask, you gave this example of some of these clinics using typologies to categorise patients, which isn't something I've come across before. Can you explain that?
That was one of our more abstract findings. I'll just go to that because I haven't... It was really, I honestly, this was a theoretically interesting paper. What we found was that when we analysed the data, the clinicians we spoke to categorised patients into different groups, like, for example, the misinformed patient or the hopeful patient or the demanding patient. And this isn't something that's you would expect would be unique to IVF. I guess this is something we all do when we're trying to sort the world into categories. And we just thought that was an interesting finding because it might then lead clinicians to treat patients in different ways depending on how they're perceived. So, yeah, that was what that was about.
That's interesting.
Yeah.
And the clinicians who described that to you, was there any commentary around sort of that approach as opposed to sort of the patient-centred care approach that most practitioners are trained in?
I'd have to take that on notice and go back to that particular element of the data, and that we do have a paper on that which we can provide. Yeah.
Thank you.
Yeah.
Thank you. I'd be very interested. The last thing I wanted to ask in my last couple of minutes was this question of informed consent and financial consent. You sort of summarised that to say that those processes were often inadequate. Can you talk through what your findings were in that space?
So, as I said, people were often had a sense of having been surprised or not adequately informed either about their likelihood of success or about the costs. So one of the things we then did was, in relation to costs, we did some theoretical legal work, which Sarah can talk to, trying to explore whether the notion of informed consent could be transferred across to information about costs, so whether our ethical and legal understandings of medical informed consent could be applied to costs. And I might let Sarah summarise the conclusion that largely she came to in that regard. It was very interesting work. Yeah.
So as Wendy said, we did find among the participants in our qualitative research that there was a lot of difficulty with understanding costs, and patients feel like they had been adequately communicated with or understood what costs would be, the way that they were structured and presented to them, and how they might accumulate over time. In terms of fitting that into our sort of existing frameworks of legal informed consent and ethical informed consent, cost sort of is quite challenging because I got the sense that it can be quite difficult it can be quite a difficult thing to talk about within the doctor-patient relationship. And costs can be quite personalised in IVF treatment because of the nature of treatment. So I think it's also something that doctors sometimes felt like they were not particularly knowledgeable about themselves. In sort of the approach of just importing costs into the informed consent sort of paradigm, it doesn't seem like it would neatly fit. It might require more resources, maybe more structure and standardisation in how it's performed, and more tools and resources for patients and for clinicians in clinics.
It's my understanding that there is a regulatory framework for disclosure of costs and financial consent for patients. I suppose is the finding that framework is inadequate and needs changing, or that framework isn't being implemented?
I don't know that I can answer that. I don't know that people were so specific, but for whatever reason, people were still telling us that they don't feel that they are adequately informed.
Thank you.
Yeah. Move to government questions.
Thanks, Chair. Thank you. Thank you to both of you for appearing today. I might start or continue with questions to Professor Lipworth and Ms. Addinger, if that's all right. You mentioned, I think, is it Addinger or Addinger?
Addinger.
Addinger, sorry, my apologies. Addinger, that you're unable to see the code of conduct sort of documents for other fertility clinics, but that was available for Monash. In terms of the market share for these sorts of companies, your submission also states that there is 3 large groups that have a combined market share of about 80%. I'm presuming Monash is one of those. Who are the other 2?
The other 2 are Virtus Health and Genea that were included in that information that we presented.
So there is a limit to what publicly available information you can find for Virtus Health and Genea?
Yes.
Yeah. But there is more information available for Monash?
Slightly more, depending on what kind of information you are looking for.
Is there anything that governs or regulates what these companies are required to publish and make available, to your knowledge?
I don't know the answer to that.
I do know that there are, across the sector, there is some data that is collected by, I believe it's ANZI. Yes. But that applies to all clinics across Australia. In terms of the kind of information that might be made public by something like Monash, that is a public kind of company, versus Genea, which is private. Most of those that are requirements would be more to do with company annual reports to shareholders, and information that those companies deem sort of relevant to put in those kinds of documents.
Yeah. We know what company annual reports are usually look like. So, yeah. Okay. I'm also interested in your submission, you talk about all of the different taxonomies in the fertility industry, which was quite fascinating to read, just the sort of the broad gamut of different things involved in the industry. But I'm particularly interested in 2. So one of those was, you mentioned special financing agencies. for example, superannuation access brokers for Australia. How common is that in the industry that people are accessing their superannuation to fund IVF treatment?
I think one of the tricky things is that we don't know. We did see that there are a few brokers available to Australians. I'm not sure if there is data, if people are accessing it presumably through the ATO, then there might be data there, but it was not something that we collected.
But there are brokers, so one would imagine that means that the service exists if there are brokers for such.
It does, yeah.
It's a
If you
reasonable
walk into
conclusion.
an IVF clinic, you might see a brochure saying, talk to us about how to access your superannuation. I've seen that personally. So I don't know how common it is, but you do see that.
It's very concerning. Yeah. The other one was the complementary and an alternative medicine, so fertility naturopaths. What is the evidence base for these sorts of things? I imagine that's another sort of add-on. Is there an evidence base for this sort of treatment, or?
It would depend on the specific treatment, and I would say it would likely be quite low. Otherwise, it would be part of conventional treatment if there was an evidence base for it. So that's my personal view on most complementary medicine. So it's probably low.
And concierge agencies. When you think of a concierge, is that sort of a navigator to assist you through the process, presumably at an additional cost again? Is that what that is?
The concierge agencies that we mentioned in the article were particularly relevant because we wrote this research with UK colleagues, and they were seeing the concierge services in the UK as a newer clinic structure where a sort of third party would receive the patients and then divert to clinicians. I'm not sure if those structures are available in Australia.
Okay. I might move now to Dr. Mariam Najad. Sorry. Your submission talks about, in terms of recommendations, recognising infertility as a health shock. Can you explain a bit more about what that would involve and why that's important?
Yeah. So when we talk about health shocks or important health events, we think about, for example, heart attacks or cancer. And these all have profound influences in individuals' life. We all know that an individual going through cancer may have loss of income, may have detachment from labor force, may need an extended leave, and might have inability to return to work, or may have difficulty and mental health issues beyond just the treatment of the disease. So when we talk about it as a health shock, it means it's kind of has a profound impact on an individual's life. And what we find in our research is infertility similarly has impacts beyond just the treatment of IVF itself. It doesn't, when we are thinking about how it impacts an individual's life, it's not just about the time that they have to go to those 6 to 8 appointments that was mentioned before. It's beyond that. It impacts how they define perhaps themselves. It impacts them long term in terms of their mental health, especially if they leave IVF unsuccessfully. And also what we see is that regardless of the outcomes, whether they conceive or not, going through IVF impacts the career trajectory of women. So what we can see this in raw data, we can see this after our econometrics analysis, which we are comparing women that go through IVF kind of before and after the treatment initiation, comparing them with themselves, let's say, had they not gone through this treatment. And we do see that they have, on average, an annual income loss of about 14%. Again, we are not able to say if this is just because they are taking unpaid leave, maybe, because there is not enough leave available. Yeah. But it could also be that it's it's consistent with the mental health loss we are seeing. So maybe because of those, they're not able to progress in their career the same as if they had not incurred or faced infertility, and so on. And that's kind of the basis for that recommendation to be recognized infertility as something that impacts individuals beyond just, receiving an acute treatment.
Yeah, there you go. Yeah.
Sorry.
Oh, that's
our
the
time,
back to
but
us now.
yeah.
Yeah, you guys you'll get another 10 minutes, but yeah.
You go first next. I'm sorry, Greg.
Yeah. Thank you. Okay, it's my turn now. Thank you for the evidence so far. Just continuing on that point. I'm interested in your submission the sort of economic impacts, and obviously you talk about the 14% for people who go through, women who go through IVF, but also in one of the recommendations or the policy implications is a financial protection and equity of access, and stronger public support, particularly for low-income families, to help mitigate those inequities. Just wondered if you could talk to that a little bit more and what your research found, particularly for lower-income families.
So what I could say is that, what we find on average, because we're looking here on averages,
yes,
we find that in 2012 dollars, which, those numbers should be considered in that respect, is on average, the out-of-pocket cost of one cycle of IVF around $2,000. So if you want to think about what that means for an individual and for a family, it means quite a lot, a world of difference between a family that for an individual with income of 50,000 or 150,000, right? So those barriers are a lot more meaningful when we consider the context or where the bases are, who is accessing them and who is having to incur them. I wish I would have done this research already to look at, because I potentially could do this, to look at the numbers that they do draw from their superannuation. We do have that in our data, but unfortunately I don't have those numbers.
Maybe you could take it on notice.
Yeah, I could take it on notice and come back.
I could take that on notice.
That'd be great.
I can tell you from, however, from the infertility groups that I have seen, the numbers of women that talk about accessing their super is astonishing.
Yeah.
And it is offered by the clinics as sometimes as a suggestion, that this way you can, and I find that problematic, as we know, women are already behind in their superannuation, and adding this, especially at such a young age, would have
absolutely,
a big loss for their retirement. Yes.
And do you think, and this is probably more broadly with your work, but we've had some evidence earlier talking about some of the challenges, I guess, and it's been kind of a national conversation around declining birth rates and what we need to do to help support, I guess, people on their journey to become parents and families. And so the economic argument, I think, is quite sound for government to invest in things like IVF and support, because we know that the birth rates are declining, but also there's the personal economic impacts for families who go through it as well. So would that be in line with what your research shows very simply, that more investment in low-fee public provision of these sort of services is a better economic outcome for everybody?
Absolutely, 100%.
Yeah. Okay. And I'll just have a couple if I can. I might direct it to you, Professor Lipworth, but I'm happy for Ms Addinger to answer as well. I'm also very grateful for the table that you put in the submission that came from one of your papers. It was very good to have it spelled out so articulately, so thank you very much. I'm interested in the regulatory frameworks part, and one of your dot points, you say that clinicians noted that competitions between clinics may discourage disclosure of adverse events. Now, obviously, there's been a few high-profile issues in Australia in recent months, but I just wondered if you could talk to that a little bit more about, I guess, why, I'm paraphrasing, but competition might then lead to kind of less transparency for the industry more broadly.
Yeah, I think I might ask Sarah to help with this one as well, but what we were trying to get at there is that it's bad for business, basically, to declare adverse events. Nobody in any even in public health care likes to disclose adverse events, but it's an expectation. So we just, I think that's pretty much what we meant. But Sarah, did you want to add anything to that?
Yeah, I think it's just observing the disincentive to disclose adverse events in a competitive provider landscape, and a sense that there should be oversight of adverse events somewhere.
Yeah, so some sort of, well, there should be public reporting of those sort of things. Okay. And then also in the part where you talk about access to ART, and we sort of you've touched on this a little bit, but just in terms of the impact for regional patients, limited service options, clinical options as well, the idea, I guess, to have provision of more public clinics, but with a bigger geographical spread, I guess, from particularly the individuals that you worked with in your research, would that be something that you think would be well received in the community? Yeah.
I think if it was feasible and you could get the right people with the appropriate expertise and facilities that they need, I would certainly say on the basis of our data that people would appreciate that. They talk not only about the lack of access to services, but I think, as you've heard from other people today that I've listened to, the costs of taking time off work and time away from children to go to appointments is a major issue for people. It is very disruptive to their lives. And telehealth has helped somewhat, but it obviously can't help with the procedural aspects of this particular kind of intervention. So I can't see any reason that it wouldn't be well received, whether it was affordable commercial services or public services. I don't think, I can't really comment on which of those would be better or whether some combination would be ideal. One thing that our participants told us, though, was that they had a sense that commercial clinics would be more likely perhaps to close on a whim if it wasn't looking good for them commercially to be in a particular area, whereas perhaps a public service might be driven to exist more by equity concerns in the first place rather than by commercial concerns. So there might be greater stability if it was provided by publics, but I didn't get the sense that there was a particular preference for one or the other.
Okay. And I was also interested where you speak about the clinic aesthetics and, you know, pastoral brandings and spa-like environments, but how that alienates patients who don't think that they sort of conform. I just found that really interesting. Is there more that you could elaborate on in relation to that?
So again, that was one of our more theoretical papers where we had our sociologist colleagues working on that one, and they drew on Foucault and all sorts of, you know, wonderful areas of scholarship. I know, it's a little bit beyond me as well, to be honest. But it did. They were getting at the sort of pink aesthetic that you might find in some IVF clinic, and that could potentially transform the environment into something that feels nice but is ultimately very consumer-oriented, and may potentially blur the boundary between commerce and medicine. The fact that it doesn't look like a clinic might give the people the impression that they aren't actually engaging in a medical encounter. And depending on your view, that could be a good thing or a bad thing. Some people take the view very strongly that most people seeking IVF are young, otherwise healthy people who are perfectly capable of being informed and acting like an informed consumer would, and so the aesthetic experience is appropriate in that context. Other people take a different view, which is that actually, no, it's very important to remember that these are people with medical problems who are in a very vulnerable position and are seeking medical care, and that maybe if that gets obscured by this very consumer-oriented aesthetic, that could be a problem.
Yeah, so, it's interesting. Very interesting. Dr. Conn?
Thanks. I wanted to come back to the mental health and financial impact on the individuals. I think you've talked already about the figure you had of women losing up to 14% of annual earnings. In the written submission, it says at the peak of treatment-related disruption, and I'm wondering if you, in your research or in your hypothesis about the long-term impact of that, does that compound over someone's career?
So as what we can see is what the data allows us to see in terms of the length. That's why we have written at the peak because we're only able to follow up to 3 years in that particular analysis, which is, quite, limited in a way. And we do see that persistency across those 3 years. However, those are also the time that they are going through IVF. In our raw data that we can follow for longer, we do see that trajectory of income has changed up to, I think there we are seeing it up to 6 years. However, the 14% is coming from the 3 years analysis, and that's what I wanted to emphasize.
Okay, thank you for clarifying that. Would it be reasonable to assume that the long-term economic impact would be much greater than that?
I would think so, in a sense that, when we are talking about foregone, let's say, promotion, etc., these things usually have lingering impacts, right, in terms of trajectory of one's career.
Thanks. In your written submission, you've made a recommendation about improved workplace and employment protections.
Yeah.
I did see you sitting in the gallery during the previous session for the Health Services Union presentation. Are you supportive of that proposal regarding reproductive health leave?
Yeah, absolutely. Yes, absolutely.
Yeah, and that sort of proposal, I mean, they've obviously pulled together something very specific. Does that meet would that meet the kind of protections that you are talking about?
I think they are suggesting, as far as I understand, 12 days of leave. I think that's a very good place to start, but I think having access to work flexibility is very important. These appointments are often in the morning, you have to arrive a bit late to work, but you can still arrive, etc. And, I personally have a job that would allow me to do that, but a lot of people may not be able to have that flexibility, and I think that flexibility is quite important for people that go through this type of treatments. Especially, we know in our data that on average women go through at least 6 cycles on average. That's a lot if you think about the and the number of appointments times 6. And that's just the average. A lot of people go through higher than that. So I think, and the other one I would believe is protections. I think a lot of women feel that they cannot disclose that they are going through this type of treatment, for better or worse. It could be stigma, it could be real consequences. I'm not sure about that, and I can't comment on that. But I think if they do feel like it's entitlement and they are able to disclose if they need to without any precautions, I think that's important.
Thank you. In your opening statement, you also mentioned your own personal experiences. Of course, there's no pressure to disclose anything on the public record that you don't want to, but I wanted to give you the opportunity, if you wanted to share any of that private experience with us in addition to your excellent research.
Absolutely. I think what it made me realize through that process was how important it is, and what it is lacking in the clinics, in a way that it's we raised it here, like I don't think the people that work in these clinics have adequate understanding of what people are going through a lot of times, in the sense that you're dealing with people that are going through grief more than once probably. And often, what you just mentioned, that it's just numbers, you do feel that, and that might not be great. And if going back to workplace, and I think the combination of that and the clinics, the way they, like, I could give that example. One day, one of my first cycles, I received a phone call right before going to class to teach. I was going to teach for 3 hours straight, and they told me that they just read me the numbers, the beta numbers, which means that, it was an unsuccessful round of IVF, and that's it. Just a phone call. These are the numbers we got from your test, and I had to walk into the classroom right away, which I did, and it was, it just left me with a very like a lasting, memory of it. And I thought, wow, how many women experience this, right? And a lot of them in situations far, greater or far worse than mine. And I was at the end, very lucky to have my children. But a lot of, in our sample, 1 in 5 women that start IVF do not end up with a child. That's a lot of people. That's a lot of women that remain childless. And we don't really talk about that population. We don't talk about them in our health policy. We don't talk about them in our social policy. And I think that's what I really like to raise awareness on, based on, I think that experience of myself, that I went through it myself, kind of gave me this, raised the questions in me to have the urge to go and look into the data, basically.
I'm sorry to hear that was your experience, but thank you for sharing that with us.
Okay. Hand back over to government.
Yeah, thank you.
Mr. Darling.
Thanks for coming along today. Appreciate your submissions and the opportunity to ask some further questions. The Health Ministers' meeting on the 12th of September last year, it was held in Perth, produced a communique. Now, I don't know whether you're aware that a communique was produced. I know it sounds a little bit down in the weeds, but it's pretty important. On the top of the second page of the communique, it says the reform of the regulatory and accreditation environment for the assisted reproductive technology sector. And I'll just read a couple of paragraphs, or perhaps a couple of sentences within paragraphs, and invite your comments. The first paragraph, it says, Health Ministers agreed that all Australians should have confidence in the ART services they assess. Health Ministers commissioned a rapid review of ART in June, that's June of last year. Goes on to say, the review found that current self-regulatory approach lacks the transparency and rigour that governments and the community expect, especially with the emergence of large private equity providers. And then it goes on and just a couple more sentences. Ministers noted the current industry-led accreditation is not adequate. And then goes on to say, ministers agreed that the Australian Commission of Safety and Quality in Healthcare should provide independent accreditation for ART services against updated national standards, and that's being worked towards to be achieved by no later than January 2027. They're pretty strong words from the health ministers. I'm wondering, does that strong language from the health ministers and what they've laid out as what they're going to do, does that sync with what you have found through your research about there are issues not perhaps well understood, and there is a need to really look at this whole area of ART and IVF in some detail in terms of its practice in Australia?
Are you asking us? Yeah, I think it does sync with what we were told. One thing that we were told on more than one occasion was that there is a need for nationally consistent regulation and for more of that regulation to be external, although people, or independent, although some people did caution and remind us, rightly or wrongly, that they perceive the sector to already be one of the most regulated. I'm not quite sure what that means, but that was a phrase that sometimes came up. But yeah, I think that is consistent with what we were told in general terms. Sarah? Yeah. Yeah.
That position put that it's highly regulated, does that, and noting the what we've seen with some of the large providers and the well-publicised examples of matters that have occurred inside their businesses, does that sound a bit self-serving to you?
It could potentially be. I think we have to be careful when we think about these errors or adverse events or whatever you want to call them. I think it's absolutely crucial that they get forensically investigated and that we get to the bottom of whatever's caused them. But I do think it requires that investigation before you immediately link that to commercial imperatives and to the need for greater regulation. But I don't think that's an argument against greater regulation in and of itself. So, sorry, that might...
So,
yeah.
Proceed carefully, that's what you're saying.
Yeah.
You're saying the fundamental argument that's coming forward is because this industry is highly commercialised and that the private enterprise providers have the lion's share, with leaving a small segment or a small niche for public services, that your position is that that's not necessarily a bad model per se. It's the question of how it's...
Sorry, no, that's probably not what I was trying to say. I think I was more getting... I don't think just focusing on the genuinely terrible adverse events that have occurred is really the primary argument for greater regulation. I think it's more what you said, which is that it is a highly commercialised sector where there are systemic things going on, like these add-on interventions being offered in more than 80% of cycles, and people feeling like they're not being adequately informed. So it's much more than those adverse events that I think are driving the view that we need regulation. Terrible adverse events happen in the public system as well. So if you just tied it to that, then I think you're potentially on shaky ground. There are more fundamental reasons for looking at regulation.
Keep going.
Yeah, you've still got time. Yep.
Thank you. So in regards to digging down and digging deep and laterally, how do we get to this level of understanding which enables policymakers and ultimately legislatures to regulate in this area? Assuming that regulation is seen as something that's required. We've got regulation up to this point, but a particular regulation looking into the future.
Well, my obvious self-serving answer would be that we need more research. I feel like our research, and particularly the work that Sarah did, touched on some really interesting ideas and concepts for regulation, but is only the beginning, and that we really do need to look at it systematically. One of the ideas that I will again attribute to Sarah is that we need to fundamentally rethink perhaps not the governance of healthcare when it's happening in these corporatised environments, and remember that it's a triangle. It's not just doctors and patients, but it's doctors, clinics and patients, and doctors are interacting with clinics and patients are interacting with clinics, and we need to think systematically about how that changes the nature of the regulation that we need. So I do think there's a need for a really systematic look at how the system works, but also the different options that we have for regulating it. Sarah, did you want to add anything to that?
No, I think that's well said.
I guess if the Commonwealth Government has stated and the state and territory health ministers have committed to this new role of the Australian Commissioner of Safety and Quality in Health Research, in healthcare, being up and running and having this new role by January 2027. That's not a particularly long time away, is it? So pretty soon. Yeah.
Thank you. Dr. Najad, I just had a couple more questions for you. In your submission, it mentions I think the average cost of $2,000 per cycle for IVF. I think you also mentioned that the average was around 6 cycles. So that's presumably a cost of $12,000 for an individual, which that's a lot. And sort of differs from some of the other earlier evidence we heard this morning. I wondered if you had any, because we don't really have any figures. It's hard to get figures and information on what the costs are and how much the costs are that people incur. Do your research cover what the average cost was, or a median cost or anything like that for individuals?
Yes, so the $2,000 out-of-pocket cost per cycle is, I should mention, is in 2012 dollars.
Oh.
Right, so it's a lot more than that if you want to think about in 2026 dollars. I could provide you with those calculations if that's helpful.
That would be very helpful.
Yeah,
okay,
if you I'll take that on notice.
Yeah.
Also, I should mention that this is only based on MBS costs, out-of-pocket costs. This does not include, sometimes there are, for medications through PBS, there are also some out-of-pocket costs involved. Sometimes depends on the type of drug.
Yep.
Usually they are limited because the PBS cover is quite good for IVF medications. then it does not include sometimes clinics, especially the low-cost clinics, have charged a flat fee that doesn't go through MBS.
Yeah,
just
okay.
the flat fee.
Yeah.
So our study wouldn't see those because they're not in the MBS, right? We see only what is registered either through MBS or PBS, right?
Okay.
So and then moreover on top of that, what Professor Lipworth was saying in terms of the add-ons, also those add-ons are not part of MBS or PBS. For example, there are, as she mentioned here that there are different types of procedures, like the glue, but also there are different drugs, that are supposed to, medications that are supposed to improve fertility, that are not covered by PBS and it's entirely out of pocket. So again, what we have here is a lower bound for the real out-of-pocket cost. I just wanted to emphasize that. But I would provide you with those numbers in terms of what we have in 2026 dollars an estimation. Yeah.
That would be very interesting. Yeah, thank you.
Sure.
Thanks, that's my time.
Thank you. So that concludes our time with you this afternoon, but thank you very much for appearing and for your answers. I think there might have been a few questions taken on notice and there might be some supplementary questions from committee members as well, so the Secretariat will be in touch in relation to those. But that's it for now, so thank you for being here.
Thank you.
We'll now have a short afternoon tea break and resume at 3:15.
Thanks, Chair.
We'll now move on to our last session of the day. Second to last session of the day.
thinking.
Yep, you're right, I'm wrong. Thank you for being here, Ms Jefford and Mr Page. I just wanted to start with asking each of you, and we'll start with you, Ms Jefford, to just state your name, your position title, and swear either an oath or an affirmation, please.
Thank you. My name is Sarah Jefford. I'm a family creation lawyer. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Mr Page?
I'm Stephen Page and I'm a lawyer practicing in this area. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Would you like to make a short opening statement? That's open to both of you.
Thank you. I will. Thank you, Chair and members, for welcoming me here today. I am a lawyer from Melbourne. I provide legal advice for surrogacy and donor arrangements across Australia. I became a parent through IVF, and I have been an egg donor, and in 2018 I delivered a baby as a surrogate. I have published a guide to surrogacy and produced the Australian Surrogacy podcast. Last year I completed a Churchill Fellowship researching best practice surrogacy frameworks to inform law reform in Australia. There are less than 150 surrogacy births across Australia each year. 80% of those arrangements involve friends and family, while 20% find each other online. Over 350 children are born via international surrogacy each year, and that means 75% of Australian children born via surrogacy are born overseas. Australians spend over $75 million on international surrogacy each year. International surrogacy comes with significant risks, including human trafficking. The industry exploits vulnerable women and intended parents and is almost entirely unregulated. Children born via international surrogacy may be born in countries that have inadequate prenatal and neonatal health care. They face barriers to recognition of their parentage, access to citizenship, passports and social services. Children born via international surrogacy are discriminated against by reason of their birth. New South Wales prohibits international commercial surrogacy. This has not deterred many hundreds of parents from engaging in international surrogacy each year. Prohibitions on advertising, restrictions on payments to surrogates, and the inconsistent patchwork of laws across the country make international surrogacy easier than trying to find a surrogate at home. Banning commercial surrogacy presumes that commercial surrogacy is exploitative and that by contrast, altruistic surrogacy is ethical. This binary approach is not supported by evidence. Well-regulated commercial surrogacy can include safeguards against exploitation. Altruistic surrogacy can exploit the unpaid labour of women. We need a national surrogacy legal framework that promotes best practice surrogacy within Australia. This includes removing barriers to access and allowing advertising, licensing matching services, and compensating surrogates for the time, effort and risk of pregnancy and birth. There is no right to a child, but people will not be denied having a child if that is what they want, and they will do whatever it takes to make that happen. We must be concerned with the exploitation of women and children overseas. We have a responsibility to ensure that surrogacy is well regulated and accessible within our own borders to reduce the instances of our citizens travelling overseas to where they and women and children are exploited. As the largest state by population, New South Wales has an opportunity to be at the forefront of leading surrogacy law reform in Australia. I thank the committee again for the opportunity to speak on these issues.
Thank you. Mr Page?
Thank you for asking me to give evidence today. I've advised in fertility law since 1988. I am Secretary of the Fertility Society of Australia and New Zealand, although my submission was a personal one, not on behalf of the Society. But I may be able to assist the committee about some of the topics I heard in the last session. Most importantly, I'm a dad through surrogacy and egg donation, and I had infertility. I had 10 topics in my submission. I won't cover surrogacy, my friend has done that already, but I would certainly say the Australian Law Reform Commission's surrogacy review, of which we are both members of the advisory committee, has been very thorough, and I expect that it will report in July to the Commonwealth. There are 3 topics I wanted to cover in this opening, and the first is Topic 1 in my submission, private donation. It is deeply concerning that there is no regulation of private donation. While family limits are set at different levels across Australia for donations through IVF clinics, there are no limits for private donors. The Health Ministers meeting over 6 months ago agreed to refer these issues to the ALRC. That kick into the long grass has not been kicked. The referral by the Commonwealth to the ALRC has not occurred. Reform is urgent when, on one estimate, the number of children being conceived through one site alone is about the same as through all of Australia's IVF clinics. The need for regulation of donor apps and websites is pressing. Topic 6, family limits. New South Wales Health has determined in its view that the 5 women to receive donor gametes, including that of the donor's family, so in effect 4 women under Section 27(1) of the ART Act, is a worldwide ban. Worldwide does not appear in the ART Act, nor was it suggested in any of the parliamentary speeches, reports or memoranda. The view taken by NSW Health has caused immediate pain. We have a shortage of donor eggs and sperm in this country, hence they are imported. The cost to intended parents of available sperm has risen in New South Wales from as low as $2,000 before this change to reports of between $45,000 and $62,000. Eggs are also affected. The obvious impact is that New South Wales intended parents will go elsewhere to access eggs and sperm interstate, overseas, and most obviously to private sperm donors. IVF clinics, and this is national clinics, have told me that their number one worry nationwide is the shortage of sperm in this state caused by this interpretation by New South Wales Health and the inability to serve the needs of the New South Wales patients. Topic 2 from my submission concerns posthumous reproduction. A widow who has just lost her husband and wants to retrieve his sperm has to run a gauntlet. It is a crying shame that only one doctor consistently in our nation's biggest city, this city, can be relied on to undertake the retrieval at any time. None of the major IVF clinics will store the sperm that has been retrieved. While the retrieval procedure is available under the Human Tissue Act, the Chief Health Officer has decreed that designated officers at hospitals are not to authorise the retrieval without a court order. The result, widows are forced to either apply to the Supreme Court, where several judgments have doubted the ability of the court to make the order, or to move the body to the morgue or a funeral home and retrieve there. If the body is moved from the hospital to enable the widow her legitimate desires, then the body is not available for organ donation. The widow cannot then use the sperm in New South Wales. She must export it interstate to either Queensland or the ACT or overseas. Thank you again for asking me. I welcome questions.
Thank you. So just for your information, the committee's resolved to split the time evenly between opposition, crossbench and government members, and we'll do 2 rounds of questions. And I will just note, Ms Jeffer, we know you have to catch a plane, so we will finish right on 4:15 to enable you to do that. So we'll start with opposition questions. I might ask Ms Carter to kick off.
Thank you both for being here.
Thank you.
I just want to confirm, Ms Jefford, the submission we have was really written for the Australian Law Reform Commission, and so it's broader than our terms of reference.
That's right.
Thank you. And Mr Page, yours is marked draft. Is that the final one you intended to submit?
I was told of that error this afternoon. That will be fixed.
Oh no, as
But
long
yes,
as
that is the final.
I'm just
It'll be-
checking we have the right
The version
submissions,
that you
that's all.
have will be the version that you get without the word draft written on it.
Great. Thank you very much. No, I appreciate that. If I could start with you, Ms Jefford, one of your primary submissions is pre-birth parentage orders or pre-birth. We had some evidence this morning, which I think speaks to a lot of our lived experience, about the relationship that a mother can form with the child that she's carrying and the relationship that that child forms with the mother. So is there a risk with pre-birth orders that we don't actually allow for what happens to the woman during pregnancy?
It's a really good question. I would query whether there is any evidence to support the idea that bonding occurs because of carrying a baby, or that it only occurs because of carrying a baby. We know, for example, that non-birthing parents can bond with a child that they did not carry. And also my experience, not just as a surrogate, but also advising surrogates and intended parents, is that the intention is to conceive and carry a child for somebody else to raise. So while, for example, I felt very bonded with the child I was carrying, it was for the purpose of her parents raising her. I didn't see bonding or caring for her while she was in utero as the same thing as parenting her once she had arrived. I think the idea of bonding that occurs in utero that is like a broken bond is not really supported by empirical research. We know, for example, that the bonding actually happens from parenting and nurturing a child and caring for a child, for example.
But you would accept, would you not, that if we are going to support the agency of women, that they should be open to make their own decisions and they should be open to whatever their particular experience of pregnancy brings them, which may be different to your experience of pregnancy.
Absolutely. In terms of pre-birth orders, I think they should be the default process if there has been pre-approval of a surrogacy arrangement. So if the parties have completed all the criteria and had approval, then the default position should be that the intended parents are recognised as the parents at birth, but that the surrogate still has an opportunity to issue court proceedings to seek parentage if that is her position.
If the intended parents, or I think they're commonly called the commissioning parents, are seen as being the parents during the pregnancy, who makes decisions in relation to that pregnancy?
So in terms of pre-birth orders or an administrative recognition of parentage, it occurs once the baby has arrived. It does not occur during pregnancy. And our laws as they stand, as what I would support continuing, is that a surrogate does continue to maintain her autonomy throughout pregnancy and the birth, but that the intended parents can make decisions about the baby once the baby has arrived.
So I think you told us that you are a lawyer that advises in relation to surrogacy. Is there available like a standard template surrogacy agreement that you could provide the committee?
I can.
Thank you.
The difficulty is that we have so many jurisdictions that each template is different. But yes, I can certainly provide a template for the New South Wales surrogacy.
Look, that would be great. I've been searching to see, and the ones that you stumble across on the internet, that great research tool, are many and varied. So it'd be interesting to see an authoritative Australian template. A number of them indicate that the commissioning parents often have significant control over the life of the woman who's carrying the child that they hope to raise. Calorie intakes, exercise requirements. How do we reconcile that level of control over a woman with maintaining dignity and respect for the woman who's carrying the child?
I have seen contracts for international surrogacy arrangements that speak to what you're mentioning there in terms of the level of control that intended parents might have. When I draft an agreement, I think of it primarily as a piece of evidence that it is a surrogacy arrangement. We are intending to have a child for the purpose of surrogacy, and then it's used as evidence for the parentage order at the end. So I only draft it in that context. There is nothing in my agreements that talk about controlling a surrogate's behaviour.
But you would be one among many people active in this space. How many children, did you say, remind me, are born through international surrogacy agreements to Australians each year?
Oh, so for international, we think it's over 350. We do not draft those
No,
contracts.
but that's what I'm saying. There would be 350 other women whose experience is dramatically different to what you're suggesting.
Which is, I think, further reason why we should be making surrogacy more accessible in Australia, because I do think then we can enshrine protection of her bodily autonomy, which is true in several pieces of state legislation.
Is there a jurisdiction internationally that you can point us to where commercial surrogacy exists, the autonomy of the birth mother is respected and there is no exploitation in the process?
In New York, as a state.
New York State?
Point. Not the only one, but yes, New York is a starting point, yes.
And you say there's no exploitation there?
No, the way that their legislation is written, it protects the surrogate's autonomy. There is actually a surrogate's Bill of Rights that protects that throughout the process. And while she is compensated, it does not compromise on her autonomous decisions.
And how is the compensation calculated?
So it tends to happen agency by agency, and it does differ across
So
the
I
country.
find this confusing, and I found this in your submission as well. I think we were talking about market forces and if we had more surrogates. Surely, if we want to be respectful, we should be looking at compensation for the service that's being provided, and we should have a standard rate, shouldn't we, rather than each surrogate being able to bargain herself?
I certainly agree with that. I don't think the free market necessarily supports children or surrogates or intended parents who are often having to find the money to compete with other intended parents.
And how do we calculate, for example, long-term impacts on a woman's physical or psychological health?
That's the question I grapple with as well. I think there is a way to regulate compensation for a surrogate that has a cap. So it's like an upper limit that she may opt into. And so it may still be different between surrogates and different arrangements and different outcomes, but it would still be capped.
So if a woman 15 years later finds that she has pelvic floor issues because of that pregnancy, is that compensated for up front, or how is that cost to her directly attributable to that pregnancy reflected?
I think that's the difficulty, and we have that difficulty currently.
How would you propose we address it?
I think at this stage, the best we can come up with is that there has to be a time limit for everybody to have clarity on when expenses can't be paid. And for example, that might be 3 months or it might be 12 months after the birth.
With respect, having children, the 12 months perhaps might be too short a cap, I think, from lived experience.
Absolutely. The difficulty is that we would still, in the system that we have, we would still expect a doctor to confirm that the injury or illness was associated with pregnancy or birth. And I'm not sure, because I'm not a medical professional, what is that limit? Is it 15 years? And what does that mean for intended parents who may not be able to service compensation 15 years after the birth?
Thank you.
Dr. Conn?
Look, just following on from one of the questions about other jurisdictions, you started talking about New York State.
Yes.
You made a very compelling argument for well-regulated, thoughtfully regulated commercial surrogacy here in Australia, and I'm interested in what you see as the components of that best practice, and if you could explain further about New York or other examples that we should look to.
Absolutely. I think when we talk about exploitation in surrogacy, people will assume that the surrogate is being exploited and the child, but they don't talk enough about the intended parents who might be exploited, particularly by the industry overseas. So the most surrogacy industries are not regulated. That's the agencies and the clinics in some countries that operate with impunity. They don't have safeguards in place, for example, for checking that the surrogate or the intended parents can give informed consent. They won't use interpreters. They won't use best practice medical treatment for fertility treatment. We can compensate surrogates for the time, effort and risk of doing surrogacy in Australia while still enshrining her right to access to legal advice and counselling to make sure she can provide informed consent, that she can read a contract that's written in her own language, and that she maintains her autonomy throughout the pregnancy and the birth. So they're all the safeguards that when people say, well, if you introduce money or payment for surrogacy, you are compromising on those things. That's not true. Payment is not the problem, it's the lack of safeguards that are written, that are not written into legislation elsewhere that we already have in our legislation. That's in every piece of surrogacy legislation in Australia. What we see in the New York model, for example, is that the industry is also regulated, that matching services providing surrogacy services in New York State must be licensed and they must adhere to those practices before they deliver those services. We're really then supporting everybody in that arrangement to have their legal rights protected, but also to make sure the surrogate's rights are still protected.
Thanks. You made a counterintuitive comment in your opening statement that altruistic surrogacy can in some cases also be exploitative. Can you explain what you meant?
Absolutely. When I think about my experience of surrogacy, I was not motivated by money. I carried a baby for 2 dads who are wonderful parents, and I had an amazing experience, and I didn't do it because I thought I might get paid, and I was not financially compensated. But I tell you, everybody else was. The lawyers, the counsellors, the clinic, the fertility doctor, the birth photographer, everybody at the hospital, they all got paid. Now, I make money giving legal advice, and often that takes several hours of my time, and then that woman goes off and does 9 months of pregnancy and delivering a baby, and she gets nothing. The birth photographer gets paid and she does not. The fertility industry in Australia is worth over $800 million a year. Everybody is paid except the surrogate. Altruistic surrogacy means all of us get paid, and it exploits her unpaid labour during that process. So when we talk about commercial surrogacy being exploitative, altruistic surrogacy is good, I think it denies that. Altruistic surrogacy expects her to work for free. And while we should be concerned about exploiting women, we should also be concerned about women and girls that are born through surrogacy, or just girls generally, thinking that they should be working for free when everybody else is profiting from their work.
Thank you. You gave some examples in your written submission about payment of surrogate expenses leading to conflict and even legal dispute. What safeguards would you suggest could be put in place to protect surrogates and parents in those instances?
There's some models overseas which includes independent escrow, or what we might call trust accounting. So the intended parents put money into a trust account that then has independent oversight to distribute those funds to the surrogate for her expenses. I really support that model. In practice, I think it has a lot of work to do in terms of who's running an escrow account, for example, because me as a lawyer, I have no interest in doing that. But I think the model itself protects everybody's interests, because the intended parents know that there's full accounting for what those expenses are, but the surrogate has some surety that she knows her expenses will be covered even if the intended parents or their relationship breaks down, or the intended parents don't want to pay anymore. Somebody else is managing that process for her. Yeah.
Thanks. You also made some comments in your written submission that were very interesting in terms of hospital policies. And I think that's particularly interesting at a state level because, of course, the New South Wales government's responsible for New South Wales health. Could you give us some examples of your clients' experiences in terms of their experiences in hospital?
Disappointingly, public hospitals across Australia are ill-equipped for surrogacy, pregnancy and birth care. I find private hospitals are generally supportive, public hospitals not so much. It's very ad hoc, and it depends on who's working at the hospital and how supportive they want to be. So I've had stories of a hospital in regional New South Wales denying a C-section on the day because the obstetrician thought that surrogacy was illegal for gay men. So they had to switch to another hospital that day. I've had situations where the surrogate has been pressured to care for the baby because the hospital does not recognise the parents as legitimate carers, and they've been told to leave after waiting hours are finished. We know that 1 in 10 hospitals in Australia has a surrogacy policy. We know that most of those hospitals will maybe care for 1 or 2 surrogacy pregnancies across 5 or 10 years, which means most of their staff have zero experience caring for a surrogacy pregnancy. The process in terms of post-birth parentage transfer also means that hospitals find themselves confused about who is the legal parent and who can care for the baby. And one policy I've seen that says the surrogate must not breastfeed the baby, the intended parents must not breastfeed the baby, and the intended parents are not to be left alone unsupervised with the baby. I mean, I don't know when they were written, but they don't apply to the intentions and the legal framework for surrogacy in Australia, that people have done a whole pre-surrogacy process of counselling and legal advice and intentionally conceiving that child for the intended parents to raise. And then the hospital steps in and says, we don't acknowledge that that's a legitimate arrangement. One hospital referred to the surrogate as the mother and refused to use any other language even when they were asked not to. It's just every week I hear stories about hospitals doing fantastic work and other hospitals just refusing or being belligerent about it, frankly.
Can I add?
Please.
It was a month ago in Sydney in a private hospital where my clients, the intended parents, were not able to take the baby home because the surrogate had a C-section. And the hospital said the surrogate is the mother. Our policy is quite clear. She is the only parent, and you cannot take the baby home until she goes home. You aren't parents, which is actually contrary to what several judges of the Family Court have said, who are parents under the Family Law Act. When my daughter was born in Brisbane, in the largest maternity hospital in the country, she had to stay in overnight at a time that our surrogate was to be discharged. This then went through 1, 2, then 3 midwives, then 1, 2, 3 hospital executives, until finally there was that conversation in the corridor that we've seen on umpteen TV shows about hospitals, between a hospital executive, a surrogate and me, turning to my surrogate saying, well, who's a family member I might say, saying, we spoke to the hospital lawyer who said that as you are the only parent, it is advisable, that's what she did, it is advisable that you not leave. Now, both of us instantly understood what that meant, that if our beloved surrogate then left, child safety would be notified. And I felt completely invisible. My role was irrelevant. Now, one of the things that I've done since then, and Sarah does also, is to have parenting plans under the Family Law Act to try and fix that as a temporary band-aid until orders are made, and they're often not made 6 months or more after the child's born. But it was such a shocking experience. And this was a hospital that had the first surrogacy policy in the country. And as I said, the largest maternity hospital in the country. And yet even they got it wrong.
Thank you. To government members?
Yeah, thank you.
Yeah.
And, thank you for
Donald.
coming along. Ms. Jefford, just going back to your opening statement, I think you said, if I understood correctly, what you said, that you, with your legal practice, are not involved in the preparation of commercial surrogacy agreements for individuals or couples going overseas seeking to secure a child through a surrogacy arrangement in another jurisdiction. Is that correct?
Yes, I give them legal advice about options and processes, particularly around bringing baby home, but I don't draft contracts.
So let's assume for a moment, just being a devil's advocate, that your proposition about setting up, so use the word setting up, or regulating commercial surrogacy is what came into law. With respect to the surrogacy agreements that you might in the future under that sort of circumstance be involved in preparing, would it not be the case that those agreements would in fact more than likely contain some of the specificity that exists in some of these overseas contracts which have been referred to? In other words, I would have thought that if commercial surrogacy became the law in New South Wales or in other Australian jurisdictions, the commercial surrogacy agreements would in fact be quite robust documents. I mean, they're binding arrangements in terms of their intention. Would not it be likely that you would be advising clients to put into those commercial surrogacy agreements some specificity about a range of things? I'm not going to get down to what they might be, but that would be the case, would it not?
Yes, I think all parties, even now, would benefit from having clarity. A lot of the disputes I see are often about lack of clarity around what money is owed for surrogates' expenses, for example. So I think any agreement, whether it's for compensated surrogacy or not, there should be clarity between the parties about what is owed and who and when it's paid, for example.
Oh, that's dealing with the dollars, if I could put it in such crude terms, about payments and periods of when payments are made, or et cetera, et cetera. But I'm talking about, if, as I said, if one does go to the internet and looks at surrogacy agreements, which I might say there doesn't seem to be a whole lot that are on the internet, but nevertheless one studies them. One does find some real specificity about certain, what could only be described as obligations or requirements that the commissioning parents are placing on the woman. Now, if that's the case overseas, and these surrogacy agreements I've seen are from all around the world, why would that not filter into Australian commercial surrogacy agreements and into in a state or territory? Well, I mean, because presumably the commissioning parents would do their homework, or perhaps come to yourselves and receive advice, and they would quickly find out that commercial surrogacy agreements around the world in different jurisdictions are much more than just a schedule of costs.
I think even as we draft the agreements now, my agreements tend to reflect what the legislation says in terms of what expenses can be covered. So as a kind of general broad statement is anything that is a reasonable out-of-pocket expense that is associated with surrogacy, pregnancy or birth. And then we can include a list of what those things might be. For example, legal advice, medical expenses, counselling. We can still include those even if we are then including, for example, a monthly compensation payment or compensation payments for a triggering event, for example, if she's had to have a hysterectomy or there's been a stillbirth. That those payments can be incorporated, whether it's dollar figures or just specifying that they will be paid if they are reasonable, for example. And the parties have an opportunity to then discuss what that might be, or there may be regulation around what is the cap, for example. So the schedule might be specific, but the agreement itself is still quite broad in terms of what can be covered. And you can still include safeguards, for example, around these payments do not compromise her autonomy. And she still has to provide informed consent, and there still has to be counselling and legal advice.
Okay, sorry, can I add?
I'm not talking about I'm not talking about the issue of payments and the disbursements with respect to the payments of the contractual arrangement, but actual directives within the contract about what the woman can and can't do, and deal with matters like, and I've seen in a few of the agreements that I've just sort of sourced on the internet, that in cases, for example, where there is surrogacy pregnancy and there is the creation of, through that, three embryos. The matter of terminating, one of those three, the retention of two and setting a limit of up to two to carry two, but the option of the commissioning parents to require the woman to terminate one of those embryos.
I wouldn't say that's different.
It gets down to quite level of specificity inside the commercial contracts. So why wouldn't we not assume that in Australia, perhaps putting you aside in the sense that you run a very strict, tight expenses, type of arrangement, that these would not filter into Australian surrogacy agreements?
I think some of it comes back to community education, that payments for the work of pregnancy and birth and being a surrogate is not the same as payment for adhering to contractual obligations, for example, for terminating a pregnancy or reducing a pregnancy, that ultimately a surrogate can still maintain her bodily autonomy. That is enshrined, and it can continue to be enshrined in all legislation, that any clause in an agreement that compromises that is not enforceable. For example, I talk to my clients and say, you could have an agreement that a surrogate will not drink alcohol during pregnancy. That's fairly typical. That's a kind of usual expectation. But there is no law that stops her from drinking alcohol during pregnancy. That's still something that she can decide to do.
But in these overseas contracts that I've seen, commercial surrogacy contracts, it deals with that. I mean, I saw one just on the weekend when I was reviewing it, specifying that the woman will not dye her hair and use hair dye over the course of the carrying of the surrogate child.
I think we can include anything like that.
I mean, I understand how you're coming back at this, but I'm saying this is what's going on in other parts of the world. And you can look at various nations around the world where you can find these arrangements. And I think you would not be surprised that I sort of press this reasonably firmly to challenge that, this, I think the proposition is that this is your approach in dealing with these things, and the law can cover stopping or preventing some of these things, but I can't see how that could sort of easily do that.
I have seen some contracts that I have found from overseas that I have found offensive in terms of the clauses. I don't know that those clauses necessarily change because money is involved. I think those clauses could be written into an altruistic agreement. And again, it's about making sure that the system does not support it being enforceable, that if the parties all agree that they want a clause in there that says she will not drink alcohol or that she'll only eat organic vegan vegetables, that's okay. They can all agree to that. She has the autonomy to say, I will adhere to that. But that ultimately it's not enforceable if she makes a different decision, and that is already enshrined in our legislation.
Can I just add, in my submission, I note that New South Wales alone, I believe it's now alone, does not say in its Surrogacy Act that the surrogate has bodily autonomy. It's part of the common law. For some reason, when this state modelled its act on the Queensland Act, that provision went out. I think it's absolutely essential that it be part of the statute law of this state that she has bodily autonomy. Just like Queensland, ACT, Victoria, Tasmania, South Australia, the Northern Territory and soon WA. I just think it's absolutely essential. And that issue that you've raised, yes, absolutely, it's concerning. I think we might be putting the cart before the horse. We'll see what the ALRC does first. They're certainly doing a very thorough inquiry. And I don't think we should assume that they're going to be recommending commercial surrogacy. But having control, having the surrogate having bodily autonomy, having it in statute, I can say putting that in the document has been very powerful for clients of mine who are surrogates. And saying this is what Parliament has said, very powerful. I just don't know why New South Wales hasn't done it.
That was going to be my question to you. So you've been reading my mind, Mr. Page. I want to ask you, though, if I've got more questions, the issue around family limits, and you touched on that in your opening statement. I've had a few people reach out to me about that as well, just with some concerns about New South Wales Health's interpretation of what that 5 number means. Can you just talk to that a little bit more? And I note one of the recommendations that you've made is effectively that New South Wales Ministry of Health should interpret that 5 to be 5 women in New South Wales or who receive treatment in a New South Wales clinic. Is it as simple as that?
It's really as simple as that. It's going to the Interpretation Act, Section 12(1)(b), if I recall correctly, and saying it's women in and of New South Wales, namely they've had treatment here or they come from here. That's not women worldwide. But because they've changed, because they've really cracked down on the issue last year and said to all the clinics, you must comply, then we've had this sudden problem. And $62,000, you know, when I was hearing before about cost, New South Wales, there'd be rare New South Wales women who can afford sperm for $62,000 when previously it was $2,000.
And I guess in your sort of experience or with the clients or people that you're working with, so it's something, just last year there was a change in the interpretation. I'm just trying to work out how or why this has occurred.
The clinics read the legislation. The legislation does not refer to worldwide. And looking at the legislation, looking at the Interpretation Act, ordinary statutory construction says it's not worldwide. It's not in any of the second reading speeches. It's not in any of the explanatory memoranda to say worldwide, but nevertheless New South Wales Health took that position and took that position firmly last year. It was not uncommon for clinics to import sperm from, say, the United States and say, well, there's 5 in New South Wales and we'll have 5 somewhere else. So we're under the national cap of 10, because in most other states it's 10 nationwide. But about a year ago, New South Wales Health said, no, you can't do that. It's 5 worldwide. And so the result is that US sperm banks are then saying, well, we can only supply to you and no one else, and as a result the price goes up. And it's gone up extraordinarily high.
So some sort of ministerial direction or something to fix it within
that
the
would be very
Health
helpful.
Would be the pathway to try to
absolutely.
Okay, thank you. Ms. Jefford, I just want to come back to you. Thank you for your submission, and both of you actually, and the personal lived experience is also really valuable for the committee to hear. I was interested in lots of parts of your submission, but particularly I want to ask about where you talk about sort of better regulation of the sort of agencies that exist at the moment or the service providers. And I note, I think you talk about New York recently have set up sort of a good model of how you can make sure you've got a good regulatory framework within existing laws. And obviously that's sort of the case here in New South Wales as well. But I guess why you see a need to have a better regulation of existing service providers here in Australia at the moment?
So lawyers, counsellors, clinicians, we're all regulated in different ways. We have practising certificates, we're insured. If people have a problem with us, they have a pathway to make complaints, and deal with our practicing certificates. Service providers like matching services, I guess, operate within consumer law, and that's not regulated specifically for surrogacy. Several states in Australia actually ban facilitating or enticing people to engage in surrogacy, and there's also prohibitions on advertising that you would provide that service. So the only service I can think of is Surrogacy Australia that kind of tries to operate in that process, but in several states they are not operating legally. And in my experience giving advice to people is that they think they're joining the service to find a match, to find a surrogate that does not exist, and there's no real consumer protections to get their money back if they find out that the service is not providing what they thought it would. So in terms of regulation, I think there should be a licensing system and standards that they need to adhere to, just like lawyers have to adhere to standards and practicing certificates, etc., that we need to actually regulate the industry. And we can't regulate the industry overseas, but we can regulate those that practice, that operate in our own country. What we see in America as an example is that you could deliver a baby as a surrogate or become a parent via surrogacy, and the next day you can start an agency where you now provide matching services with no business qualifications, no psychology degree or law degree, and some of them do really well, but many of them fail in the first year. So if we are going to open up options for people to find a surrogate in Australia, we need to regulate those services that are going to provide matching services.
If you go down to Coles or Woolies late at night and buy a bottle of milk for $4, you know it's safe to drink. It's cheap, highly regulated. If you go to surrogacy agencies around the world, except New York, they're not. So if you're going to a surrogacy agency in the United States, for example, you might spend $40,000 US on their fee, not regulated. It's really a case of buyer beware. And there are many good surrogacy agencies overseas, but there are also many worrisome agencies. And I'd certainly strongly endorse that if we're going to have surrogacy agencies here, that they be properly regulated.
And I think you also talked, Ms Jefford, about the licensed non-profits being overseen by a regulatory authority, framework regulated, say, by the Department of Health. So bringing it back into that sort of government oversight, would that be your suggestion for best practice in Australia?
Yes.
Yeah.
I'd like to see a national regulator in that respect rather than state by state. I don't think that makes it any better. But if we had national regulation and licensing for matching services, for example, and it could also regulate the clinics, it could be one commission for fertility treatments and surrogacy, that everybody has to adhere to the same standards, that there's codes of conduct, there's penalties if we don't adhere to them. I think that it's not just about making surrogacy more accessible, it's also about making it safer for intended parents and surrogates and the children that are born.
Did you want to add something?
There should be one nationwide. We had Professor Greg Hunt and Dr. Rachel Swift for the Fertility Society note that there should be one system of regulation of ART nationwide. Incidentally, the regulation by the Commonwealth, accreditation of IVF clinics, that's not likely to commence until 2028 or 2029. And because in that 3-month rapid review, it wasn't realised that ARTAC regulates or accredits clinics in New Zealand and throughout Southeast Asia and by law in Singapore. So it's, if there's going to be a review, it's going to be done thoroughly. But look at the national picture, have one system, not 8 systems as we have at the moment. We struggle because we have 8 different systems of surrogacy law. There's just no consistency across the country. I complained when I gave evidence to the House of Representatives Committee on this back in 2015, and while we've moved, we haven't moved far enough.
Just one more, Ms Jefford, the consistency of counselling and surrogacy counsellors and their various qualifications. I think one of your recommendations, you actually recommend not having post-birth counselling, but I just wondered if, and happy for either or both of you to comment on, I guess, the quality of surrogacy counselling, the expertise, what sort of training is needed that doesn't occur at the moment in this space.
I absolutely believe there's benefit in counselling being available throughout pregnancy and post-birth. I just don't think it should be a criteria to get a parentage order.
Okay.
And actually there's 4 jurisdictions that require it and 4 jurisdictions that do not. So it just shows how ridiculous it is. In terms of counsellors, I have some excellent counselling colleagues in this space. There is no kind of formal training to be a surrogacy counsellor, but ANZICA is the member body for fertility counsellors across Australia. It's a small body. They operate as a committee of the Fertility Society. They are not a regulatory body. I think they could be a regulatory body that actually has standards that they license counsellors for fertility and surrogacy counselling. I have seen a whole spectrum of excellent surrogacy counselling, and the reports are excellent and they do a great job. And I've seen others where I have seen red flags flying, and the counsellor, it has felt like a tick and flick process for the counsellor and for the parties. It is not meant to be a therapeutic process. It's meant to be an assessment and to help the parties prepare for the complexity of surrogacy. That requires specialised knowledge and skill and experience to provide that service. I do have concerns about, with respect to counsellors, they are always doing their best, but counsellors that are employed by clinics, I think, are conflicted from providing surrogacy counselling, and I think that counselling should be provided external to the clinics by independent counsellors.
Thank you. Dr. Conn.
Thanks. I might start with a question for Mr. Page. In your written submission, you made a comment about changes you would recommend to the Anti-Discrimination Act in New South Wales, that government employees are at risk of discrimination. Can you explain that argument?
Well, particularly the directive about taking leave for surrogacy, that the current requirement, if you're a public servant, is that you must obtain a parentage order from the Supreme Court in order to be able to obtain the surrogacy leave. It's certainly much more restrictive than Queensland. I sound like a previous witness, but certainly in Queensland there is no difficulty obtaining surrogacy leave or adoption leave or parenting leave. They're written into the awards. And there's no requirement to go off and go to the Supreme Court. And the example that I gave in the submission is that if you do altruistic surrogacy in Canada, you then get typically an order in Canada recognising you as the parents. According to the directive, you won't be entitled to get leave unless you then end up in the Supreme Court here. The Supreme Court here, I could imagine, the judge would say, but I don't have jurisdiction, an order's already been made. Why are you coming here that the matter is at an end? By contrast, if you were a teacher a female teacher who has no uterus, for example, and you're employed by the Catholic Church, you are protected by the Disability Discrimination Act, notwithstanding that the Church is opposed to all IVF and is opposed to surrogacy. So there's more protection in that example for a teacher who's employed by the Church than a teacher necessarily employed by New South Wales Government.
Thank you. I might come back to Ms. Jeffin. You gave a cost estimate in your written submission that families can be paying up to $200,000 for international surrogacy, which is obviously an extraordinary expense.
I'd say that's wrong. It's closer to $300,000 as a starting point.
Okay.
Some of my clients are paid over $300,000 American dollars.
Okay. And so can you break down roughly where the various expenses are for the families?
For international surrogacy, it would mostly be, I think, fertility clinics and agency commissions. The surrogate probably gets a very small fraction of those fees in most countries. And then, of course, it would also be the legal process, legal fees in that country if they even have a lawyer, and then flights and accommodation and living in that country before and after the birth, before they can come home. There would also be fees for engaging with an Australian lawyer, perhaps an Australian migration agent, and going through the citizenship and passport process to then come home.
If I can give some numbers.
Please.
If they're going to Georgia, and Georgia, of course, has had an egg farm where Thai women were held as slaves, and also had the couple who had 21 children 1 year via surrogacy, which is deeply worrying. That was a few years ago. the cost would be under $100,000 for Australians. If they're going to a place like Mexico, probably about $130,000. This is all in Australian dollars from home over and back. The United States, $360,000 plus. If they're doing it here, somewhere between $50,000 and $100,000. Approximately half of which is the cost of IVF, and the other half is related to the specific surrogacy journey, namely the expenses for the surrogate, lawyers, etc.
Okay, and I appreciate these are all back of the envelope numbers. It really sounds like the majority of these expenses are going to for-profit agencies and lawyers.
In the United States, if you gave some numbers, the agency would have a fee of say $40,000 US. The IVF there would be say $50,000 US, and the surrogate's fee, it varies depending on what state she lives in and depends on whether she's a first-time surrogate or a second-time surrogate. But ballpark for her fee, not her expenses, $50,000 US.
I have a perhaps obvious follow-up question, but I think it's still important to answer it for the record. My assumption would be that the majority of your clients would prefer to undertake that process in Australia, were it permitted and regulated.
Every last client would prefer to do it here, down the road at their trusted IVF clinic. And just to follow up a comment that was made before, the practice that Australian and New Zealand IVF clinics pioneered worldwide to help women's safety is single embryo transfer. We should be very proud in this country about our IVF clinics doing that.
I can tell you 92% of intended parents have, research has been taken to show that they would prefer to have engaged in surrogacy in Australia if that had been an option for them.
Okay, thank you. That's helpful.
That's commercial surrogacy.
No, 92% of intended parents would prefer to do it in Australia, full stop.
Whether it's altruistic or commercial?
Yeah.
I don't think they've been asked that specific question whether it's commercial or not, but they would rather. The problem is there are no surrogates. There are not enough surrogates, and intended parents therefore finding they can't find a surrogate here. Everyone's looking for that 1 in 5 surrogates if they don't know someone, so they go overseas.
I wanted to follow up, Ms. Jefford, in your written submission as well. You talked about changes which the Trump administration, at the time you wrote the submission, they were being considered. I think they've now come into force. What are the implications of that for Australian families seeking surrogacy in the US?
So Stephen might have some comments about this too. The Trump administration announced, I think on day one of his new term, that he was going to get rid of birthright citizenship. It's not as simple as that, but for an Australian couple going to America for surrogacy, they generally get an American birth certificate and then they can get an American passport and bring the child to Australia on a visa. And then when they arrive in Australia, they can apply for Australian citizenship for that child. If birthright citizenship was changed or got rid of in America, that could mean that they are in America with the child who is now stateless, and they would have to apply for Australian citizenship before they can get a passport to bring the child home, which could blow out their time in America to several months, but there's also risks for that child and the family. Now, there has been progress, and I've spoken to American colleagues who have said at this stage it's really nothing to worry about. However, I think it highlights that the landscape of geopolitical changes and surrogacy law reform or war can change very rapidly while we have pregnant surrogates for Australian intended parents. And there's very little that you can do when your surrogate is 6 months pregnant and the law now changed and suddenly what you thought was going to happen is not what's going to happen. I think it's another reason why we should be making it more accessible at home, because it's safer here for everybody, and we don't have surrogates who are now at risk of being criminalised because the law changed in their country.
One of the things I did at Easter was to read the transcript of the US Supreme Court in the challenge to the President's executive order on birthright citizenship. I think it's most unlikely that he will succeed. Most unlikely, I would say. As a betting man, I'd say 7-2 or 6-3 against him. But as Sarah said, that's really highlights the problem. We can control what we do in our country. We can't control what happens outside our country. And we have had, I've lost count of the number of surrogacy crises that have happened overseas, where halfway through a journey, the government overseas has reacted to a crisis and pulled down the roller doors. I would encourage, wherever possible, surrogacy to occur here and intended parents to undertake surrogacy here rather than overseas. But if the President is successful with that action, I'm confident that the Department of Home Affairs, as it has done so before, will act quickly to protect the citizenship of those children.
Thank you. Can I very briefly follow up? I appreciate, if in the interest of time, you may need to take it on notice, but I'd be interested in some of those examples of those surrogacy crises. I know we've had some reported in the media recently, but for the committee to have those examples.
I can say India 2012, 14, 16, Nepal 2016, Cambodia 2016, Thailand 2014, Tabasco in Mexico 2016, the world 2020 to 2021 with the pandemic, and then Greece with Mediterranean Fertility Institute in 2023, and then Argentina in 2024. I think that's it.
And Ukraine.
Oh, and Ukraine in 2022 onwards.
Government members, your time.
Thank you, Chair. Ms Jefford, thank you for appearing. Thank you to both for appearing and for your evidence. In your submission, Ms Jefford, you mentioned in the introduction that law reform in New South Wales should be informed by the ALRC review. That's the position that you're putting forward?
Yes, absolutely. Well, I guess there's two parts to that. The Law Reform Commission report is due in July, but it will go to the Attorney General, and then we just wait for what might happen at a national level. I think given New South Wales is doing this review, it would be amazing to see law reform that starts here, because I think certainly one of the recommendations is that we have national consistent laws across the country, and either the states and territories transfer their powers to the Commonwealth, which is unlikely, that actually we need everybody to come to the table and write consistent laws, and one way that that happens in practice is that one state does it and another state then copy-pastes. I think New South Wales is in a great position to do that because you are the most populous. 40% of my clients are New South Wales residents. So if it starts here, that would be fabulous, because there doesn't seem to be any reason to delay that while we wait for the Law Reform Commission at the national level. And I know how long these sorts of things can take as well.
Yeah, okay, thank you. You also mention about the importance of education and awareness in terms of the views about surrogacy. And consider that surrogacy would be improved through greater education and awareness and appropriate regulation. I just wonder if you can give us some sort of specifics or examples of what that education and awareness involves.
So we know that when somebody's thinking about surrogacy, they'll Google, is surrogacy legal in Australia? So a lot of people, if you read Facebook comments, you'll see people say, oh, I don't think that's legal, you can't do that here. My friends went to America, for example. That's a pretty standard response. I think rather than people looking at my website or Stephen's website and finding information on Facebook groups, the government needs to take some responsibility for putting out unbiased information and education around what surrogacy laws are in Australia and how to find a surrogate and what the process looks like. Without that, people can Google surrogacy and end up in Mexico without ever talking to a lawyer or a government official about what the risks are in that country. We have a real problem that it's prohibited to advertise surrogacy in several states, but a Mexican or Argentine or American surrogacy agency can advertise on Google, and that's the information people are accessing, which may not be correct. I've had clients tell me, I was told I can get a parentage order back in Australia, and when I asked them who told them that, oh, it's their Chinese broker that sent them to Kyrgyzstan. So that sort of misinformation needs to be countered, and we can do as much as we can, but it needs to come from the government.
Okay, I might just pass to my colleague if you've got any further questions.
Yeah, these are really to be taken on notice. Jefford, in regards to the surrogacy contracts, if I call it that you're involved in preparing for clients, are you able to provide on notice to the committee some de-identified examples so we can try and grasp what is the content of what a typical agreement looks like?
Absolutely, and I can provide a sample copy, but I can tell you for mine it's generally tells the story of the arrangement, gives the recitals, for example, and then we'll talk about the agreement to intentionally enter a surrogacy arrangement, making sure we meet the criteria under the Surrogacy Act, including that they've done their counselling and legal advice, that it's not enforceable, for example. I have a clause around the surrogacy expenses and costs to be paid, and then also a discussion around the process after the birth or before the birth and after the birth for parentage.
And could I be bold enough to ask if you could provide to the committee on notice a copy of your two books? There's the book More Than Just a Baby, a guide.
Do you want mine too?
Indeed.
Yes, I do.
You've got ahead.
Of course you do.
Indeed. So you're way ahead. Yes, they can be autographed. I'm quite reluctant.
I have one book, but it's the second edition. So
okay. I thought there was, we need a surrogate, what's next? I thought that
that's just a blog article on my website.
Okay.
Yes.
And Mr. Probyn, you obviously are ahead of the curve, and I won't need to make the request, and I'd be grateful if those two books. And just in regards to, if you're able to do so on notice, if you have, looking at the overseas arrangements now, particularly any what is a standard pro forma one that you may use, and with respect to, if you don't have that, any examples which are obviously identified, just to help us grasp the content of the...
It's really hard because if you talk about the United States, for example, we think of the United States as one country. It's really like 51. So 51 different jurisdictions. They're all different rules in each place.
I'll leave it to you to make a discern.
But certainly a place that Australians are going to in increasing numbers now is Mexico, in part because of cost and risk with the United States, in part because of very welcoming decisions of the Supreme Court of Mexico upholding human rights. I'll see if I can get you a Mexican agreement so you can see some of the things they set out human rights in there.
I'm just conscious of time, Ms. Jefford, needing to get away.
I do have a fact sheet that I brought enough copies of, if I could...
So on a table? Yeah, that'd be great.
Thank you. And yes, if I could head off.
Yes, no, that's fine. Thank you both for appearing, and anything on notice or any supplementary questions, the Secretariat will be in touch, but thank you for your time today.
Thank you.
Thank you so much for joining us. I just wondered whether you could start by just stating your name, your position title, and swear either an oath or an affirmation, which I believe has been provided to you by the Secretariat staff.
Yes. So first of all, thank you very much for this opportunity. My name is Rima Al-Salem. I'm the UN Special Rapporteur on Violence Against Women and Girls. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Fantastic. Ms. Al-Salem, would you like to make an opening statement for the committee?
I was informed that it's better to keep it very brief and get started. So, as you know, I have presented for your attention as a piece of evidence the report that I presented to the United Nations General Assembly Third Committee on surrogacy and violence against women and girls. This was my thematic report last year, in which I detail the many ways in which surrogacy constitutes violence against women, but also against children. I presented an analysis of the different human rights standards and human rights obligations that states are bound by, including Australia, and that surrogacy as a system violates. I also made recommendations to states and others on how to address the harms caused by surrogacy. And what I suggested is actually to adopt an abolitionist framework towards surrogacy, akin to the one we have in a number of countries on prostitution, because I see that there are many similarities in the phenomenon, both of surrogacy on one hand, prostitution on another, the causes for it, the elements that allow for it to prevail, and also the kind of violations that women in surrogacy and girls in surrogacy are subjected to. So that's it in a nutshell, and I'm happy to answer any questions you may have.
Thank you. So we will go between members of the committee, and they'll appear on screen so you can see the person who's asking you the question. But I might just start with one. I was just interested in your paper where you speak about how there's not sort of any process for, I guess, monitoring the intentions of intended parents, whereas in adoption, for instance, that's part of the processes. I'm just curious to learn a little bit more about what the evidence was around that and what led you to make that sort of recommendation as such.
So for this report, as I said, I looked at the credible secondary sources, so research materials, studies that are longitudinal and that have a proper sample. I also looked at processes in a number of countries. I spoke to women and children affected by surrogacy. And I held also consultations with experts. But it is very clear that in most countries, if not all of them, that have adoption processes in place, there is a much more rigorous process associated with adoption than we have ever seen in surrogacy. In adoption, they vet the parents, so you have to apply to adopt a child. Your background is checked, your approach, meetings are held between you and the agency in the state responsible for child adoption. And you are basically vetted, assessed on whether you are appropriate. None of this happens in surrogacy because it is also not designed to be that way. In surrogacy, what matters is that you can buy, is that you express an interest in having a child through surrogacy. You do forum shopping, you look at where the best offer is, just like buying anything else under the sun. And so you decide if the laws in the country are appropriate, you decide if they can get you the women with their appropriate physical and genetic makeup, and also it depends if there are also eggs that come into it that you also need to get, and also how easy it is to take the child out. So in most countries, even that allow surrogacy, when someone comes back with a child, there is really no way, very little ways of knowing that this child was procured through surrogacy and that the child has effectively been bought, because the paperwork is done abroad. And when they come back with a child, it's mostly sort of just legalized in the country where they come in, if the child is declared. But I am not aware of anyone checking into the background of an adult who has a child procured through surrogacy, could be also for the intention, commissioned to become a parent. And we really hear about it only through the media when there is a scandal, when it comes to our attention, often too late. that this child has been abused or exploited in one way or another. And recently we've seen a lot more reports about that.
And then just one quick before I hand to my colleague, in your opening comments and in your submission and the recommendations, effectively you're saying that the practice of surrogacy is characterised by exploitation and violence against women and girls. Is that commercial surrogacy, altruistic surrogacy, or all forms? I'm trying to just understand the clarity in the position in the paper.
So my conclusion following this report is that there is no meaningful distinction one can draw between so-called altruistic surrogacy and commercial surrogacy, because quote-unquote altruistic surrogacy doesn't really exist. It's really just a smokescreen. The price for a woman to engage or for a female to engage in surrogacy is built into what is presented to be just the daily expenses for her to be pregnant and to carry this child to term. But the real price is often baked into or embedded into the agreement that is reached. And so other than that, it's the same manifestations, causes of violence, consequences, and severe human rights violations that both surrogate mother and child are subjected to.
Thank you. Ms. Carter?
Thank you, Ms. Al-Salim, for being with us today. My name is Susan Carter. I'm curious, in your report you flagged psychological violence as a risk for women and girls in surrogacy. Could you perhaps explain that risk to us a bit?
Absolutely. So there are many ways in which psychological violence manifests itself. I would say that the most severe and persistent one of them is that surrogacy deliberately ignores and undermines the bond that is created between the mother, who is the female that was pregnant and brought the child into the world, and the child. Now, this is not a figment of imagination. This bond, which is formed over 9 months, is a material reality, is a fact. There are studies that have been done on this, and it's how nature engineered us in order to for species to survive, not just humans but others. And so in all surrogacy arrangements, the child is immediately removed from the mother. No skin-to-skin contact is allowed. If it is allowed, it's really an exception. And that's done deliberately because commissioning parents or the commissioning person and the agencies want to make sure that there is no bond that is created. And so the mother, of course, suffers because of this. Her whole body and way in the world for the last 9 months have gone towards creating this link. The other issue is the systematic stripping of women of their dignity and agency through surrogacy arrangements. For all the talk that we hear about the importance of consent and bodily autonomy, and the fact that many justify surrogacy, saying it's really the will and desire of surrogate mothers to enter in these arrangements, what we see is a systematic stripping of females engaged in surrogacy of their dignity, of their consent, of their agency. Because through these contracts in particular, they hand over completely the agency over their bodies, their wishes, their family life, even things like what they eat, where they go, who they see. So many of the surrogate mothers I've spoken to have spoken about the huge toll that this takes on them. Not to mention that surrogacy is actually a dangerous exercise. So because they take many hormones, and some of these also pregnancies and deliveries are dangerous, they notice very quickly that when their life is in danger, or when they have issues, or when they suffer, or when they express desires, they are not taken into consideration. They are sidelined. And there have been surrogate mothers that have said also to me that when they were in labor and their life was being threatened, nobody cared about what they were going through. So that's the other thing. Then also their desires being systematically sidelines. There are mothers who want to then keep the child, mothers who change their mind, mothers who are forced to have an abortion against their will because it's the desire of the commissioning parents or the agency that is involved in this. It can be a healthy child. Also, if it's not a healthy child, the point is the mother is forced to have an abortion against her will. And then you get also the subsequent ways of treatment of women that are then threatened if they insist on, for example, claiming the child, if they want to, if they even think of filing complaints because of the treatment, and they remain with this lifelong feeling of grief and loss. I was recently in Colombia and I spoke to a woman that was a surrogate mother 2 years before I actually met her. She could not stop crying throughout the entire interview. She feels that her life was hijacked from her. And this is a woman that has children. She felt cheated, she felt betrayed, but most of all, she felt utterly dehumanized and treated as cattle, if not worse. Thank you.
Thank you very much.
Thank you. Look, you've been very clear that your approach and recommendation is prohibitionist. There's been evidence, including published in the British Medical Journal, that prohibition doesn't make surrogacy safer. If anything, it further puts women and children at risk. Are you able to point us to any scientific or peer-reviewed evidence that a prohibition approach improves the well-being of either birthing parents or intended parents or children?
So I wish to correct, first of all, my position on this. I am not a prohibitionist, I'm an abolitionist. And while the two terms may look as if they are similar, they are in fact very different. Prohibiting is a policy choice that is very much focused on adopting a law that tries to criminalize an action. And this is not what abolition is. Just 1 second, I just want to find my notes on this. Abolishing is focused on addressing the underlying causes of a phenomena. And it does not criminalize every actor engaged, in this case, surrogacy. What I believe we have to address is the demand for surrogacy, because it is the demand that fuels and keeps this this phenomenon alive, and with it the exploitation and the violence that it brings. Keep in mind that I do not, for example, propose to punish or criminalize women engaged in surrogacy. On the contrary, as I say in my report, I consider them as victims, just like the way I consider women in prostitution as victims. What I'm proposing is that we have to criminalize the demand, because only through criminalizing the demand can we reduce the demand, and can we start to see really a human rights-centered approach to this. We have to criminalize the demand. We have to criminalize the work of agencies and intermediaries that benefit from the exploitation. and violence that surrogate women and children are subjected to. And all, because for me, they are equivalent of pimps. And frankly, anyone who benefits from this. There are tourist agencies who also add a nice little tourist package to surrogate arrangements. So anyone who benefits from it should also be criminalized. But the women, the surrogate women, I recognize that they are victims. I recognize that they only get engaged in surrogacy, and I'm speaking for really the overwhelming vast majority of them, like over, I think, 95% of women do it because they come from marginalized, impoverished backgrounds, because they need to make ends meet, often for other children that they have. And this is an option available to them. Many of them also come from countries affected by conflict. If I think of Ukraine, for example, they enter into a profound relationship of inequality and disequilibrium of power, where they also don't understand the contracts, they don't understand what they're getting into, they don't have sufficient information on the threats that
I'm
this
sorry to interrupt you.
for them.
You've spent a significant bit of time clarifying my question, and you're very welcome to correct if I've mischaracterized your position, but you haven't actually answered my question, which my question was about if you're able to point the committee to any scientific or peer-reviewed evidence that the approach that you're suggesting measurably improves the well-being of surrogates or of children, or both.
But you characterized my approach as being prohibitionist, and I'm clarifying that we would not find evidence on that, because that's not my approach. And yes, there is no evidence that what I'm proposing in terms of an abolitionist approach, that there's a country that has fully adopted an abolitionist approach. There are countries that are moving into the direction of prohibiting surrogacy or allowing some very, very, very exceptional situations. But we are still far from having really policies in general by states on surrogacy. And this is part of the problem, as I say in my report, that most countries are actually either silent on surrogacy or some of them allow it. Some of them allow for, as I said, this artificial distinction between altruistic and commercial surrogacy. But the vast majority of countries don't even have a policy, don't monitor its consequences, don't know how many countries come into their borders born through surrogacy, don't monitor what happens to surrogate children, don't know how many women are engaged in surrogacy or exploited in surrogacy, and even if they allow for altruistic surrogacy. So yes, we don't have that. And I've also said in my report that good studies in general on surrogacy, on all aspects of surrogacy and its consequences other than the strictly medical issue, are not available.
In your report, you called for ending surrogacy, but also reducing discrimination against children born from surrogacy. For
Correct.
us as a state legislature in Australia, to protect children born from surrogacy who are being raised in families here in New South Wales, that would require an approach that might be contrary to your other aims in terms of ending surrogacy. So I'm interested in how you navigate that. What solution would you propose that would both end surrogacy and reduce discrimination against children who are already born from surrogacy?
In my report, I actually say that we shouldn't discriminate against children born through surrogacy. First of all, they are children, and children's interests are always guided by their best interests. Children should not be punished for something that they should never be punished because they're children, but also they are victims. They are some of the most important groups of victims of this whole process. So they exist once again. They are born, they exist materially, and so we have to adopt measures in order to minimize the harm that they may be exposed to and other violations. So I talk about the fact that we have to ensure that they do not end up stateless. I talk about the fact that we have to also put them into care arrangements that, first of all, are vetted, that respect their rights, that provide them with the dignity and all other rights that they are entitled to. And then that they may be adopted out at some point, if that's in their best interest. And the adopting parent could be the partner of the persons who commissioned the child. But we will have to then go through it, go through the process. We have to see if the parents, if the persons who commissioned the children are really have the right profile to do that. So I don't think the two things are contradictory. Also, when I say of criminalizing the buying of surrogacy, just like with prostitution, it does not mean necessarily only a prison sentence. It could mean a fine, it could mean a criminal record, it could mean ensuring that they do social work. There has to be some kind of consequence, but I don't see the two things as exclusionary.
I'm out of time.
Thank you. And thank you, Special Rapporteur. It's Greg Donnelly here. Just a few questions. I'm just conscious of the time we've got. The general proposition that's been put to us thus far, and we're only at our first day of hearing, and we've got more to come, from those proposing to amend the legislation in Australia to legalise commercial surrogacy, or a lighter touch might be to liberalise existing altruistic surrogacy laws that currently have provisions within them that are seen as restrictive, is this, that the advocates for the reform say that what we effectively need is stronger, better regulation. That, in other words, the issues that are coming forth and being exposed or being shown to be occurring are the result of a failure of regulation. And that is either law, that's sort of black letter law, or regulation that is overseen by legislatures. And that if we could only get these laws and regulations in better shape, that the problems that are being raised with respect to surrogacy in its altruistic or commercial form will effectively disappear. They will no longer exist. I'm wondering if you'd care to respond to that general proposition.
So what you're saying is an argument that has been often made, and it just doesn't withhold evidence. We have seen some of the worst cases of exploiting women in surrogacy and children in surrogacy in countries that allow altruistic surrogacy only. Also because what they effectively do is that they just allow to displace the harm to other places. Because take a country, for example, take California, which allows only altruistic surrogacy, if I'm not mistaken. What happens is, because that's the extent of its legislation, most persons interested in procuring a child will go outside of that state and will go to other places, and then will bring back the child. The other thing is, we have seen situations where women have been kept in slavery-like situations, in bondage situations, and I'm happy to give you examples after, where in countries that allowed for altruistic surrogacy. So again, going along with this artificial distinction, it's just not going to cut it. And as I said, it's artificial. So in fact, it is a commercial form of surrogacy. And if you were to ban all forms of surrogacy. If you were to consider altruistic, if you were not to pay women engaged in surrogacy for carrying the child, and by the way, it's only at most a fraction, 10% or less even of what is paid to the agency or what is paid for the process that the woman gets. But if you were to get rid of even the payment aspect, hardly any woman or girl would engage in surrogacy, because we have to acknowledge why they are doing it. It's because they are systematically discriminated against, come from marginalized and vulnerable backgrounds. And this is an exploitative system that therefore takes advantage of this.
Just got one final question because I think my time is nearly near. That with respect to altruistic surrogacy arrangements and commercial surrogacy arrangements, what strikes me is that there appears to be virtually no consideration. In fact, I'd be prepared to say I've not seen any agreement or arrangement, not that they're easy to locate and find, but no consideration about what happens to the woman who's the surrogate after the birth of the child, and to sort of use the colloquial phrase, the handing over the child to the commissioning parent or parents. And it strikes me that there could be a range of matters and a range of effects potentially across a number of domains for a woman who has acted as a surrogate that follow what could be immediately, in the immediate term, the sort of longer term impact of entering into this arrangement. But the contracts just seem to bring the guillotine down, if I could sort of use that phrase, at the point of handing over the baby, and no consideration for the woman for whatever may happen after that. And I'm thinking about physical injury that might occur in terms of surgery or other procedures, and psychosocial and social impacts that might, in fact, a bit like post-traumatic syndrome, we know takes a period of years to manifest. Would you like to comment on that?
I'm sorry, I didn't understand the question or what you would like me specifically to comment on. My apologies.
No. I'm just wondering that a number of agreements that I've seen in looking around, both altruistic and commercial, seem to provide little to the commissioning, to the surrogate woman after the birth and the handing over of the child, and what could be longer term impacts on her after the birth.
Yes.
It could be medical, it could be psychosocial, it could be social. There's just no consideration for any of that in these arrangements. It just strikes to me a very strange way of having a contract where you don't have any consideration for what could be the impact of entering into an arrangement.
Yes, because the objective of the contract, as I said, is to seize control by the mother in favor of the commissioning parents and the agency. So they are kings. They are absolutely in charge and completely. They make all the decisions about everything, including whether they want to abandon the child, as I said, abort the child, what the woman should eat. But I want to say one important thing that I haven't mentioned, because I think we have to be very clear that international law views surrogacy as trafficking. And trafficking is a crime. Trafficking also of children is a crime. Because under Article 35 of the Convention of the Right of the Child, as well as the optional protocol on the sale of children, child prostitution and child pornography, the sale of children is explicitly prohibited. And in the protocol to prevent, suppress, and punish trafficking in persons, especially women and children, that supplements the Convention Against Transnational Organized Crime. There is no requirement even to prove that exploitation has happened as a separate element. So instead, the transfer of the child for payment constitutes a serious harm and human rights violation in and itself. And by the way, the European Parliament has had a resolution where it also defines surrogacy as trafficking. So yeah.
Thank you very much.
Thank you. Well, Mrs. Al-Salam, that concludes our time with you today, but thank you so much for making yourself available to the committee and answering questions. There may be some supplementary questions that committee members have following today, and the Secretariat will be in touch with you if there are any directed to you, but thank you for appearing for us this afternoon.
Thank you. Thank you very much.
Thank you.
Thank you.
Okay, that concludes today's hearing, so thank you.